Mas few words and introduce Akila. Then Akila will take over.
Yeah, fine. Kishore, we can go live, Kishore.
Yes, sir. Yeah,
all of you be ready for a picture.
Recording in progress.
We are live now. We can start.
Good morning, ladies and gentlemen. We welcome you to the OGSSICON 2020, the 37th annual conference of the Team 2020, which we were supposed to have held last year, but unfortunately due to the COVID pandemic, we were not able to do it. We thought we'll open up and we will do it this year, but we are still unfortunate that we're not able to meet all of you in person. But then we have a lot of advantages of having been conducting the conference in the web. And without wasting much time, let me just welcome all of you for this wonderful sessions today, which is going to be happening from morning till evening, maybe around 5 o'clock with the inauguration at 4:15 and a lot of important events in the middle. I'm sure you will be familiar with the brochure which has been sent all across the country, and I'm sure you'll be able to see that. So I welcome you all. Without wasting time, let me just introduce the coordinator for the day, Dr. Akila. Slide, Kishore. And the whole day sponsors are Sun Pharma, Inca, Senora, and Spectra, who've been very kind enough to give the technical support and much more than that. And thank you very much, Sun Pharma, for sponsoring the entire 3 days program. Slide. I'm very happy to introduce Dr. Akila Ayyappan, who will be the coordinator for the entire morning session, who's a medical officer, Greater Chennai Corporation. And she's been very humble in giving only one line of curriculum vitae, but then she's been a very active member of OGSI and been inducted into the executive committee of OGSI this year. And she's been very, very involved in the works of OGSI and committee and at this conference, playing a very vital role. Over to you, Akila, for the proceedings of the conference.
Good morning to all. Thank you, sir, for the kind introduction. And thank you very much for giving me this opportunity to be as a coordinator for this OGSSICON 2020. I'd like to introduce the chairperson for the first session. Slide, please. It gives me immense pleasure to introduce Dr. Cynthia Alexander. She's a pro-life activist and member in CASCA and a resource person for family life, education of school, college, and premarital classes. She has put in more than 35 years of government service, served various institutions, retired as a director of Institute of Obstetrics and Gynecology, Chennai, Egmore. Madam is a Lifetime Achievement Awardee of Tamil Nadu, MGR University, and a recipient of A.L. Mudalia Traveling Fellowship Award. Next slide, please. Dr. Chitra, Madam is a professor and a unit chief in PSG Institute of Medical Sciences, Coimbatore, Tamil Nadu. Has a rich experience in teaching and is an award winner of teaching excellence. To add to her credit, she has a number of achievements as organizing secretary of many conferences and CMEs, publications in national and international indexes. She's always been a favorite invitee for many national and international conferences. At present, she is a president in Powai Oxy and Gynec Society. A special interest is urogynecology and high-risk pregnancy. Next slide, please. Dr. Premalata, Madam is head of the department, Tagore Medical College and Hospital. She's retired as a professor and project coordinator in from Madras Medical College and Hospital. A special interest is adolescent and high-risk obstetrics. She has served in the service for more than 35 years and a rich teaching experience of more than 35 years. Over to you, Madam, Dr. Premalata, to introduce the postgraduate.
Good morning. I welcome all to the first session of the OGSSICON 2020. First, I thank the organizer for giving me opportunity to chair along with great people like Dr. Cynthia Madam and Dr. Citra. So we will start with the youngest person, the young obstetrician. Labor mostly is conducted in lithotomy position or lying in position, but other position has been adopted by many other people. So Dr. P. Madhura, third year PG in the Institute of Obstetric Gynecology, will be discussing about the various positions and advantages of various positions during labor. Over to you, Madhura.
Okay, ma'am. Hello, ma'am.
Hello.
Okay, ma'am. Good morning to everyone. I thank Oxy and our director ma'am and assistant professors who gave me this chance to present this in this conference.
Yes, ma'am.
And ma'am screen.
While
Yeah,
your
it's coming,
screen
it's
is
coming.
being
It is
shared,
coming. It is coming.
let me tell that the idea of introducing this PGs, I'm sure we've all been doing this as capsules, and now we've changed the name to sprouts for the very simple reason they're all sprouting obstetricians, and that's the reason why we have sprouts, which is quite healthy, easy to digest, and of course lovely. And we're going to have the first sprout from Dr. Mathura from IOG. Over to you, Mathura.
Okay, sir. Next slide, sir. Okay, introduction. Here, the birth of a child is one of the most significant events in a woman's life, and practices associated with the birthing process are therefore important to the well-being of, as well as the successful outcome of the pregnancy. And included among these practices is the birthing position, which has the great deal of controversy always. And next slide, sir. And why we need to know about the positions, different positions, is because there are many benefits of proper positioning, like increased comfort, reduced pain, an enhanced sense of control and involvement in the birth, more effective contractions, better progression of labor, and baby is more likely to descend in an optimal position, better blood and oxygen supply to baby. Next slide, sir. And here, this slide depicts the evolution of birthing position. Here, in the ancient time itself, kneeling down position was the one used, and also surveys have shown that a lying down position has never been the norms in the traditional cultures. Next slide, sir. Here, these are the other pictures of sculptures which also depicts the birthing position that was practiced in ancient times. And next slide, sir. And this shows the evolution of the birthing stools and chairs here, which has dated back to Babylonian times. Now the evolution of birthing stools and labor board has been changed, and depending upon many other factors. Now here, this is the birthing chair that was used in ancient times, and here this is the new modern labor board. Here the birthing ball is used, and this birthing stool is used in the water birth, and the labor board, the position can be altered according to the labor stage of the labor accordingly. And next slide, sir. And here, this is this shows various positions that can be used accordingly in the labor board. Next slide, sir. And there are many choices for alternative birth positions, and the alternative birth positions include standing, on hands and knees or leaning forward, squatting position, sitting position, lying on side position. Next slide, sir. And in spite of many alternative positions that we all know, there are barriers to follow this alternative position, is because ease of interventions like usage of instrumentations and pervasive cultural image of the birth, healthcare provider comfort and convenience, healthcare provider training, and physical structures of labor delivery room, that is overcrowded and less space, availability of less space. Next slide, sir. And here, there are many risks and benefits of positions women choose in labor and birth. In women who assumed a non-supine position for birth, they had very fewer perineal injuries, less vulvar edema, and less blood loss. And in women who chose non-supine position for birth, had shorter second stages, and they required less pain relief and medication, and they had fewer abnormal fetal heart rates. Next slide, sir. And this is the study that was updated in June 2009. Here, the results of the study was the use of any upright or slide lying position compared with lying on your back with legs in stirrups or associated with the following benefits. Like it shortens the second stage of labor, and the small decrease in use of instrumentations, fewer episiotomies, lesser chance of experiencing severe pains, fewer abnormal heart racing, and small increased second degree tears. Next, sir. Next slide, sir. And the same study was updated on 2017. Here also, it review assessed the possible benefits and risks to the mother and baby by giving birth in upright position compared with supine position, and also looked at some individuals who use upright positions for benefits and harms. In the findings of this review suggest that several possible benefits of upright posture, such as it lessens the duration of second stage of labor, reduction in episiotomies, and assisted deliveries. However, there is an increased risk of blood loss greater than 500 ml, and there may be increased second degree tears in an upright postures. Next slide, sir. Sir. Next slide, please, sir. And we can discuss about different positions now. First, supine position. Here, the supine position, the woman lies flat on her back with her trunk slightly raised, and her legs may be out straight, bent with her feet flat on the bed in the leg rest, or it can be drawn up and back towards her shoulders. Next, sir. And this is a study that was a meta-analytic review that was made 2004, where the supine position is compared with other positions during the second stage of labor. And the results are the supine position, other positions was associated with increased rate of instrumental deliveries, and increase in episiotomies and second degree tears or more in supine position when compared with other positions. And also more mothers complaints of pain and unpleasant experience in supine positions when compared to the in other non-supine positions. And also more women had difficulty in bearing down in supine position, and most of them chose non-supine position when they asked in which position they would like to give birth for the next time. And next slide, sir. The advantages of the supine position is that it has easier access to the perineum for obstetrical intervention, and it also enables the obstetrician or nurse to listen the fetal heart at frequent intervals, and it will be more comfortable for the person conducting delivery, and maintenance of asepsis is easier. And disadvantage is that increased need for forceps or vacuum, excessive head molding, compression of the umbilical cord, and stress on baby, disruption of baby's oxygen supply, and poor position and angle of the fetus in relation to the pelvis. Next, sir. And this squatting position. In the squatting position, a woman's weight rests mainly on her feet, but her knees are markedly bent, and she may lean or pull on some support. And the squatting position is often regarded as the natural position because it is very similar to the habitual resting position. However, a major disadvantage of the squatting position is the difficulty for the pregnant women to maintain the squatting for a long time. Next slide, sir. And the advantages of squatting position is that it decreases the amount of time, that is, it shortens the second stage of labor and shortens the depth of birth canal, and increases the pelvic diameter by 10%, and it lessens the use of episiotomy to aid in the labor due to relaxing and stretching of pelvic floor muscles, and it uses the gravity to assist with birthing process. And the disadvantage is that use of this position is exhausting to mother and difficulty in fetal heart rate monitoring, and it also impairs the mother's ability to assist in delivery. Next, sir. Here it depicts the standing postures. Next slide, sir. In this position, the advantages is that it allows to remain in the upright posture, and it increases the diameter of the pelvis by 1 centimeter due to downward pressure on the maternal pelvis, and baby is in line with the angle of pelvis, and it takes advantage of gravity during and in between the contractions. And standing may also increase the urge to push in the second stage of labor. And disadvantage is that it is the most uncomfortable posture for the person who is conducting delivery. Next, sir. And sitting posture, it includes semi-sitting and sitting upright. In semi-sitting posture, the woman sits with her trunk at an angle greater than 45 degrees to the bed. And in sitting upright position, the woman sits straight up on a bed, chair or stool. Based on several published studies, it seems that sitting postures are comparatively more popular in some Western developed countries than in Asian countries. Next slide, sir. And it is a good position for resting. It has more gravity advantage than lying down, and fetal heart monitoring can be done, and it shortens the duration of second stage of labor, and uterine pressure and expulsive force is more when compared to the supine posture. Next. And here comes the lithotomy position. Here the women's legs are neither bent with their feet flat on the this one, or placed in stirrups, straight leg support, or by birth attendants. Next slide, sir. Here, the advantages of the lithotomy position is that it allows the easiest access to the mother to give episiotomy, and usage of instrumentations like forceps or vacuum is easier. And disadvantage is that it narrows the pelvic outlet, and it also places the pressure on the tailbone of the mother, and it places undue stress and increasing the risk of tears, and it works against gravity, and it also increases the second stage of the labor. Next stage, sir. Kneeling position, it may vary from upright kneeling to all four positions. Generally, all four also called as hands on knee position. In this position, the woman kneels and leans forward and supports herself on either the palms of her hands or her fist. Next, sir. And here the advantages is that it relieves the backache, and the position is also assists rotation of the baby in the posterior position. Next slide, sir. And this left lateral position, which is also called a slide lying position. Here in the side lying position, the woman lies with both hips and knees flexed and pillows in between her legs with her upper legs supported. Next, sir. Here the advantages is that there will be a greater control of the fetal head during birth and greater relaxation and less tension of the perineal muscles, fewer perineal lacerations and decreased need for episiotomy, a familiar and comfortable position for the women which is conducive between contractions, and perineum is constantly under observation and accessible during delivery, and it is easily assumed adaptable position for delivery. And the next slide, sir. The disadvantage is that large episiotomy is difficult to cut and it is unsuitable for applications of instruments, and the women may need help with positioning, and complications of third stage are difficult to manage. Next.
Mathura, your time is almost done, Mathura.
Okay, sir. Okay, sir. In the squatting position, the sacrum is free and it moves back to widen the pelvic outlet. But in the semi-sitting position and semi-reclining position, the sacrum will be immobile and the pelvic outlet will be narrowed. Next slide, sir. Here, because other advantages is that the birthing positions are used in treating other obstetric complications. Like in all four positions, it is regarded as a possible method in resolving shoulder dystocia. The ACOG suggested that the Gaskin maneuvers may be useful in relieving the shoulder dystocia. Apart from shoulder dystocia, several studies investigated the effects of maternal positions on facilitating spontaneous fetal rotation to occiput anterior position. For example, the lateral position may serve as a non-medical intervention to enhance the rotation of an occipital posterior fetus. Next slide. And here there was a review and comparison of the maternal positions during the second stage of labor. Here also, the study also depicts that the upright positions have more benefits in facilitating the labor progress than the horizontal position. Particularly the squatting position, which is commonly used every day, is effective in shortening the second stage of labor. An observational study found that the duration of the second stage of labor decreased by 9 minutes in both primiparas and multiparas in squatting position when compared with supine position. Next, sir. And here, there was a study that used MR obstetric pelvimetry to study the effect of birthing position on pelvic bony dimensions. Here, the aim of the study was to measure the impact of supine and upright positions on MR pelvimetric dimensions. And the results indicated that the difference in postures can significantly increase the female pelvic dimension and thus provide confirmation for the Hornard parturient experience and advantages of changing the birthing position to facilitate the vaginal birth. That is, the sagittal outlet and interspinous diameter was significantly higher in hand to knee and squatting position than in supine position. Next slide, sir. And here, this recently, the water birth, here also we can assume different positions in underwater during labor. Example, squatting, kneeling, leaning forwards onto the side of pool, resting on side with head on a pillow on the side of pool, and floating on back with floating on tummy. And if the birth partner is in the pool, sitting with back against him. These are the different positions that can be assumed during labor underwater. Next slide, sir. And finally, this is a recent journal that was published in our Tamil Nadu, Chennai. It was published in International Journal of Clinical Obstetrics and Gynecology. Here, they studied the prospective study of different postures during the second stage of labor and their outcome. And the results were duration of the second stage is very much reduced in squatting position than sitting position than supine posture.
Madhura, your time is over. Please.
Okay, ma'am. Okay, ma'am.
Next slide.
Okay, ma'am. The last slide, ma'am.
Okay.
Can I present, ma'am?
Yes, just finish up in quickly.
Okay, ma'am. 1 minute and 5 minute upcar is better in squatting position than in sitting posture. And third degree other tears are also less in squatting sitting position than knee elbow position. Maternal satisfaction is also more in non-conventional postures. And overall satisfaction was found better in squatting position than sitting knee elbow position in decreasing order. And finally, to conclude, last slide, sir. Last slide, sir. And to conclude, the choice of labor and birth positions encourages a woman's sense of control and reduces need for analgesia. And it has also a respect for choice was recently endorsed by WHO within the quality of care framework. And we have to help women understand that they can use alternative position and feel free to be mobile and try different positions during labor and birth. And we need to be able to gain experience in assisting labors, births in non-supine positions, and so that we can provide the care that is evidence-based and shown to be beneficial, including birth in alternative position. Thank you, sir. Thank you, ma'am. Thank you, everyone.
Thank you, Madhura. That has been very nice discussion about the different position. By preference is non-spine, isn't it? That is the take-home message.
Yes.
But convenient for the obstetrician is the
Supine
position and laparotomy position. Thank you, Madhura.
Thank you. Thank you.
Over to you, Dr. Chitra.
Okay, very good morning. And at the outset, let me thank Dr. Palniyappan and the OGSSICON team for having given me this opportunity. And congratulations for a very wonderful conference and for this new initiative, Sprouts. Now, we move on to the next topic, which is online access to abortion services, Hype or Hope by Dr. Geeta Lakshmi. It gives me great pleasure to introduce Dr. Geeta Lakshmi. She is a registered and senior consultant in the Department of Obstetrics KGH Hospital. She graduated from MMC. She's an undergraduate and a postgraduate teacher from 2000 onwards. And her special interest is in high-risk pregnancy, adolescent health problem, which is very rare. Many people do not take up this at all. And MET. And I've seen Dr. Geeta Lakshmi being very active in many PG teaching programs, many conferences and workshops. And she's had an award, original research paper in the GDM, Gestation Glucose Intolerance, which is published in the World Journal of Advanced Healthcare Service Research in January 2021. She's trained in laparoscopy and colposcopy. Now, just a few words about this services. In fact, they say 15 million abortions occur all over in India per year. And surprisingly, because of COVID, many people, thanks to working from home, have got pregnant, either infertility or unwanted pregnancy. So when limited access to medical services was there, especially during the lockdown, it is very important that the people have some way of which they could approach the people for medical services. And I'm sure Dr. Geeta will enlighten us. There's much about this in Western countries, but in our country, especially with so much of networking being possible, I'm sure Dr. Geeta Lakshmi will throw some light about what is happening in our country. Over to Dr. Geeta Lakshmi.
A very good morning to everybody. Thank you, Chitra Madam, for the kind words. And I'll share my screen and I'll go on to my topic. The topic given to me was online access to abortion.
Just slideshow, Geeta.
Is it a hope or a hype? So when the president...
Geeta Lakshmi Madam, go to slideshow. Yeah.
Slideshow, yes.
You can continue, Madam.
Yes. Yes. Is it okay? So when this topic was given to me by the President, Dr. Palniyappan, I asked him, sir, should I talk about? He said, Dr. Geeta, it is not a debate, hope and hope. So the incidence of abortion and unintended pregnancy in India.
Geeta Lakshmi Madam, there's some connectivity issue. We are unable to hear you.
15.6 million abortions. Overall, one second. Now am I connected?
Yes.
Vijay, am I connected?
Yes, now we can hear you.
Yeah. So the incidence of abortion and unintended pregnancy also as of 2015 is estimated to be 15.6 million abortions. Overall, 12.7 million abortions were medication abortions and 2.2 million abortions were surgical and 0.8 million abortions.
Madam, your voice is broken. You stop your video and present, ma'am.
Okay.
Stop your video and then present.
Okay. So, are you able to hear me, Vijay, now?
Yes, yes,
Hello?
Geeta Lakshmi. Yes.
Yes, madam. So the overall 12.7 million abortions were medication abortions, 2.2 million abortions were surgical, and 0.8 million abortions were probably unsafe. They estimated a rate of 70.1 unintended pregnancies per 1,000 women who are aged between 15 and 49 years. 3.4 million abortions were obtained in health facilities. 11.5 million abortions were medication abortions done outside the health facility, and 0.8 million abortions were done outside the health facility using other methods other than medical abortion. So thanks to the coronavirus, as far as COVID-19 and abortion is concerned, the coronavirus lockdown prevented 1.85 million Indian women from getting an abortion. In the first 3 months of the COVID-19 lockdown, that is from the March 25th to June 24th, the estimated about 3.9 million abortions that would have likely taken place were possibly compromised. 1.85 million women could not terminate an unwanted pregnancy, and this was concluded by the IPAS Development Foundation of India as of May 2020. There are two burning problems. Of 1.85 million women, that is 80%, compromised abortions were due to lack of availability of the medical abortion. 370,000 abortions were compromised due to the reduced access to facilities. According to the RCOG, coronavirus infection and abortion care, the priority is given to abortion care since it is an essential part of the healthcare for women. Services must be maintained even where non-urgent or elective services are suspended. Abortion is time sensitive, and access to abortion care should be organized so that delays are minimized. It was the WHO, World Health Organization, who gave an obvious solution for this. WHO recommends minimizing facility visits and provider-client contact through the use of telemedicine for abortion to the full extent allowed by law. So, as far as India is concerned, where do we stand in telemedicine? The Indian Space Research Organization initiated telemedicine in India in 2001. It was not even clearly legal before the issuance of the 25th March 2020 telemedicine guidelines. A lack of a clear policy or legislation and a ruling of criminal negligence left the future of telemedicine uncertain in India until COVID-19 brought it into sharp focus. So in India, there are several platforms such as Hidden Pockets, Love Matters, Nurse Nisa, Ask Nivi, Women First Digital, and Haya provide information on the abortion legality, access, and referrals via online platforms and social media. Thus, models that provide information on how to access abortion in India already exist. So these were the hidden pockets and how to deal with an unwanted pregnancy. But the telemedicine practice guidelines for India, published on the 26th March 2020, do not specifically include abortion services, and the common consensus is that it is a missed opportunity for ensuring access to safe abortion during COVID-19 and expanding access post-pandemic. On one note, it is 3 steps forward and 2 steps back. The legislation of MPP for the first trimester abortion is 3 steps forward, but services in terms of practice and execution inculcated fear of litigation among the practitioners, which was a 2 steps back. The Indian legislation on abortion services, the MPP Act, through its journey from inception of 1971 to the Amendment Bill 2020, has seen the transformation in the focus of abortion law from a healthcare perspective to the women's rights perspective by extending the gestation age limit for abortion to 24 weeks, requiring only one physician opinion for abortion to 20 weeks, not restricting the services to only married women, but expanding the horizon to include all women in need. provision of abortion services by even mid-level and non-allopathic practitioners, improved emphasis on the privacy of the women undergoing abortion, the drug controller, that is DCGI, emphasizing the need for a prescription to procure MTP medication. So what does the existing data tell us? There was a study which was conducted by the British Pregnancy Advisory Service, which is a cross-sectional study, which dealt on the client satisfaction and experience of telemedicine and home use of misoprostol and misoprostol for abortion up to 10 weeks to gestation. A total of 1,333 clients participated. Respondents described home use of medication as straightforward, 75.8%, and most were very satisfied, 78.3%, or satisfied, 18.6% overall. Thus, if needed in the future, most would prefer consultation by phone, 74.3%, and home use of misoprostol and misoprostol, 77.3%. A self-reported outcome and adverse event after a medical abortion through online medicine was conducted in the Republic of Ireland and Northern Ireland. So the outcome of the abortion was reported by the women conducting a medical abortion through online telemedicine. So the outcome as far as the pregnancy was concerned, no longer pregnant, that is, when it was less than 9 weeks, the percentage was 99.5%. And the surgical intervention was only 7.3% when it was less than 9 weeks. And the successful medical abortion, that is no longer pregnant and no longer surgical intervention, was 92.2%. As far as the treatment of the adverse events reported by the women conducting the medical abortion through online telemedicine, the usage of antibiotics when it was less than 9 weeks, it was only 7%. And the usage of blood transfusion was 3%, and nil death was reported, and any adverse event was 10%. There was another study, the telemedicine for medical abortion, a systematic review, which was published in the BJOG, the International Journal of Obstetrics and Gynecology. It stated that if medical abortion via telemedicine is done for gestational age less than 10 weeks, the complete abortion rate is more than 90%, and the adverse events are negligible. So thus the catch. There are no studies focusing on the low-income countries with limited infrastructure and poor resource settings. The studies stated above do not mention the demographics of the user population with regards to literacy rate and economic capacity to own a mobile or internet facility. Thus, the validity of using these results to represent the Indian scenario is a long stretch. Now, we come on to our topic, online access to abortion services. Yes, it's a hope because telemedicine does have undisputed benefits even in poor resource settings, even more so in the resource limited settings as it increases utilization of the available manpower. That is because of satisfaction, safety and efficacy, and improved resource management. Satisfaction of the utilizers patient is evidently higher with telemedicine is mainly due to decreased travel time and cost, flexibility with the schedule and location, no need to lose daily wages, no need to burden others for the household responsibilities during the hospital visit. As far as safety and efficacy is concerned, studies through similar safety and efficacy profiles with telemedicine when compared to in-person provision. Improved resource utilization. In an attempt to reduce the COVID-19 exposure, we face the death of healthcare providers, provision, and communication difficulties, and telemedicine single-handedly solves the issue. It also provides opportunity for even the quarantine doctors to extend their services. Every side of a coin has another side, and it's a hype because the pitfalls include infrastructure, privacy and equality, and legislation. So is India equipped for telemedicine? In India is one of the biggest and rapidly growing markets for digital consumers with 560 million internet subscribers in 2019. And in 2019, more than 110,000 villages have been equipped with broadband connectivity. But only 36% of the overall population is acquainted with internet usage. Only 28% of the women use internet or mobile services in rural India, and telemedicine for abortion can leave behind those without reliable internet phone lines and or access to electricity or mobile phones, or those with low literacy. Equality and privacy is concerned. As far as India is concerned, men are more likely to own a phone than a woman. And furthermore, those experiencing intimate partner violence or reproductive coercion may seek additional confidentiality in their process, and this could be challenging. Telehealth could also create an additional barrier to minors accessing abortion care. Legal reporting requirements may delay, complicate the care they need, and the fear of the digital records being misused and leaked is also a concern. As far as law is concerned, some pharmacists also do not stock abortion pills due to misinformation about the legality or the beliefs that they are harmful to users. So this law and policy should provide the medical abortion it should be suitably trained by the community health workers, the ASHAs and the ANMs. So the MPP Act and the DCGI guidelines and comprehensive health workers, the comprehensive abortion care guidelines should be updated to permit the provision of abortion through prescriptions generated by after the teleconsultation with the RMP. The telemedicine guidelines should be updated to explicitly include a medical abortion service. The problems we face are the confirmation of gestational age, usage of ultrasound to rule out an ectopic, consent, emergency service access in instance of adverse events, and incomplete abortion. When it occurs, it needs a surgical intervention. So how to strike a balance? The list of RMPs should be...
Madam, your time is up, madam. Kindly wind up.
Network problem, just give me 2
Yes,
minutes.
madam. Thank you, madam. Thank you.
RMP is willing to provide remote care can be collated. Abortion seekers could reach out to hotlines and online platforms to the nearest provider. The RMP could be located physically in a clinic or taking the call virtually. The eligibility assessment could include pregnancy confirmation, dating, and ruling out the risk factors for ectopic gestation. Eligible clients can then procure the medications from a nearby local pharmacy or e-pharmacy as outlined in the telemedicine practice guidelines. So hotlines and online services could also provide further information on the side effects, possible complications, provide support during abortion process, and carry out the follow-up assessment. If clients require additional clinical support, they could help direct them to the nearest facility care, and proper data and documentation of the services should be maintained. So to conclude, the future prospects for telemedicine in abortion services is that it is a viable choice even when quality services are available, since it would reduce the burden on the health infrastructure by reducing in-person visits. By expanding telemedicine to include medical abortion, India can forge the way ahead for safe abortion access, not just during the pandemic, but also creating an opportunity for a long-lasting impact. I thank the organizers for the opportunity. Thank you so much.
Thank you, madam.
Thank you, Dr. Geeta, for this wonderful presentation. In fact, you so nicely brought out what are the advantages and disadvantages. Advantages being very good satisfaction and very efficient, because more than 90% of all people would abort with medical abortions. But yet, unless we have certain guidelines which are being formed for the government, it is very difficult in this country to practice, because many people might misuse it. So it's very, very important. And since it's so efficient, it's important that the government gives us certain guidelines. Thank you so much. And we'll move on to the next topic. Dr. Akila?
Yes, madam.
Yeah, you can take over.
I call upon Dr. Cynthia. Madam, Dr. Cynthia Alexander, madam, to deliver the keynote address.
So on this pleasant morning, across oceans and continents, we are honored to have with us Dr. Ananth Karumanchi to deliver the keynote address. A few marks of introduction. He is the director of the Renovascular Research and Medallion Professor, Cedar Sinai Medical Center, Los Angeles, California. He is a visiting professor at the Harvard Medical School, Boston, passed out in 1992 from KMC. And as a former faculty of KMC, I consider him a jewel in the crown who has added pride and prestige to the Kilpatrick Medical College. He was trained at Detroit, and he is a fellowship in nephrology at the Beth Israel Medical Center, Boston. He is a pioneer in the research in angiogenesis and finding of therapies in hypertensive disorders of pregnancy. Has published more than 300 papers and was awarded many awards, mainly the American Heart Association Award, International Society of Study for HIP, and Chesley Award. Over to you, Dr. Anand. We are proud of you.
Above all, people who do not know what is happening, Anant is my classmate. We went to the same medical school, same class, and we were together for 5.5 years. And happy to have you here, Anant. And I'm very happy that you easily accepted the invitation, and we are honored to have you here, Anant.
So another jewel.
Yes, could you see my screen?
Yes, Anant, very clear. Yeah, okay. Go on.
Well, thank you. It's truly a privilege for me to present here, particularly to be invited by my close friend, colleague at medical school, Professor Palaniappan. So I'm going to be talking to you. This is going to be more of a science talk, more like a futuristic talk. This is preeclampsia is a very descriptive disease, and not much has changed in 50 years other than sort of identifying the disease and delivering. The question is, could you use modern tools to really understand, what's the biology of the disease and how can we use these tools to develop new therapies? And so the question I had, let me see if the slide's not moving. Hang on 1 second.
No, you just click on the slide, it will move, sir.
Okay, so the question that I had about 15 years ago, 20 years ago, when we discovered this pathway as so what's a nephrologist, doing here in an obstetric disease? So it turns out that I was quite intrigued because this is a disease, sort of an unsolved disease, where the patients typically present with high blood pressure and proteinuria. And I was interested in asking, what are the molecules that the placenta may produce that in turn causes the systemic maternal disease? And many of you have seen patients who present with HELLP syndrome or eclampsia, quite bad. And the question is, just like diabetes, we once, Banting and Best discovered insulin. We understood exactly how to manage diabetes. You can, lower the sugar by giving back insulin. The idea is the same idea. Could you find specifically molecules and pathways by which the placenta, leads to a systemic, maternal disease? And a major protein that we found is both sufficient and necessary for the disease is this one protein called soluble FLT1 that regulates angiogenesis. And I'm going to tell you a bit about how this molecule is both necessary and sufficient, for preeclampsia. So just to give you an idea, what is angiogenesis? Angiogenesis is a process of new blood vessel growth from pre-existing blood vessels. This is a picture taken from a tumor. A tumor, in this case, secretes a angiogenic protein called vascular endothelial growth factor, and this protein acts on blood vessels, and these blood vessels, feed the tumor. This allows the tumors to grow and metastasize. So a lot of this work happened in the 80s, and we now have drugs that block anti-VEGF. Some of the gynecologists here would know in patients with ovarian cancer, you'd use a drug called Avastin that essentially blocks this VEGF pathway by which you shrink the tumor. But important to know that while angiogenesis has largely been linked in cancer, there's physiological angiogenesis happening every day in wound healing. And in fact, originally, the discovery of angiogenesis was first described in the rhesus monkey placentas. And so the question is, is preeclampsia a disease of abnormal angiogenesis? And really what I'm going to propose to you is that a hypothesis that in preeclampsia, the placenta is not as vascular. If you think about it, its placenta is really a bag of blood vessels. And essentially there's exchange of oxygen and nutrients happening between mother and the fetus. And we think when the placenta doesn't form very well because of lack of this angiogenesis, you essentially can cause preeclampsia. So what is this protein soluble FLT1? So it turns out that growth factors the placenta makes comes in several flavors. The one called placental growth factor, the other one called vascular endothelial growth factors. These growth factors bind on endothelial cells on cell surface receptors. So just like you have an accelerator to accelerate the car, when the placenta is growing to keep up the demands of the baby, you need these growth factors to act on these endothelial cells, and you make more blood vessels, and that's how the placenta grows. And the way you stop the growth toward the end of pregnancy is you actually need to have a break. And so the way the placenta, makes this break is it actually secretes a soluble version of this protein, so that doesn't attach to cell surface. Essentially, now you have a soluble version of the protein that can bind these growth factors and essentially create it mops up these growth factors and creates a deficiency. So this is the way the placenta regulates, its angiogenesis. In contrast to tumor, which keeps growing on and on because you make a lot of these growth factors, but the placenta has this sort of very fine system where it regulates the process by regulating these growth factors and blocking it by making these endogenous inhibitors of these growth factors. So just to give you a picture of what I think goes on, these are the growth factors shown in these colored circles, and this is a blood vessel on which you have endothelial cells, these receptors that are situated. And so normally in pregnancy, to keep up with the demands of the baby, you have a lot of these growth factors, and to some extent towards the end of pregnancy, to regulate the process, you have a small amount of soluble receptor. And in preeclampsia, what we think is going on, you have a lot of soluble receptors that binds these growth factors, and now these vessels no longer see these growth factors, and blood vessels now are sick. And so these patients typically present with vasoconstriction, hypertension, and all of the sequelae of preeclampsia. And so where is this soluble fluid being made? So this is a histology of the placenta. You see a normal, staining around the syncytial trophoblast. That's the layer that faces the maternal blood. And in preeclampsia, you see these syncytial knots. These are degenerating cellular structures of the trophoblast, and that's where the highest expression is. Presumably, these are secreted in the maternal bloodstream and essentially can disrupt vascular endothelial function that leads to signs and symptoms of the disease. I won't go into the details of this, but the bottom line is that a fellow by name Sharon Maynard discovered this pathway in my laboratory many years ago. And what is shown here is that patients with mild preeclampsia and severe preeclampsia, they have a higher level of this protein in their plasma, and it goes away after delivery of the placenta. But in fact, if you measure the ligands, literally if you measure these growth factors, as you can see in this picture, that you have a higher level of the soluble receptor, but the free or unbound growth factors should be decreased. And that's what she was able to show, that free VEGF and free PLGF are significantly decreased. Why is this important? So this was the first real molecular signature of preeclampsia in a patient's blood. So analogous to heart attacks, when I was in training 20 years ago, heart attacks we diagnosed by chest pain or EKG changes. We now have a test for heart attack where you measure troponin, which is a biochemical marker in the plasma that's very sensitive for heart attack. We think it's the same analogy. In preeclampsia, you might diagnose it with hypertension and proteinuria, but in fact, the biochemical hallmark of preeclampsia and plasma is this particular ratio where you have high levels of the soluble growth factor called soluble FLT1 and low levels of this growth factor PLGF. And you can measure this. You can see a 50-fold elevated levels of these growth factors in severe preeclampsia compared to normal pregnancy. And it's not seen in other preterm labor, and you see a smaller elevation in patients with mild, disease. Now, it turns out that this particular pathway is not just an epiphenomenon. If you take a pregnant rat in this case, and if you were to give this protein, soluble FLT1, that disrupts blood vessel function, these animals get nephrotic range proteinuria, and these animals get severe hypertension. And this is a kidney biopsy of this animal, in this case, a pregnant rat. And I suspect the obstetricians here may not know how this looks like, but let me just clarify to you. This is the urinary space, and this is the glomerular capillary membrane. This is the electron micrographs. And what you see in eclampsia, patients with eclampsia, is that you normally have a swollen endothelial cells, total disruption of this barrier. That's why you get proteinuria. And what was quite remarkable to us is that we had found an animal in which we gave one single protein, essentially recapitulated the high blood pressure, the proteinuria, but also the classic histological lesions that is described in the textbooks of what constitutes, preeclampsia. And what is it that makes this protein important is that this is made for the most part only in the placenta and is delivered after the placenta is gone. And so essentially we think that this is sufficient proof that this might itself be sufficient to cause preeclampsia. In fact, a number of years ago, we worked with a biotech company that had an endogenous protein called vascular endothelial growth factor that would antagonize this molecule. And you could see in these animals, if you were to give this protein to these preeclamptic animals, the blood pressure and proteinuria, resolved. There was no changes to the fetal weights, and you could see that a lot of the histological lesions of the kidney, for example, got better. But most importantly, is this pathway. This is an endogenous angiogenesis inhibitor that's made by the placenta. We had tested a few patients in Boston. We've done a few animal experiments, but is this really relevant in preeclampsia? That's a worldwide problem. So it turns out, as I mentioned to you, many pharmaceutical companies have developed antibodies against against this pathway for the treatment of cancer-related angiogenesis. And many of those patients, if exposed to these drugs for long periods of time, we're getting essentially a preeclampsia-like phenotype. Even though they're not even pregnant, they would get hypertension, proteinuria, elevated liver enzymes, symptoms of seizures, due to edema in the back of the brain. And so this really convinced us that this endogenous, VEGF inhibitor made by the placenta was sufficient to induce the signs and symptoms of preeclampsia. So what is it somebody does? What does somebody do when you make a discovery like this? You found a protein made by the placenta that causes high blood pressure and proteinuria. So, to take a pathway and develop a drug into a human being, it takes 10 to 20 years, perhaps as much as $300, $400 million of investment has to go in. So the question is, how do we convince pharmaceutical companies that this is the most important pathway? So we have to do a lot of epidemiological studies. So we did, the classic epidemiological studies, for example, to show that there's a very strong dose response, meaning patients with eclampsia or preeclampsia complicated by severe growth restriction, they had the highest levels of these molecules. They had very, all the risk factors could be explained by this pathway. I'll just share with you one risk factor. So if you had a woman presenting with high blood pressure and proteinuria, less than 20 weeks of pregnancies, you're taught by the professors that think of moles. And so we were very intrigued by this analogy. And so mole is a tumor of the placenta. And these patients have 10 to 20-fold high levels of sFlt1. And that's what makes this molar pregnancies quite avascular. And you see a bag of, grapes out there, looking like structures. And so a number of publications here, people can look it up. Fundamentally, by studying all these risk factors, we will be able to explain that a single molecule made by the placenta is likely sufficient to cause a lot of the signs and symptoms of the disease. And so this is a classic paper that we published in the New England Journal of Medicine, looking at women with preeclampsia presenting less than 37 weeks and compared that to control pregnant patients, and really asking what happens at the time pre-delivery. And you can see, at the week preceding the delivery, you see an acute elevated levels of sFlt1 and lowering of PLGF, and you see this nice spike. So we think that this kind of spike is important for a clinical obstetrician, because if you knew that before clinical blood pressure and proteinuria, that this kind of pattern predicts preeclampsia, this could change the way antenatal medicine is practiced. You could refer these patients from the village or to a tertiary care center. Particularly if the women's at very preterm, they need to be delivered at a facility that has a NICU. So we think this is the first molecular test that might be useful for obstetrician to predict who is, might be getting this early, preeclampsia. We also think that this particular pathway could explain some of the genetics of preeclampsia. We know that women with preeclampsia sometimes has a family history of preeclampsia. And so this is a large study that was published in the United Kingdom, almost 500,000 PrEP patients. And when they looked at whole genome sequencing and looked to see what genetic variants determined preeclampsia, there was only one locus that associated with preeclampsia. That was in the fetal FLT1 gene, and that had a very, very high p-value of almost 10 to the minus 11. And this turns out regulates, the expression of soluble FLT in the placenta, which is a fetal tissue, but importantly, explains about 3 to 5% of preeclampsia. So at least in those forms of familial preeclampsia, you perhaps may have a genetic mutation or a polymorphism in this gene that explains why you get preeclampsia. So as a physician scientist, I was intrigued by this, and I thought, we had, essentially found a pathway that should be used by obstetricians. So how do you sort of change this field? So we had to develop a diagnostic test. And then at the moment, we're also very interested in seeing if you can take this pathway and develop a specific therapy for the disease. So this is a diagnostic test that we developed. We can measure soluble FLT and PLGF. This is a company called Roche that you can use this. It's 10 minutes. It's on automated platforms, and many of the European countries have it. I'm not sure if these tests are already there in India, but many of the in European countries and Japan, these tests are approved. So you can actually use this test today in the triage setting to rule out preeclampsia. So why is that important? So I'll tell you, as a clinician, as a nephrologist, I get consulted all the time for diabetic pregnancies or chronic kidney disease pregnancies where the proteinuria and blood pressure gets worse. And we can't tell if this is preeclampsia or if this is, a kidney disease. And so and many times the obstetricians don't want to be cautious, and they deliver these patients. So if you had a woman at 26 weeks with diabetes and blood pressure and proteinuria, and you delivered the woman, you're dealing with all these fetal complications. But if you knew that it was not real preeclampsia, that this pregnancy could be extended, you can see that the pregnancy outcomes could be better. So even in the absence of a therapy, having an accurate molecular test might allow obstetricians to may have a big impact, particularly in these patients who have, who have other mimics of preeclampsia. So this is a study that we did, many years ago, where we studied about 500 odd patients who presented with suspicion of preeclampsia, to the emergency room or the obstetrics triage unit. And what you can see, this is plotted on a log scale. You see a 10-fold increased elevation of soluble FLT compared to control pregnant patients. And likewise, the PLGF, which is the ligand for this receptor, 10-fold lower levels. And the test is, essentially measured as a ratio. And you can see a very nice, clean sort of separation. And in fact, if you, did an ROC curve, essentially you get a very, very good test. Yeah, you do have some patients who are preeclamptic who are called normal pregnancy, and some patients are normal who are called, preeclampsia. Why is that? In fact, when we went back and looked at these preeclamptic patients who are within the normal range, they all have adverse normal clinical outcomes. Perhaps they were misclassified as preeclampsia. And many of these patients who are, in the preeclamptic range, but are considered normal, many of them had very severe IUGR or placental abruption or sudden fetal death. So clearly these markers not just predict true preeclampsia, but predict preeclampsia related, adverse outcomes. So how is this test used today? So if you were delivering this patient, if you were an obstetrician and you were in Europe, how do they use it? It's primarily used as a rule-out test. So this is a large paper that was published in the New England Journal many years ago now. And so this was a 1,000 patient study where women presenting with preeclampsia, if you use this test, you have a negative predictive value of 99% over the subsequent week. So when a woman comes in with high blood pressure, proteinuria, if this test was low, your chance of not getting preeclampsia is more than 99% in the subsequent week. And up to a month, it's about 95%. So it's a very good rule-out test. And so today, a number of societies like the ISSHP, the FIGO, and a number of organizations are now incorporating these tests into the guidelines to clinically rule out preeclampsia. What about ruling in preeclampsia? What would you do? There's no treatments today other than just sort of watching them, giving them some magnesium, and perhaps delivering them. But this is how the field of heart attacks changed. If you can diagnose true heart attacks, you can take them to the cath lab, angioplasty them, and save them from getting a full-blown myocardial infarction. So the same idea, if you can identify patients who have severe preeclampsia before they get the full-blown disease, can you actually do something to them, at least interrupt this pathway? And so this is a study we did in Boston, where we looked at soluble FLT PLGF ratio. You can see compared with all women, and some of them presented with severe preeclampsia, you can see the women with severe preeclampsia have almost a 5 to 10-fold high levels of this ratio compared to the non-severe preeclampsia. We have positive predictive values of 60% and negative predictive values of 95% in this population. So we think not only is it a good rule-out test, but it's a rule-in test. And we think this is the first true sort of molecular test for preeclampsia that I think Indian obstetricians need to be aware. What is this is a little bit older slide, but people have done a lot of meta-analysis, and you could see in women with suspected preeclampsia, particularly we have early onset preeclampsia, their area under the curve is 0.98. The diagnostic odds ratio is almost 250. It's almost a slam dunk for diagnosis of preeclampsia. How does this look compared to the existing test? So today we do liver enzymes in the United States. If the woman comes in with preeclampsia, suspicion of preeclampsia, you're doing uric acid, liver enzymes, blood pressure, creatinine, proteinuria. This single test outperforms all of the clinical tests. So so if you look at even outperforms blood pressure in predicting preeclampsia-related adverse outcomes. These are abruption, sudden fetal death, severe fetal growth restriction, eclampsia, things like that. So you can see as a composite adverse outcomes in this paper, this test clearly outperforms all the existing tests. But to an obstetrician, what's the most important thing is, can I tell when a woman comes in with preeclampsia, when is she going to deliver? When is she going to get really sick that's going to deliver? And that's important because then you can time steroids. And more importantly, if it's going to be a preterm period, you may want to deliver, where there's a good NICU for the babies to survive. So this is a paper that we did with some obstetricians in Boston, where we looked at about 700 patients, and in women with suspicion of preeclampsia with a positive test, they all delivered within 3 to 4 days. Women with suspicion of preeclampsia with a negative test, their pregnancies lasted beyond 2 weeks or longer. So I think it's a very good, not only a diagnostic test, but also a good prognostic test, because it tells the obstetrician how sick this patient is going to be in the next week or so. So in the last sort of few minutes, I want to talk to you about, so what does this all mean? It's great to have a test, but if you're not really going to interrupt this pathway, who cares? It's like diagnosing diabetes with glucose. Who cares if the patient has diabetes, unless you have a therapy where you can give insulin or something like that to sort of lower the glucose. So we've been very intrigued by this. And so for the last decade or so, I've been working with a number of companies to try and develop specific treatments. And I'll show you a few snippets, a few things that we've done. One is, it's really hard to convince a pharmaceutical company to develop a drug for pregnancy, because of all possibilities of the drug crossing from the placenta into the fetus and all the litigations and lawsuits from anything bad that might happen in the United States. Companies are very afraid of developing new drugs. So one of the things we suggested since I'm a kidney doctor, we thought, instead of adding a drug, why not subtract it? If you have high levels of this protein, could you simply subtract it from the plasma? So this is an approach where we had a column, because of its biochemical properties, binds soluble fluid. This column is made out of dextran sulfate. It's a negatively charged column. It binds soluble fluid. And you can see, for whatever it's worth, in a single patient, this is a patient comes in with preterm preeclampsia. Every time you lower the S-fluid levels, the pregnancy keeps going almost a month or so, but you can see the proteinuria goes down and the blood pressure kind of stabilizes. And this is just looking at, a single treatment compared to control patients. You can see an extension of pregnancy by a week or so. This is still early. We're optimizing this, and this is really hard. Think about this. This requires almost a team of 10 people taking care of a patient. This is not something that you could do in a rural hospital. So I've been always thinking, how can we take this discovery and put it in the hands of doctors in the middle of Africa, in the middle of rural India? So a number of years ago, the Gates Foundation, approached me and said, we'll give you $1 million. Could you come up with something low cost, a simple treatment, like a vaccine? Can you come up that can be given one dose and, relatively cheap? And so we've been thinking about this. And, if you've heard about the COVID vaccine, one of the big success of COVID vaccine, certainly in the United States and many parts of the world, is this availability of this RNA vaccine. The idea is that instead of developing a protein or the actual virus to sort of make the vaccine, you can take the message, the software that determines the protein, and using that, you can make a vaccine much faster and with less side effects. And so this is the same sort of idea, because it's cheaper to make the message rather than make the actual protein. The idea is that you can actually interrupt that message, and this is called RNA interference. So this is a game-changing sort of way of thinking about how you develop new medicines. And the guy who discovered this pathway, won the Nobel Prize. A guy named Craig Mello and Andy Fire won the Nobel Prize in 2006 for this discovery that you can interrupt any genes by making a double-stranded RNA, like a Google search engine. It would go in and sort of essentially bind to a complementary gene and can essentially block the synthesis of this. So long story short, we knew that this was a fantastic pathway because it can be very cheap. It costs maybe $5 to $10 to make this, and it doesn't need to be protected in freezers. If this technology were to work, we could sort of cure preeclampsia around the world. And so the idea is, how do we do this? So the gene is made primarily in the placenta. So this is, it's not really expressed in other cells. So we don't think there would be many side effects. And it's made in multiple isoforms. I won't go into the details of the chemistry, but the bottom line is that we were able to work with some chemists at the University of Massachusetts to make a double-stranded RNA against soluble FLT1 and we attach a little cholesterol molecule to it. Since the placenta takes up cholesterol, this was a way for us to get the drug into the placenta. And roughly about 10% of the drug can get into the placenta. The nice thing is that you can give a single dose. You can take, if this were to work, it's a single dose. You come and take a woman with preeclampsia, have a positive test, give one dose. You can block the production of this protein from the placenta, and the woman hopefully will have a cure of the blood pressure and proteinuria. So hopefully she can, her pregnancies can be extended. So I'll show you a couple of very interesting experiments. This is a pregnant monkey with preeclampsia, where we tie off one of the uterine artery. So the placenta is ischemic. You give a single dose. You can see this is a control animal. This is a preeclamptic animal on the red side. You see a massive rise in soluble FLT levels. And these three animals that got a single dose, you see a nice reduction of the soluble FLT levels, with the single dose. And with the single dose, you could see these same animals compared to control patients. They have the preeclamptic animals of high blood pressure and proteinuria. You can see the single dose lowers the blood pressure and proteinuria. Again, it's a very small study, only 3 animals, but it's the first proof of concept that you can interrupt the cycle of preeclampsia with a very clear sort of a molecular, a drug. So let me just summarize what I shared with you. We think the placenta secretes this anti-angiogenic molecule called soluble FLT1 that acts by binding PLGF and VEGF. These are growth factors that are necessary for normal blood vessel formation. We think these molecules, low PLGF, high sFLT1, can be used to diagnose or predict preeclampsia, and we think interrupting this pathway may be of therapeutic benefit. The last few minutes, I wanted to talk to you a little bit about women's health beyond preeclampsia. We think, at least when I was in Keelpauk Medical College 25 years ago, we were taught that this disease is a disease restricted to pregnancy. Once the pregnancy is done, you're done. You don't have to worry about it because the placenta is gone. Not true. If you follow these patients long-term, they have significant cardiovascular disease. Let me tell you why that's important. If a woman were to smoke throughout her life, her chance of getting heart attacks and strokes is increased threefold. If you have very severe preterm preeclampsia, meaning if you have preeclampsia with growth-restricted babies presenting at, let's say, 32 weeks, your chance of getting a heart attack is 8-fold. So these mothers are getting severe heart attacks, strokes in their 40s and 50s. And why is that? This is an important sort of observation, and we need to identify these women after the delivery, make sure they get treated. We don't really know why they get this, but it's almost like, even though the hypertension, proteinuria gets better after the placenta is delivered, it's almost like the vasculature doesn't heal. They go on to get strokes, heart attacks, and a lot of the cardiovascular, including chronic kidney disease requiring dialysis. So I'll just show you a little bit of the data, why we think this is so intriguing. So we took, in this case, we took a pregnant mouse. We made it preeclamptic, and then we allowed it to recover. And after 2 months, the animals have normal blood pressure, virtually normal proteinuria. You can't tell compared to a control pregnant animal that this animal had preeclampsia, just like our patients. The patients, follow them a year later, you cannot tell. They look fine. You create an injury. In this case, you sort of damage their carotid artery and simply ask, how does it heal? This is quite cool. If you take an animal that had no preeclampsia and you injure the carotid artery, it regenerates the vessels quite nicely. But the same animal that had prior preeclampsia, you see this messed up vasculature, basically doesn't know how to heal. This blue color is a Masson trichrome stain. It's essentially a lot of fibrosis. So somehow the preeclampsia, leaves a scar in the vessels, and then they cannot sort of heal as well. And we don't know what the mechanism is. We think understanding this mechanism might allow us to sort of test a drug or a therapy in the postpartum period to prevent long-term, cardiovascular disease. So this is the paper that I wrote a number of years ago for the American Heart Association. We think that these patients with preeclampsia, even though they get better after pregnancy, there's a persistent vascular responsiveness to injury. And we think that this leads to long-term heart attacks, strokes, cardiovascular death. This is the first gender-specific risk factor. All the risk factors for heart attacks are cholesterol, diabetes, hypertension. That's gender neutral. This is the first risk factor that is specific for women. And so I think that there's going to be a lot of exciting studies that are going to come out that's going to talk about exactly the mechanisms. So let me stop here. And if there's any questions, I'm happy to take. Hopefully this would inspire many of you to think about this pathway. And hopefully, I think in the next 5-10 years, we are going to think about new therapies, for our patients. Thank you.
Cynthia, madam, you're muted.
Is this, Palaniappan, was this okay? I'm sorry.
That's perfectly fine, Anand. And I'm sure Dr. Cynthia is muted. She will come out. That was fantastic. And it was awesome. And this is what we wanted you to speak to the Indian population. And there are already questions, but before they take out the questions, let me ask you a question from Dr. Kurian. What happened to the VEGF treatment story still going on to lower the VEGF, the SFLT?
Yes. There are. So it turns out that VEGF, it's very difficult to dose the drug. It turns out that therapeutic index is quite narrow. And so it's very difficult to dose the drug. And so we have a better drug than VEGF. It's called PLGF, which is another cousin of VEGF. So recombinant placental growth factor is being now tested. So we're sort of, I would say, at a phase 1 stage right now. And so that has a bigger therapeutic window. It does the same basic thing. It binds to a soluble fluid and it lowers the blood pressure, proteinuria. It allows the placenta to grow. The nice thing about PLGF is that's what's made by the placenta endogenously, and that's depleted. So we think, that could be one sort of avenue for treatment. The problem with that is it's just like insulin or erythropoietin. It's going to cost a lot of money. So it's not a kind of therapy that's going to be useful for most women in India or out in Africa. I think that I'm more interested in this RNA therapy because I think that's going to be relatively cheap and easy to do. Just one sub-Q dose, it'll be like a vaccine. And I think that's probably has a better chance of having a bigger impact in the world.
Thank you, Anant. The next question is this test available in India? I don't think Anant will be able to answer that question. That test is still not available in India.
I know that in Bangalore, one of the doctors reached out to me, and she's using this test through some commercial lab. And I can't remember her name, but it may be available in some in private labs, possibly.
It's
perhaps
available on a research purpose, but it's still not available for the obstetricians to prescribe like blood sugar and whatever. So that is not possible. Anand, the next question which I wanted to ask, the questions are coming on the chat box, Anand. The question is, sometime back, the obstetricians claimed preeclampsia to be a disease of the placenta. And I thought the nephrologist would claim that it's a disease of the kidney, but I thought the cardiologist now, and even an obstetrician, I'm sure you know Dr. Baski Tilakanathan from UK.
Yes, very well, yes.
The disease is a disease of the heart and not a disease of the placenta. So what's your thought on that?
Yeah, it's a placenta disease. I think it's a placenta disease, and it's just of course, you need the mother. The susceptibility of the mother would make the disease more or less manifest. So if you have a strong mother, with no risk factors, you need very, very sick placenta to create the disease. But if a mom was, let's say, had chronic risk factors, like if the mother had chronic hypertension or heart disease, even a mild placenta disease can make her very sick. So the mom is really, in my opinion, it's more a susceptibility factor, but the primary cause of preeclampsia is the placenta. The placenta is poorly formed, it's sick. We know as obstetricians, most patients get better after delivery of the placenta. Within 48, 72 hours, the blood pressure gets better. Maybe within 3-4 weeks, the proteinuria gets better. And many experimental models, I won't go into the details, would suggest that placenta is the trigger for preeclampsia. The mom is more like a susceptibility. That's the best I can give you.
Thank you, Anant. And are there any questions, Akila, on the chat box? You have it on the...
Dr. Anjalakshi madam has put a question. Can we have this full literature?
Yes, of course. What did you say? The literature?
Yes, sir.
Yes, of course. If I will email you some reviews. I've written for a couple of the OB textbooks, some chapters on this, Williams and a bunch of other OB North American books. But I also have some reviews on this. I will send it to Palaniappan, and I'm happy. You guys should read it. I think this is fantastic because this disease. There's been nothing happened in 50 years. There's a possibility with this discovery that something could happen.
Thank you very much, sir.
So thank you, Dr. Anand, for that very amazing keynote address. It was indeed an eye-opener to the angiogenic imbalance in preeclampsia. Thank you so much.
Well, tomorrow I will. Thank you very much. It's truly a privilege. I want to tell you, you have a fantastic speaker, Kypros Nicolaitis, who's going to be talking about one of these factors called placental growth factor that's deficient early in first trimester. And he uses that, almost like to screen with ultrasounds very early. And if you can have a positive test, you can actually give aspirin, which can delay the onset of preeclampsia. So I think you should listen to him. And it's really, he's made some remarkable advances, particularly in this antenatal space in first trimester. Thank you.
Yes, Anand, thank you. And Kishore, can we have the plaque being presented here? Kishore, yeah. So Anand, this is with great honor. I request Cynthia Madam to read the plaque.
OGSSICON 2020 International Online Conference, 27th, 28th, and 29th August 2021. Appreciation Award presented to Dr. S. Anant Harumanchi for delivering the keynote address on 28th August 2021. We are honored to present this.
Thank you, ma'am. Anand, this plaque is ready with me. I'll see how it reaches you or it can reach.
Well, I will be, as you know, my mother still lives there, and I will see you in person and we'll pick it up in the 6 months. It's truly a privilege for me. I feel we're all family here, and there's nothing more exciting for me to come and present this work. Perhaps after the COVID, I will get in touch with Dr. Palaniappan and see if we could even do some in-person, sessions. I would love to sort of I view all of you as family. Thank you.
Sure, Anand. Thank you very much, and I'm looking forward to meet you in person. See you.
Thank you
very much.
Thank you.
So,
thank you,
Adila,
sir. Yes,
on behalf of our co-chairpersons, I thank you for this opportunity. It was indeed very wonderful, meticulously planned program, a show of talent by the organizers.
Thank you, madam. Thank you very much.
Akila, we move on to the next session.
To the next session. The next session, we have Dr. Madhani, Dr. Ramani Devi, and Dr. Epsiba as chairpersons. Dr. Madhani has wide experience of 40 years in teaching undergraduate and postgraduate students. She's a past director of obstetrics and gynecology, Egmore, and she's a past president of OGSSI. She has contributed to many chapters in books. Next slide, please. Dr. Ramani Devi, madam, is a consultant in obstetrics and gynecology in reproductive medicine in Trichy. She has been receiving various awards all through her careers. Added to her credit, she has published in many journals and edited chapters in textbooks and journals. Her special interest is infertility, endometriosis, and laparoscopic surgeries. Next slide, please. Dr. Epsiba, madam is a dynamic person. She is a professor in Savita Medical College at present. She was a past president of OGSSI and vice president in Chennai Menopause Society. She's interested in serving the society in several capacities, in creating awareness programs in the community through radios and televisions. And she has been receiving a lifetime achievement award from Tamil Nadu MGR University and various awards. To her credit, she has contributed to textbooks and many publications, and she's doing ongoing research in vitro hearing and osteoporosis. Over to you, chairpersons, to chair the next session. Madam will be introducing the speakers now.
Good morning to one and all. Dr. Hepzibah, can you kindly introduce Dr. Chinmayi for the FGR? Dr. Hepzibah.
Good morning.
Madam, volume.
Am I audible?
Can you increase
Yes.
the volume, madam, please?
Yeah. I'm happy to introduce Simaya, my old friend. She's the renowned fetal medicine specialist. She's a director and lead consultant. She's got a lot of awards received for Fetal Medicine Award and Young Author Award, and she's got received CS Dawn Gold Medal. And she's going to talk on the FGR early and late. As we all know, FGR is a complex multifactorial disorder which affects fetal development, and it is a common condition which causes contributes a major cause for perinatal mortality and long-term morbidity. But it is very important to differentiate early and late FGR because there is a lot of difference right from clinical manifestation, pattern of Doppler changes, monitoring, everything is different. So let's hear from Dr. Simya Ratta about the early and late FGR. Over to you, madam.
Thank you. Thank you so much, ma'am, for the kind introduction. At the outset, it is an honor to be here. I thank Palaniappan sir for this opportunity. And it's a privilege to follow Professor Ananth Karumanchi in a talk on FGR after he has explained so well how the placenta can have dysfunction and what are the reasons why it may not function as it should. And one of the fallouts of a poor placental function is fetal growth restriction. Now, we know that fetal growth restriction is the failure of any fetus to achieve its genetically predetermined growth potential. So whatever it is supposed to be, if it is unable to achieve that weight, then we think this is a form of growth restriction. But growth is a continuous process, and when there is restriction, the restriction will happen at some stage of that process. Obviously, when you talk about early and late, it is when early growth restriction sets in, it's called early growth restriction, and similarly late growth restriction. But when exactly does it set in for us to classify this is what we'll see, and why this classification is important is also something we need to understand. The important thing is fetal growth restriction itself becomes one of the most common pregnancy complications, and it becomes one of the important reasons for neonatal morbidity and mortality. So preventing fetal growth restriction or managing it optimally will help in improving the overall perinatal care. The algorithm for fetal growth restriction remains the same, that you establish pregnancy dating first so that you are assessing growth for the correct gestational age, assess biometry according to that gestational age, and then look at the Dopplers, fluid and placenta to see how the baby is responding to any form of restriction there. The problems with fetal growth restriction is the fetus is unable to grow inside the uterus. Why? Maybe it's not getting enough blood supply, or maybe it just doesn't have the potential to grow. So what is required is we monitor the baby, see how the blood flows inside are there. Is there any scope of improving the intrauterine environment? And when that is not possible, then you deliver the baby. But to deliver the baby, it should be at a viable gestational age, and you should have a good neonatal support to salvage a baby which is not completely term. Now, this classification of early and late growth restriction, we call it early versus late growth restriction, but actually it's early and late growth restriction because we need to understand that both may be going on simultaneously. But as a ballpark figure, 32 weeks has been taken as the cutoff. So any growth restriction that sets in before 32 weeks will be an early onset IUGR, and any growth restriction that starts after 32 weeks is late onset IUGR. So remember, it starts after 32 weeks. So your distinction will only be correct if you have checked that 32 weeks and made sure that there is no growth restriction at 32 weeks. Thereafter, if the growth slows down, that is late onset growth restriction. Sometimes you may do a scan at 35 weeks and find a growth restricted baby. Now, depending on the Doppler parameters, you'll probably be able to say whether it is a late manifestation of an early growth restriction or it is a late onset growth restriction. We'll come to that. So early IOGR has early placental dysfunction and very severe growth restriction, because just like we heard right now, till the placenta supports the pregnancy, it might not be able to achieve its full potential. A late fetal growth restriction is because of placental compromise, not so much as the resistance, but a little bit about the function. And this may not lead to a very small baby, but it has a serious risk of morbidity and mortality. If you look at the distinction of the two types of growth restriction, actually, clinically speaking, the late onset IOGR is more common. However, it is easy to identify the early onset IOGR because the manifestations are very stark. There is a reduction in the placenta, in terms of the pathology part of it, there's a reduction in the placental villus vascular area. So there are small number of vessels there, and therefore the placenta itself is not well formed, and there is a huge resistance to that blood flow in the placental circulation. The progression happens from a very early onset growth restriction to worsening of the umbilical artery Dopplers. Whereas in late onset growth restriction, the placenta may be very well formed. The number of villi will be fine. So there will be no great difference in the resistance of the blood flow that is offered, but the placental maturation is poor, and therefore gas exchange across the placental vessels might be impeded, and the quality of blood that goes to the baby becomes poorer. So here there is less blood, there is blood with less amount of oxygen being transferred. So typically in an early onset IOGR, one will see that dating has been established correctly, but all biometry parameters fall short for that stage of gestation. And one has to think of many other things other than the placenta per se, about aneuploidies, fetal infections, maternal nutrition compromise. If all this is fine, then probably the cause is very early onset uteroplacental insufficiency. When there is uteroplacental insufficiency, you see changes. You see some of the placenta which doesn't look very good, large, bulky, jelly-like placenta, echogenic bowel, rise in the resistance of the uterine arteries, which shows that the placenta is not being formed well. The mother is having to pump against a very high resistance circulation. And the umbilical artery, which is the flow that goes, from the fetus to the placenta and is a reflection of the placental resistance, starts showing increased resistance, absent diastolic flow, and reverse diastolic flow. So you may have cases like this where, early onset growth restriction sets in, and one of the key factors there is very early onset evidence of placental dysfunction, either uterine artery resistance increased or a low PAPA, and then a lower biometry. When you follow them up, there is a serial progression for that, but comparative to the gestational age, if you are able to achieve a good weight, then and a good gestational age, you probably have a good outcome. But if you are not able to do that, if you're not able to achieve that, you may have a compromise at some point. So this is a case of early onset IOGR where you see so many risk factors are apparent. Their age is 45 years, known case of diabetes, hypertension, low PAPA, and very early onset changes in the Doppler, like increased resistance in uterine artery, absent or reverse diastolic flow in the umbilical artery. So you go on following it serially. Now, when you go for a serial progression, you have to understand that there is high placental resistance and the umbilical artery changes predominate the picture, the clinical picture. So you have high resistance, absent diastolic flow, and reverse diastolic flow. So detecting early IOGR is not very difficult, but managing early IOGR becomes a big problem because you are racing against time and you want to achieve that appropriate gestation where you will be able to deliver a baby that can be salvaged. So sometimes you're able to push it with, improving the intrauterine factors, whatever you can do. And then you may take it to 36 weeks and deliver a baby, which may be 1.8 kgs, but you may still have a good outcome. So management here is difficult. Now, why is the umbilical artery such an important thing in early onset growth restriction? Because as you see, the umbilical artery is the vessel which is coming from the baby to the placenta. So the end resistance which the umbilical artery is encountering is placental resistance. So whenever placental resistance changes, umbilical artery flows change first, and then after a certain level of dysfunction, there will be hypoxia. The MCA redistribution is a sign of fetal hypoxia. Finally, the ductus venosus is the blood flow that is coming into the baby from the umbilical vein, and that is connected to the right side heart of the baby. So it is connected to the right atrium. So when cardiac dysfunction starts in the baby, because it is pumping against such high pressure, the baby's heart is under a lot of pressure in early onset IUGR. And when that heart failure sets in, then the ductus venosus flows will become abnormal. When ductus venosus flows become abnormal, it's an indication that even the inflow of oxygenated blood is getting affected. And now this baby has a serious risk of intrauterine fetal death. So in early onset IUGR, we monitor the cascade of Doppler changes, starting from the umbilical artery changes to the middle cerebral artery redistribution. And finally, the ductus venosus becomes the single most important predictor of the risk of fetal death. So when ductus venosus becomes abnormal, you have to assess. If you are at 26 weeks, you may probably have a long chat with the family because it's very difficult to save this baby at 26 weeks with these changes. But if she's 34, 33 weeks, you might as well go ahead and deliver the baby. So in late onset IUGR, the problem is not about this fight against the gestational age because it starts only after 32 weeks. In early onset IUGR, you'd be happy to reach 32 weeks. But late onset IUGR, the problem is starting after 32 weeks. So where is the problem? The problem is you may not actually detect the late onset IUGR. What happens here is placental resistance does not change, but placental maturity is poor. So that cascade of umbilical artery flows and that abnormal Dopplers, that whole story doesn't happen here. What happens? Some subtle changes. There is a mild vasodilatation in the cerebral circulation so that the MCA resistance mildly decreases. The umbilical resistance may mildly increase, may not mildly increase. So how do we detect this? What is happening here is if you look at the growth curves serially, if you check the pattern of growth curve in a serial manner, you will see that towards the end, the growth curve is flattening. The velocity of growth is reducing. And this results from a failure of the placenta to supply adequate nutrients and oxygen in the late gestation feature. The diagnosis is difficult and the outcomes have a large variability in terms of parameters. So you can only suspect late IUGR if you're serially monitoring the growth of a baby and you see that as the gestation progresses, the centiles at which the baby is growing are falling. In fact, it is defined as 2 quartiles. If it comes down to almost 50 centiles if the fetal growth drops, then you will find that. Or you may have a very changed HC by AC ratio in the 3rd trimester, which will give you the first clue about late onset IUGR. What happens to the blood flows? As I told you, the umbilical resistance may not change because the placental villi have not become smaller in number. There is only a small change in the only a problem in the maturity of the placenta. So here the MCA Doppler will show the first changes, which will be very subtle. And therefore, just by one Doppler, you may not be able to pick up the change, which is why this concept of doing the cerebroplacental ratio is important. Because if there is a small change in the MCA, what happens? The resistance decreases. Small change in umbilical artery, what happens? The resistance increases. So because the numerator and denominator are changing in opposite directions, the ratio will change much more. So instead of a single Doppler, the cerebroplacental ratio helps there. So if you differentiate between early and late growth restriction, in early, the fetal heart is at risk. The maternal heart is at risk. Whereas because there is the incidence of preeclampsia and other problems are more in the early onset growth restriction pathophysiology. Whereas in the late onset pathophysiology, it's the fetal brain which is at risk because this is a non-compromised baby at 32 weeks who is suddenly subject to hypoxia. So the brainstem might get affected and there is a high risk of even fetal death. So increased morbidity and mortality is a picture in both the conditions of early and late onset IUGR, but early IUGR is easy to detect, late IUGR is difficult to detect. Just as an analogy, if you see the report cards of 2 babies, student A and student B. Student A has been consistently performing on the lower grades. He got C, D, and his final marks are 47 out of 100. But he's managed to pass the final exam because somehow he managed, because they started, everybody was worried. They started tuitions, they started extra classes, and somehow this baby did well. But student B was going on with excellent grades, A, B, C, nobody bothered about him. Something happened in the last trimester in the last final exam period when the child got distracted completely and had a very poor performance in the final exam. Now, what has happened in the student A scenario? Either the student doesn't do well and drops out early, which you anyway expect, or somehow you manage to push through the final exam and do something like a planned preterm delivery in an early IOGR. Whereas in a late IOGR, the student was doing so well. Something went wrong in the final semester. Nobody paid attention and he crashed in the final exams. Even though the overall marks are 75 out of 100, this child won't pass because if you fail the final exam, you don't pass the class. So that is exactly how late onset IOGR may start late, may not show an overall smallness. The weight of a baby who has crashed because of a late IOGR complication might be more than the weight of a baby who has been salvaged after an early IOGR complication. So the smallness is more in early IOGR, less in late IOGR, but the potential for damage is much more in late IOGR. So the Doppler changes in early and late should be remembered by everybody. You have a cascade in early IOGR. You have a very subtle CPR, cerebroplacental ratio change in the late IOGR. The smallness is much more in early IOGR because problem has started much earlier. The smallness is not so much, but there is a risk of death because the brainstem is not attuned to handle that level of hypoxia. This is not a baby which has a degree of compensation going on. And therefore, fetal growth restriction remains preventable morbidity and mortality, early diagnosis, appropriate monitoring, and timely delivery. So how do you optimize delivery? You try and treat what is wrong in the baby or in the mother, but you can't do much. There are no proven treatments for growth restriction. What we know is very little. We don't know whether maternal nutrition just helps, whether rest helps, whether hydration helps. We try whatever we can do within the parameter of do no harm, but there are no proven treatments for growth restriction. All we can do is a timely delivery. So there is a stage-based management criteria for delivery, and it all depends on the gestational age and the Doppler status. So whether early or late, when you look at this particular stage-based management, you can actually make out. So at 37 weeks, you have a parameter of low CPR and a smallness of the baby. So if the baby is small, in late IOGR, if there is a change of more than 2 quartiles and CPR is less, then you can think of delivery. In early IOGR, you can go stage-based at every gestation, looking at the Doppler parameters, and it's a fairly self-explanatory table where you try and optimize the gestational age and the Doppler abnormalities. Because these Doppler abnormalities are actually reflecting the problems in the baby, which start with placental disease, go to hypoxia, then acidosis, and then death. You want to intervene between hypoxia and acidosis because it's a small baby. You don't want to intervene before hypoxia because there's no reason. It's a small baby, but if you wait till acidosis, you will have non-reversible neurological changes. And if you wait beyond that, you may lose the baby. So you have to constantly balance the odds and try and keep the heart and the brain in sync with each other. Because as I said, in early pregnancy, in early IOGR, the heart is at risk. In late IOGR, the brain is at risk. So early diagnosis, appropriate monitoring, and timely delivery. The common goal of management of fetal growth restriction remains survival, but now we are more interested in intact survival. We don't want a baby who has long-term neurological deficit. So whether early or late, your delivery should be neither early nor late. If you deliver the baby too early, you will have extreme prematurity and problems related to that. If you wait too late, you will have hypoxia, acidosis, and sometimes death. If not death, acidosis can lead to long-term neurodevelopmental delay. So understanding the early and late classification is important. Let's not call it early versus late IOGR. Let's call it early and late IOGR and understand that it's not just the gestational age, but the parameters. So for people who've done the scan at 28 weeks and do the next scan at 36 weeks and get confused whether this is early or whether it is late, it's actually not such a big problem there. If you see serious changes in the umbilical artery, probably it is a late manifestation of an early onset IOGR. If you see very subtle changes in the umbilical artery, probably it's a late onset IOGR. But really, in terms of management, it doesn't make such a big difference. In terms of understanding, it does, because like we heard in the last lecture, pregnancy is now becoming the window where you predict the long-term maternal health as well. So early IOGR has the problems with regard to maternal morbidity much more than late IOGR. I think with that, I'll rest my case. Thank you very much for this wonderful opportunity.
Thank you, Dr. Sylvia. It was a wonderful talk and very nicely pointed out how the early changes happens in early FGR. It is a cascade of events which is directed towards the heart, the umbilical artery, and then the MCI cell changes, and then the ductus venosus. And in late, it is mainly the MCR, and that it is the subtle changes. So it affects the brain. So in both, it can even coexist. In both, the monitoring is important. The Doppler changes we have to do, and we have to do a timely intervention and appropriate gestational age so that we can give them an intact survival. It was beautifully dealt, very nicely. Everyone would have understood what is early, how to monitor. Thank you so much for the wonderful session.
Thank you.
Madam, kindly introduce the next speaker, madam.
Yeah. Am I audible?
Yes, ma'am.
You are not able to see me. Okay. A preterm birth is either spontaneous or induced. Iatrogenic preterm births are on the increase. You know, because of the assisted reproduction, increased incidence of GDM, hypertensive disorders of pregnancy, as the previous speaker said, FGR. We all know that preterm birth contributes significantly to the neonatal morbidity and mortality. Children born prematurely have an increased risk of RDS, cerebral palsy, respiratory illness, sensory deficits, and learning disabilities. Most common cause of death is going to be a preterm newborn in RDS, as also said by Dr. Anand in his slide. After experimenting in fetal lamb, Liggins and Hovey in 1972 observed that AN steroids, if given to mothers prior to preterm delivery, reduces RDS and hence the newborn mortality. We have got a fetal medicine specialist to talk to us, Dr. Joy Balakrishnan, who graduated from Karnataka, did his MS in Orissa, and has settled down in Kerala, starting the first fetal medicine unit and doing all the interventional surgeries, including fetoscopy, etc. He has been presented in various papers, conferences. So I invite Dr. Joy Balakrishnan to give the talk on the magic bullet.
Thank you, ma'am. I'll just share my screen. I hope my screen is visible.
Yes, sir. Please go ahead.
Yes.
Yes, it is visible.
Yes, you are visible.
Thank you so much, and good morning, everyone. And let me start by thanking Palaniappan sir and the entire team for giving me this opportunity to be here. And yes, I totally agree with what Dr. Ananthan sir said in the beginning. You know, when you develop a drug in pregnancy, we are always worried as to what the side effects are going to be. What are the problems when you have a drug? It's not just the benefits. We need to know the complications as well. And steroid is something that we have been using in and out in pregnancy, and we believe that it's good. It prevents RDS, it prevents neonatal mortality, and it prevents a host of other complications. So it should be good. It should be the magic bullet that we can use to actually take out all these complications. Now, I must also thank Chinmay for giving us that outline on early and late onset growth restriction, because I know most of you obstetricians will have faced this common clinical situation. At 33 weeks, you have a fetus that has got severe growth restriction and somebody has advised immediate delivery. And the question running in your mind is, should I give steroid to this mother to save the baby's lungs or not? And that's going to be the predominant question that we need to answer. Now, if this was a live conference, I would have asked for a show of hands to know how many of you would give steroids to this mother. G2, P1, L1, 33 weeks, stage 3 FGR, advised immediate delivery. I'm assuming that most of you would have said yes. And that's why this talk is important, because the answer to this question is no. And I'll tell you why at the end of this talk. Now, when we talk about evidence-based medicine, we know that systematic reviews, meta-analysis are right there on the top, followed by randomized controlled trials. And if you look at steroids, it can't get better than this. There are more than 12 randomized controlled trials that prove steroids are good. They decrease the incidence and severity of a host of complications like RDS, intraventricular hemorrhages, necrotizing enterocolitis, and even mortality, it's extremely, extremely good. I'm not going to argue with that. But this evidence has translated into an indiscriminate use. There is a very low threshold when it comes to the usage of steroids, and now guidelines have pushed the usage of steroids till 36 plus weeks. But the interesting fact here is that 1/3 of your pregnancies that you give steroids to will deliver at term, 1/3 of them. And this is under the assumption that there are no long-term effects for the steroids that you give. So are they completely safe? Aren't there any long-term outcomes for steroids? And if there aren't any outcomes, bad outcomes for steroid usage, then why are neonatologists so afraid of giving steroids to the newborn? They do not give steroids to the newborn because they hold it back for a number of reasons, and I'll come back to that. So how do steroids work basically? They just work on the lungs, they improve the pneumocytes, they improve the beta receptors, they release and absorption of surfactants. They also play a primary role in making your lungs dry. But that's all before 34 weeks. After 34 weeks, the primary role is basically to increase the postnatal absorption of the lung field. So you have very little fluid within the lungs, and that is where steroids help. And so the best time that it acts is between the 2nd and the 7th day after you take your first dose. But that does not mean you do not give it if you do not have that much time between giving steroids and delivery. You can give it even if you have a very short interval between the first dosage and delivery, because studies have shown that it is effective even a few hours after you give your first dosage. Now, the common indications are preterm labor, PPROM, and maternal indications. And preterm labor is something that's very, very important to understand, because 53% of your preterms are not going to deliver, which means your diagnosis is going to be wrong. And most of the times you are very happy to give steroids if you have a suspected case of preterm labor. So your drug of choice is going to be either betamethasone or dexamethasone. And it's because of the ability of these drugs to cross the placenta and reach the fetus. And that's why we use these drugs. And we have these standard dosages that are there. There's 12 milligrams for betamethasone and 6 milligrams for dexamethasone. And you have to give the same dose whether they are obese or mothers who are on steroid therapy. We know all this. These are all common facts that we as obstetricians know day in and day out. But when we come to the side effects, we have to understand that when you're giving a combination of steroids and
Please continue.
Yeah. So when we give steroids along with tocolytics, there is an increased risk of pulmonary edema apart from the normal risk of chorioamnitis and hyperglycemia. And also, when you look at fetal surveillance, for example, in early onset or late onset growth restriction, as Chinmay has already described, if you give steroids, you're going to create changes in the CTG. There's going to be a less amount of variability. You're going to decrease the breathing movement. You're going to decrease the fetal movements. And it's important to understand that you will give steroids only after you have decided to make the delivery. And you're not going to change your plan of management based on what you see on the CTG after giving steroids. The same thing goes for Doppler as well. There is a transient improvement in the end diastolic flow, and it happens 8 hours after your first dose and lasts for around 3 days. So that transient improvement does not mean that the fetus is getting better. It just tells you that your steroids is having some action on the fetal heart, but you have to go ahead with your delivery as planned. Now, we cannot give it before 23 weeks because although the survival benefit is going to be there, it's not going to change the morbidity in that group. Whereas between 23 and 34 weeks, the survival benefit has been proven. And if the baby delivers within 7 days, your outcomes are going to be extremely good as compared to the long-term outcomes. But the controversy is in late preterms. Can we give steroids for fetuses that have crossed the 34 weeks mark gestation? Now, most guidelines are supporting this. The NICE guideline says that you can give steroids till around 34 to 36 weeks in all cases of suspected diagnosed preterm births, PPROMs, and also planned vaginal deliveries before 36 weeks. The ACOG guidelines also says the same thing. 34 to 37 weeks, you can give steroids. However, they do warn you should not give it in chorioamnitis. You should not give if you have given a previous dose of steroids, and you should watch out for neonatal hypoglycemia. Now, all this evidence is based on this single paper which came out in the New England Journal of Medicine in 2016, which looks at antenatal corticosteroids in women at risk for late preterm delivery. And this paper said that it's okay to give steroids and it improves outcomes. But in every study or every paper, the devil is in the details. And we need to look at this paper a little bit more carefully. They had 2,800 women and they divided it into two groups. One group received steroids and the other one received a placebo. And both of them delivered at term. They looked at the primary outcome, which is the requirement of respiratory treatment within 72 hours. And what was this respiratory treatment? They specifically looked at the need for CPAP, the need for high-flow nasal cannulas, ECMO, and mechanical ventilation. Now, in none of these groups, that is, neither in the placebo group and nor in the steroid group, was ECMO or mechanical ventilation required, which means there was no serious complication in either of these two groups. So the difference that they saw was in CPAP and high-flow nasal cannula, which means the difference that they saw was basically in transient tachypnea of newborn, and it was primarily in those fetuses that had an elective cesarean section rather than those fetuses that went in for a vaginal delivery. Now, what does that tell you? It tells you that the change that is there in these fetuses when you give steroids is actually very short term. It's just a minimal survival, not even a survival benefit. It is a slightly improved lung condition, that is an absence of transient tachypnea of newborn, which is actually having a very good outcome. But what about long-term outcomes? When you give steroids to these fetuses to overcome a minor complications, are you going to put these fetuses at risk? And that is why these two papers, one which is a population study which came out in 2020 in the BMJ, which looked at neurodevelopmental disorders among term infants exposed to antenatal corticosteroids, found that there were a huge host of complications that were more common in those fetuses that were exposed at term. There was attention deficit disorders, emotional disorders, disorders of social functioning, and also tic disorders. Now, another study that was done was also showed the same thing. And if you look at this chart, you can see that the red bars here are showing neurocognitive abnormalities. And when you followed up fetuses that received steroids as compared to those fetuses that did not receive steroids, and when both of them were delivered at term and followed up to the age of 9 years, you can see very clearly that the red bars are taller, clearly telling us that the group that had received steroids were at increased risk. And there was more evidence that was published in JAMA. This was a Finland paper which looked at, again, a large number of fetuses, and they found the same thing. There was composite neurodevelopmental delay in those fetuses that were born closer to term and had been exposed to steroids. Now, why is this happening? The brain is actually highly metabolically active, and the growth accelerates after 34 weeks. And as this brain acceleration happens, there is a large number of glucocorticoid receptors within the brain. And these glucocorticoid receptors are going to affect the neuroendocrine system. They're going to create changes in your endocrinal, behavioral, emotional, and cognitive functions. It's going to have a direct effect on the brain because of these receptors. Now, these receptors are not present in those early preterm fetuses before 34 weeks or before 30 weeks, where the lung is going to have a really good improvement when you give them steroids. And that's why neonatologists also postnatally do not give steroids, because there is clear evidence of neurological impairment in these brains that are actually growing at a very fast pace even after the baby is born. And numerous animal studies have actually shown this same thing. And it's not just the neonatologists. Even when you look at the preterm fetuses that are born before 34 weeks, also there is a slight difference. But that slight difference is actually overcome by the survival benefits for these fetuses that are born before 34 weeks. So before 34 weeks, it is absolutely essential that you give steroids. But after 34 weeks is an area that still needs more research. And the whole world is waking up to this fact. And the European guidelines for the management of RDS clearly states that you cannot give steroids beyond 34 weeks, and they recommend steroids only till 34 weeks. And what about repeated dosing? Whenever we have a baby that is going to deliver, we give steroids. And we get it wrong 53% of the time. The baby might just continue and go ahead. And then later on, again, they have a certain preterm contraction or a suspected preterm labor, and then we go in and give steroids. So how can we do that? Or can we keep on giving steroids? And the ACOG has clearly stated that you can give only a single course of steroid, and it has to be given at least after 14 days of your last dose. And it can also be reasonably given within 7 to 14 days, but not more than one dose. And you can either give it as a single dose, or you can give it as the entire whole two-dose course that you give, but either one of them would be reasonable. So you cannot keep on giving steroids because of this issue of probable long-term neurological outcomes. What about the growth-restricted baby? Now, the growth-restricted baby is under stress. This baby has a large amount of cortisol circulating within its body. So do we actually need to give steroids? And I'm sure when you have looked at your fetuses that have delivered preterm, you would have found that they are actually doing well in the NICU. When they come out, when they are born stressed, they actually do well, even if you have not given steroids. And if you have twins with growth discordance or one baby showing growth restriction, you will find it's the larger baby that has difficulty in the NICU, whereas the smaller baby does well. And this controversy was settled by this paper, which came out in 2020, which looked at antenatal corticosteroids in SGA babies, and they found that it was useful. Here again, I want to remind you about the details. And I look at the forest plot of that particular paper. They looked at a number of studies, and let me just give you a little bit of statistics here. If you find that the line crosses this black straight line, it means it has no effect. And if you look at all the studies, you can see that almost all of them have shown no effect. It's only these 3 studies that have shown some effect in favor of antenatal corticosteroids, and it is these 3 studies that have pushed the usage of steroids in favor of actually these fetuses that are growth restricted, and therefore we would probably need larger trials to say whether we can give them in these early onset growth restricted fetuses. But yes, till that question is resolved, it is definitely indicated to give steroids for these babies less than 34 weeks. Coming to our question, which I asked right at the beginning, G2P1L1, second opinion, 33 weeks, stage 3 FGR, advised immediate delivery. Do we steroid this pregnancy or not? Yes, you would steroid this pregnancy if the diagnosis is correct. And that's why it's important to understand that the first thing that you need to think about is not the gestational age, but to look at the diagnosis. And so we looked at the report and we found that this baby was, yes, small, less than the 10th centile, had normal Dopplers, a normal AFI. It was only the DV that was abnormal. Now, as Chinmay rightly pointed out, it's not possible for us to get an abnormal DV with everything else being normal. There has to be some sign of cardiovascular decompensation. So it was the DV that we looked at. And when we looked at the DV, this is what we saw. We found that, yes, the DV was showing increased resistance. But when we looked at it a little bit more closely, we found that that resistance was actually varying over a period of time. So that there was high resistance at some places and there was low resistance at some places also. So what does that tell us? It tells us that this baby was probably doing something else, and that something else was this, a very reassuring sign of the baby breathing. And when the baby breathes, the abdominal pressure is going to increase and it is going to create a change in your DV flow. And when a baby breathes, immediately we know that that baby is not having any acidosis. So the final picture was a baby that was at the less than the 10th centile. All Dopplers were normal. The biophysical profile was 8/10, and this baby was probably a small for gestational age fetus that did not require delivery, imminent delivery, and was followed up and delivered at 38 to 39 weeks. So the take-home message is that yes, steroid is a powerful tool, but it has possible side effects. It's best used before 34 weeks. And remember that whenever we decide to deliver, we should be sure of our diagnosis and we should be sure that this baby is going to deliver within the next 7 days. Giving it after 34 weeks is controversial. And right now, I would err on the side of caution because the only advantage of giving steroids after 34 weeks is to prevent transient tachypnea of newborn. And that has not been shown to cause any major complications. So get your timing of delivery right, and you have only 2 chances to use your magic bullet. Thank you. Thank you for listening.
Thank you, Dr. Vijay, for your excellent talk on that. Every bullet has got its use and abuse. So correctly, you have told us what we should do. So take home messages after 34 weeks, better not give. Thank you very much.
Thank you.
Vijay, I'm sure you have questions in the chat box. We'll take it at the end of the session. If it's possible, please stay on for some time.
Yes, sir.
Dr. Ramani Devi, are you there?
She's not there, ma'am. Would you mind introducing, or I'll do the honors?
You want to introduce? Go ahead. No problem.
Yes, okay. Let me have the honor of introducing Dr. Muralidhar V. Pai. Dr. Muralidhar V. Pai is the Dean of the Sikkim Manipal Institute of Medical Sciences, Sikkim, and I'm sure we know that he's been associated with the Manipal Institute in Karnataka, and he's been recently taken over as the Dean of Sikkim Manipal Institute of Medical Sciences, Professor of Obstetrics and Gynecology, and he's held various positions, and he's had over 500 guest lectures and 175 publications, author of so many books, and he's the best outgoing candidate, best teacher 8 times, best teaching material 3 times, and he's got a lot of kudos to his credit. And apart from all that, Dr. Murli is a very close friend of mine and would kindly accept to come for the conference whenever. And the topic is quite flexible, and whatever topic we give to Dr. Murli, he'll be absolutely happy to take the topic and do the best possible job out of it. And that is why there are a lot of fan followers for him throughout the country. And over to you, Dr. Murli.
Thank you very much, Dr. Palaniappan, for this kind invite. And I'm always happy to visit Chennai. And especially when you invite me, I just cannot say no. The original talk was supposed to be at evening, and then you said there is some other reason we have to bring it in the morning. So I have to adjust time for you. So I'm happy to talk today on a topic which is so common. Cesarean section is bread and butter of obstetricians, and an average obstetrician would have done thousands of cesarean sections. Yet the next cesarean section can be a challenge. So Dr. Palani wanted me to address this issue, and there is no chapter as such in any textbook on the difficult cesarean sections as such. So what I have done is I have dug into my own experience and my colleagues' experience and listed out following are the challenges that most of us usually face. And I have suggested some, troubleshoot for these. Number one is, and the commonest, the approaching the lower segment, especially in the era of previous cesarean sections. Then extending or spontaneous extension of uterine incision because of the brittleness of the lower segment, delivering the mobile head, especially when you plan the cesarean section earlier before term, or on the other hand, delivering a deeply engaged head. Suddenly you realize a fetal distress in the late second stage, or delivering a big baby or an anomalous baby or twins. And very, very rarely, even now, we may confront a conjoined twins. Abnormal positions and presentations are always a challenge for the beginners, especially. And then malpresentations, same reason. Delivering in placenta previa can be a challenge, even for an experienced person. And then the management of adherent placenta. Postpartum hemorrhage after cesarean section. Suturing the uterine incisions, and finally, the other injuries that you may cause at the time of cesarean section. I would quickly go through, rather run through each one of them because I want to finish in 15 to 20 minutes. This talk was tailored for 30 minutes, but I will try to finish in 15 minutes. First, approaching the lower segment. All of you know that the dense adhesions between abdominal wall and intestines and anterior abdominal wall itself can be a challenge. Before approaching the lower segment, you may not be able to see the uterus itself. You can take the help of surgeons. In spite of doing that, sometimes they also won't be able to give you even an upper segment. So very rarely you may have to go through the fundus. I have gone through the fundus twice in my life, but only thing is after that, it is mandatory to do sterilization because fundus is the weakest point of the uterus and it's a sure recipe for rupture uterus in the next pregnancy. Bladder pulled up is the commonest problem that we all face. The tip here is go for a sharp dissection. Push the bladder down adequately. Then you won't be in trouble. If you have difficulty, of course, you can go to the upper segment. But the problem is the current day obstetricians are not well versed with even upper segment cesarean section. It is better we watch one or two at least. Second, extending or spontaneous extension of uterine incision. As I said earlier, it is difficult to extend a scarred or a brittle lower segment due to previous cesarean section. What I have shown in the picture is the normal way of extending the lower incision in a primary cesarean section. This may not always be possible. So what we have to do here is extend with a sharp dissection. I have realized some obstetricians routinely do this, but it is not necessary to do routinely because when you do sharp dissection with the scissors, there are chances to injure the fetus. That's why you have to always guide by putting 2 fingers inside. And also if you overshoot, you can injure the uterine arteries. So that's exactly why in the next slide, I am suggesting go for a curvilinear or a smiley incision, what we call, or simply a J-shaped incision. The third problem is delivering a mobile head. Especially if you are going for an elective cesarean section, the head may not have been engaged. She is gravida too as well. So if it is a preterm situation, you can go for what is called low longitudinal incision. Of course, one has to be careful not to extend into the bladder. Bladder has to be pulled or pushed down very nicely before go for a longitudinal incision. I have hardly gone through a low longitudinal incision in my life. The standard procedure, whether it is preterm or a term baby, is a manual delivery first by incising as low as possible and in inserting your hand below the head so as to guide the head to glide on your hand. Drain the liquor and allow the head to descend enough. If you prematurely try to hook it out, you may land up in problem. Then if you want, you can ask the anesthetist or an assistant to give a slight frontal pressure. Now, this has been controversial in especially the vaginal delivery. But in abdominal delivery, usually we ask the anesthetist or an assistant to give frontal pressure. So here is a small video taken from the YouTube wherein you see that a slight pressure on the fundus will help to hook out the head of the baby. Now, if that is not possible, you can use vacuum provided the baby is term. Here is a vacuum that is used, a handheld vacuum, kiwis, and you have to go as posteriorly as possible so that you will maintain the flexion of the head as delivery, during delivery. And once you are sure about creating enough grip on the head, you can nicely deliver the head. In Manipal, we have kept a vacuum with a very long tubing and that it can be sterilized. But this kiwis instrument seems to be easier. Dr. Nazar Shariar always promotes this forceps delivery. Now here, we need to remember that you have to use both the blades. PGs usually get confused with this. So I'm underlying the word both the blades. As you can see here, it is a cephalic application because the head is above the pelvis. The left blade becomes the lower blade. You insert the lower blade first, and then on top of that, you insert the right blade, or which is called the upper blade. And of course, it will be transverse to the pelvis, but doesn't matter because we are not in the pelvis at all. And once you have locked the blades, you can slowly deliver the head. This is the standard procedure for a mobile head in many situations. As you can see that. It may not be very easy, but you have to have patience. There are chances of extension of the incision. You have to be careful about it. That's exactly why it is better you give a curvilinear incision right in the beginning. Now, here is a demo. You do the phantom application first, then take the lower blade, that's the left blade, guide it on the palm of your hand as shown here. Take the right blade, which is upper blade, again guide it under the palm, lock it, and then slowly you can deliver the baby. Yes. So now, if that is not possible, or you are not comfortable using vacuum or forceps, what you can do is internal podalic version followed by breech extraction. I jokingly always tell it is easier to pull others' legs. So you are not able to get the head. Don't worry. Just go for the legs. And then the feet. Catch hold of the feet. Do internal podalic version and breech extraction. Of course, for this also you need a lot of experience. Now I go to the exactly opposite, that is deeply engaged head. This can be a big challenge, especially the lower segment is so thinned out. That's exactly why the incision has to be as high as possible. Break the vacuum between the head and pelvis. I'm not saying use vacuum. There will be a big vacuum created because of the jamming of the head. Unless you break this by putting your fingers in between the lower segment and the head, you will not be able to budge the head, neither push the head or deliver the head. So now what you do, insert the hand deeper down. If your hands don't go, you can use a single blade forceps or a special instrument called Vectis. Here I'm underlying the word single blade. For a mobile head, both the blades. For a deeply engaged head, single blade. So this is a picture of Vectis. It will work like a shoe horn and you insert it below the head and then hook out the head. Now, if that is not possible, this is another commonest technique that is used called push technique. You request your assistant to wear a sterile gloves and push the head. Now, fetal pillow is another instrument that is used which can be inserted below. As you inflate the pillow, that will push the head up. So you can use both. And here you have to remember, it is not just pushing the head. In fact, you have to flex the head and then push the head. Otherwise, you may damage the anterior fontanelle. Now, if that is not possible, here it is reverse breech extraction. Not internal podalic version and breech extraction as I told in case of mobile head. It is different. As you can see here, you have put an incision, the head is deeply engaged, you cannot do the delivery of the head. Now here, you deliver the breech first, not internal podalic version. You deliver the breech and then deliver the head. Then of course, the famous Patwardhan technique. So in this technique, there are several techniques that have been suggested. First, you go for whatever organ is available. That is the hands, then the body, then the legs, and finally the head. This is the classical Patwardhan maneuver. Now, there are certain modifications. Other day, when I gave a talk like modification, somebody answered saying that there is not modification. These are different versions of same Patwardhan technique. Here you go for one hand, then the second hand, then the body, then the legs, and finally the head. But in another modification, especially when it is occipito-posterior, you go for the legs first, then the body, then the hands, and then finally the head. It is almost like reverse breech extraction, which I showed you. It is on the mannequin. You can see that first you go for the legs, and then the body, and then the arms, and finally the head. Dr. Ajit Virkut's videos on YouTube are excellent. Here is another technique where you go ipsilateral, same side, hand and leg, other side, hand and leg, then the body, and then the head finally. So whatever you can deliver first, you deliver, but head is delivered in the end. That summarizes Patwardhan technique. Then I come to the big anomalous babies or twins or conjoined twins. So the tip here is that you have to make a bigger incision, both abdominal and uterine, and it is better done with the scissors, U-shaped, J-shaped. Avoid inverted T-shape at any cost. But if it is necessary, you have to do that. But gentle while delivering the head and shoulders. You may drain the hydrocephalus ascites before delivering a very big or an anomalous baby. As far as twin is concerned, the tip here is deliver first the first baby, of course, but don't deliver the placenta as we tell in vaginal delivery. Then, of course, deliver the second baby, apply 2 clamps for identification, and finally deliver the placenta. If it is conjoined twins, again, as in case of big babies and anomalous babies, make a big abdominal incision and you deliver in sequence. Here is a small cesarean, which I did when I was associate professor. It was a triplet. The first baby was normal, and the second 2 babies were conjoined twins, actually. And as you can see here, I extended incision using scissors. Can you see that? Yes. And then you deliver the first baby as usual, no problem, hand over. And then you go for the conjoined twin. Now, while delivering conjoined twin, you have to go in sequence. First deliver one head. And then you go for the shoulders of that baby. Here I am rupturing the back of membranes. Of course, it is always better to know the type of conjoined twins, whether it is thoracopagus or craniopagus, etc. See, here it was thoracopagus. Deliver one head and deliver the shoulder of that particular baby. And then, as you can see here, the other baby is hugging the co-twin. Then, of course, you go for the head of the conjoined twins. This happened some 15 years ago. Nowadays, we don't get conjoined twins at all because if you diagnose them early, you may not allow them to continue. That is the conjoined twin. The tip here is you have to make a big incision. I'll go for abnormal positions. Because of paucity of time, I have just 2 or 3 minutes left. The tip I want to give you is that irrespective of whether it is vertex, brow, face, anterior, transverse, posterior, left or right, the tip is maintain the flexion of the head. What I mean by that is, if you are standing on the right side, and if it is ROA, hook out away from you. If it is LOA, hook towards you. If it is occipito-posterior, hook towards the mother's head. This is the simple tip I want to give you. Maintain the flexion at any cost. Then comes the malpresentation. Transverse slide. Again, the tip here is you go for the legs or the ankles, catch hold of the ankles, internal podalic version followed by breech extraction. But the usual question that is asked in the exam is that suppose some fetal parts are coming out at the time of incision or loop of the cord comes out. I have written in bold and red. Ignore all that. Try to go for the ankles, deliver the baby, ignore all the parts. As far as breech is concerned, the principles are same. Maintain the back anterior. And as far as pulling is concerned, you have to pull parallel to the OT table because to avoid the extension of the head. If the baby is a frank breech, go for Pinot's maneuver. That means flexing the legs by pushing on the popliteal fossa and then catching off the ankles and delivering the legs one by one. Delivering in the placenta previa. Suppose if it is the type 1, try to incise as low as possible, avoiding incision on the placenta. Push the placental edge up. If it is type 3 or 4, go as high as possible, again avoiding the incision of the placenta. But if it is type 2, you can't help it. You have to cut through the placenta, immediately clamp the loop of cords, and deliver the baby. Here you need an experienced obstetrician. Then comes the problems in placenta previa. Always anticipate adherent placenta, postpartum hemorrhage, suturing difficulties, and be prepared and take prior consent for component therapy, peripartum hysterectomy, and ICU admission. Adherent placenta, of course, nowadays it is very, very clear, unless it is a simple adherent placenta where you can manually remove the placenta. If it is accreta and percreta, better to go for elective cesarean hysterectomy, cesarean followed by hysterectomy around 36 weeks. Postpartum hemorrhage, you are in a better position because abdomen is already open. Go for stepwise vascularization, devascularization. If that is not working well, go for interiliac ligation. As other methods, B-Lynch and Cho stitches also can be put. But if those don't work, go ahead with the peripartum hysterectomy, and the principles here are clamp and drop, double ligature for all pedicles, and do, as far as possible, total hysterectomy. Take care of descending cervical and vaginal arteries while doing so. Finally, I come to the last two difficulties, that is suturing of the uterine incision can be challenged sometimes because if there is placenta previa, that can be friable, and if the assistant pulls hard, it will cut through. Make bigger bites, ask the assistant to not pull very hard. And of course, you have to approximate the edges, be meticulous while doing so, take care of the bleeders by figure of 8 sutures, evacuate the hematoma, and suture the edges properly. Finally, other injuries. If it is small nick on the bladder, you can suture in layers. But if it is big injury or a ureteral injury, better to take help of urologist. Same for bowel injuries. Only a serosal tears you can suture, but other injuries you have to bring the surgeons in. As far as uterine rupture and lacerations, it is always better to do hysterectomy rather than repair the ragged edges. If it is fibroid, nowadays everybody is going for removal of fibroids at cesarean section. Thank you very much for your patient listening.
Thank you, sir, for a wonderful deliberation on difficulties in various aspects you have dealt so nicely. Thank you for the wonderful lecture. Thank you so much, sir.
Thank you.
Okay. Can we move on to the next? Yeah, it's my privilege to introduce my friend, the Stanleyan, Dr. Kurian Joseph. He's director of Joseph Hospital. He's a pioneer in endoscopies and he has trained many doctors from India and abroad in endoscopy. He's not only an endoscopist, he's an expert in instrumental delivery. He's a past president of OXI, past president of Asia Oceanic Federation of Obstetrics and Gynecology. He has been elected twice as a board member for International Society of Gynecendoscopy. He's a vice president of FOXI. He's the organizing chairperson for AICOG 2015 at Chennai. And currently, he's a chairperson for Tamil Nadu Indian Association of Endoscopy. And the forceps, as we all know, it is very safe, but currently it is declining. And even today, it is a safe instrument to use in so many conditions. And but it requires a careful assessment of the clinical situation and expertise in the procedure. But still it is declining, and the attitude to maybe an increasing attitude of the obstetrician to prefer a vacuum extraction or a cesarean, or it can be due to a maternal choice preferring a cesarean section on demand, or it can be due to an obstetrician has to be trained adequately and supervised during the use of forceps. Let us hear from Dr. Kurian in his keynote address, forceps delivery safe, yet why it is not popular? Over to Korean.
Good morning. Can you hear me?
Yes, Dr. Korean.
And you can see the picture also. Thank you.
Yes.
It's a rare honor after so many years to be introduced by your classmate. Thanks, Hepsi. Thanks, Palniappan and team for a great show, as usual. And I appreciate the way you took your decision and said, we shall overcome. And you have overcome it. Full marks to you and your team for doing that, and to OGSI. The topic today for me is forceps delivery, safe yet not popular. Now, what happens whenever one thinks of the forceps? You think of this classic picture of peace and power. You see Lord Buddha with his peace emanating from every part of it, and on top of it, you see the tiger. This is typical of what happens when one does something with the forceps. In a moment, you go from peace to absolute chaos if you have any problem. This is possibly what all of you would see if you go around in future. The obstetric forceps died because you did not use it properly. Should we see this, or should we have some other option? Today, all the Star Wars fans think in terms of Star Wars and the power with it. The obstetrician, may the forceps be with you is the thought. May the forceps be with you. May you be able to use it. And should we overcome is what I leave it to you to decide in this coming lecture. So we all come across a picture where the head is too high, but it's just not coming down. Too high, I mean an engaged head. But it is too low for a cesarean section. At this situation, one has to think in terms of an instrument, which is essential to complete the delivery. So I think there is still a need for forceps. And historically, one of the early forceps was a smelly forceps. I initially used to think it was called smelly forceps because it must have been smelling. With all the grease on it and the leather patches and things on it, it must have been very dirty and smelly. But from there entered Chamberlain with their magic instruments, and they were very, very sort of cagey or secretive about their instrument, and went on doing their routine work with that. But remember that when the Chamberlains were working, that was an era of rickets. That was an era of malnourishment. And that was an era also of very great surgical morbidity. You had a very high mortality rate with the cesarean section. And so people had to do some other thing. From that time, we went to the time when they say that man midwives armed with rusty forceps shook up obstetrics. What exactly happened? Oops. Can you see the picture or no? You're able to see the picture?
Not yet, Dr. Kurian, not yet.
Not? Okay, sorry. Can you see now?
You can see, yeah.
Okay, sorry about that, yeah. So these male midwives, remember they were not doctors. They were not nurses either. They were usually barbers. And they were called to help doctors or nurses or midwives who could not pull the baby out. So these people used any method available with them to try and deliver the baby. Oops. Some problem with that. Just let me put it up again.
You want to go back or move forward, sir?
I want to go forward.
Okay, just you can use the arrow key, sir. As a arrow keys, forward arrow key.
You can see it?
Yeah.
Can you see the picture?
Yes, yes.
Okay, fine. One minute, let me just move these. Other things below are irritating me. Yeah, fine. So these male the midwives, as they would call it, they were totally criticized by groups of women's lib activators. They said the natural impatient that compelled men to use these infernal iron and steel instruments to unnaturally hasten a delivery by creating more havoc. So this was a time when everything was criticized. I was just wondering, if it had been women, would this still have happened? Because we must have had to get muscular women to do the same work, and that could have still happened. So forceps application is a lost art. If you see the incidents right now, in 2011, the UK reported 10 to 13%. If you go to the US, the forceps incidence has become so low, we talk of less than 1%. And another feature in the US is the incident varies from area to area. On the eastern seaboard, regions like New York, forceps is very little. But in the Midwest, which would be called the rural or the farmland, the forceps incidence goes higher up, maybe 2% and more. What about in India? A teaching hospital study says that the incidence was around 2.6%. In Pondicherry, a large study of around 5,445 deliveries, they had an instrument delivery of 7.7%, but the forceps was just less than about 2 or 3%. In our own hospital, we have a forceps rate which is just about around 1 to about 3%. This was around 3 years ago. So this is the picture at which we stand right now. All my fingers seem to be acting like thumbs, sadly. Okay. So do we still need to continue, or do we have to revive the art? If you see our deliveries in 2020, even in the COVID era, we had a forceps rate, we had a lower cesarean rate, but then even those numbers are very, very small. If we go on like this may be the only way to use a forceps in the labor room. We're not going to have any need to put it for the patient to deliver her. So the use of forceps has declined. Why has this happened? Your first problem is difficulty in decision making. How do we decide when to use it, and when we use it, will we have problems? The complications associated with it, and finally, today we are coming down to a picture where there is no way we can train a person to use it. But still remember, you may be the obstetrician in the labor room. There comes a time when the head is very low. The baby needs a little help and you don't have facility to do the section. That instrument may still come, and thereby that instrument is still going to be needed. The prerequisites for operative vaginal delivery are very well known to you, from the cervix, the membrane, the position of the head. But a very simple thing you should do, you will see your consultants doing it always, just palpate per abdomen and make sure that the head has gone in. An adequate pelvis, all those things, you're well known, I don't want to go into the detail. But your real dilemma comes when the criteria are only partly met. What if the cervix is 8 centimeters and there is problems of acute fetal distress? So this is the dilemma. You can also create your own checklist. A, B, C, anesthesia, adequate pelvis, the baby SS, bladder empty, the cervix dilated, cesarean if needed ready, and the consent obtained. Whatever it is, prepare well. When you're prepared, you've by then decided the type of operative vaginal delivery you're going to do, whether it's going to be an outlet, low, mid is rare now, and high we don't mention at all. So strictly speaking, an outlet or low forceps. Which forceps to use? Again, a dilemma. Many choices, nearly 700 types. Determine outlet, low or mid forceps. Practice with a standard pair. We are very used to using an axis traction forceps in our hospital for nearly 25 years. So many of our doctors are quite comfortable using it. But today, improved, smaller versions are available. Professor Piley's forceps are lighter, smaller, and equally effective. And they can even be used on a preterm head with ease. Axis traction forceps are useful if one is thinking of rotation. The steps of application: do the practice ghost application, assemble the forceps, because sometimes after you put it in, you'll find you've got different parts of different sets of forceps and they don't come together. Identify the blades, introduce it gently, get an assistant to help you, and repeat the thing on the opposite side. When you have applied it fully, confirm that the position is correct. But what are the indications for using an operative vaginal delivery? ACOG today recommends a prolonged second stage of labor, or if you have suspicion or immediate or potential fetal compromise, and shortening of the second stage for maternal benefit. But remember, all these are the indications. These are not absolute. And remember that all these are indications where cesarean delivery also is possible. So let's go into that a little more detail. When you talk of the prolonged second stage, maternal fetal conditions permit, we can keep waiting if other things are all right. With epidural, you can wait longer. There is no upper limit, provided the fetal well-being is monitored and the mother is keeping well hydrated. Evaluate and decide whether you would like to do an operative vaginal delivery versus expectant management. What about shortening the second stage? When we were studying, they would say it's all for the past fetal indications. But today, when we can monitor the fetus properly, we don't think of that at all. Today, evidence does not support the concept of doing a cesarean section or shortening the second stage for fetal indications if it is not indicated there. The role for shortening for maternal indications like heart disease and COPD, however, persists. And if there are sections, forceps being applied, it is more for the maternal reasons. What about fetal distress? Fetal compromise? If you have imminent fetal compromise, yes, indicated. Where the speed of delivery is important, again, well indicated. But remember, if delay is anticipated, if you think it's going to be a difficult forceps, then the cesarean section would be a better option. There are the contraindications, you're all familiar, most of them with fetal indications, especially fetal prematurity, demineralizing disease, etc. But the unengaged head or the unknown fetal position is a very, very important thing. Remember, there should be absolutely no confusion on the position of the fetal head. Today, sadly, digital examination is incorrect in approximately 20 to 40% of the cases, regardless of the person performing the examination. This is one of the major problems where our forceps applications are wrongly applied and create trouble. So what does Cochrane report? 32 studies on 6,597 women, forceps were more likely than Ventouse to achieve a vaginal birth. There were more cesarean sections in the forceps when it failed. There were more third and fourth degree tears and vaginal trauma. So this is the problem, and many people tend to prefer Ventouse when in doubt. Also remember that when you're using an operative vaginal delivery, the direction of traction in line with the birth canal may also include rotation, and this will help to improve your results. What about the strength used to apply? Early days, they would call 3 people to support the person who's pulling. Today, we have to be very careful with the strength we use. So this brings us to the most vital part of applying a forceps: when to give up.
Hello.
When it is difficult to apply, do not go ahead with it. Second, when you try 3 pulls or wait for 15 minutes and you find there is no progress, remember, 82% of forceps applied should deliver in that time. If it's not happening, don't do that. Next, do not persist if there is no descent. Neonatal morbidity increases 45%. 45% of the babies delivered, if you persist, have infant trauma. What about using another instrument? It's extremely tempting. use a forceps, get the head low down, then put the vacuum and deliver. It is definitely not recommended because the morbidity increases. But however, at times, people are still using it. The failed delivery incidence with forceps is around 9%, and with the ventouse is around 14%. So these were the words of Ian Donald many years ago when he wrote the Practical Obstetric Problem textbook. The trial of forceps is like lion taming. It is not a sort of exercise one would willingly undertake in the expectation of failure. That means if you think it's not going to be reasonably successful, don't attempt it. That's the very important message from Ian Donald. Complications, maternal fetal trauma, damage to the baby, severe problems can occur. But remember, follow-up evaluations of babies comparing outcome at school age after a forceps delivery. At about 5 years, when babies were evaluated, they found no differences in cognitive testing, suggesting that most of these babies did reasonably well. But today, the biggest problem we are facing is websites like this. Legal help for vacuum and forceps injuries. Free case review, available 24/7, and no fees until we win. This is the problem one has to face and putting us off. The perinatal morbidity and mortality after attempted operator vaginal delivery at mid-pelvic station, if it is dystocia, remember that cesarean would create more damage. But in fetal distress, the rates of severe perinatal morbidity and mortality were higher after sequential instrumentation than after cesarean section. So encouraging higher rates of operative vaginal delivery as a strategy to reduce cesarean section could result in increases in perinatal and maternal morbidity. So what can we do to improve the forceps? Today, we can better train using better simulators. You have lovely digital trainers which could help you to practice applying the forceps. Assess the strength used. Remember, when you sit, you use less force than when you stand. When you stand, you tend to use your whole body energy. Remember also that men, if they pull with both hands, are going to use energy which is far too much than what is needed. So can the forceps be improved in any other way? Today, if you ask me, the best option would be to use an ultrasound support to assess the fetal occiput, or as they call the forehead sign. Check the angle of progression. Make sure that the head has gone in. This will take off all the problems of your vaginal examination, creating trouble. But if in doubt, set definite guidelines in your labor room for attempts, progress, and if not, stop the procedure. Newer techniques could come. The Odon device was advertised, but at the moment, it is still not effective enough. So in conclusion, I'd like to say the forceps and the vacuum are good instruments to use, but use with caution, making sure that all the criteria are met. If in doubt, do cesarean section. If used like this, your forceps is safe, your results are good, and comparative with any other thing you do in the labor room. There is room for technical improvement, like a smaller, lighter forceps with better material may improve the way we do our forceps. The dilemma remains, however, how would you get familiar and use an instrument when it is hardly used? And that I can't find any answer for. But as you're using a forceps, do not let your ego take over. Do not say that I must apply and deliver it by forceps. If you can't, in doubt, just change your decision and complete the cesarean section. I could take care for cesarean section. Thank you very much. Thank you, Palni, and thank you, OGSSICON.
Thank you, Dr. Priyan. As usual, the keynote address was very excellent. We know the forceps delivery people have got to learn. They got to choose the selection, correct case selection, counseling, the correct instrument, and the good execution and aftercare. And documentation is important. As you said, the intrapartum USG will help for more people to choose a forceps when it's needed. Thank you.
Thank you.
Thank you, sir.
Kishore, there will be a plaque. Sir, this plaque is for you. We'll see that it reaches you, sir. And Madhuri ma'am, please read the plaque, ma'am.
OGSSICON 2020 International Online Conference, 27th, 28th, and 29th August 2021. Appreciation Award presented to Dr. Kurian Joseph for delivering the keynote address on 28th August 2021. It's well deserved, and I thank all of you. I thank Dr. Palaniappan and the team on my behalf and the co-chairpersons for giving us an opportunity. Thank you and good luck.
Thank you, Palani.
Thank you, sir. I'm sure we'll see that it will reach you soon, sir. And the advantage is we are in Chennai, so I'll take it as a privilege to come and give it to you, sir.
Yeah, you can send it to me by courier.
And to all the faculty of this session, there will be questions posted in the chat box. For want of time, if you can kindly answer the questions in the chat box, it will be helpful. Kishore, kindly post the questions here. Thank you.
Thank you, Dr. Palaniappan. One more time.
Thank you, Murali. Thank you very much for staying. Please take the questions.
Sure, I will answer them.
Yeah, we'll move on to the next session.
Yeah.
Now I welcome the next chairperson, Dr. Vidya. She's a professor and a unit head in Amin Medical College. She is
sorry to interrupt.
Yes, ma'am.
A very sincere thanks to the chairpersons of the previous session, Dr. Madhini ma'am, Dr. Hepzibah ma'am. Thank you so much, madam. So, sorry, Akila, continue.
No issues. So I welcome our next chairperson, Dr. Vidya. She's a professor and unit head in Amin Medical College. Adam has got a rich teaching experience of 3 decades. She shows interest in serving the society and has academic contributions to national and international affairs. Next, please. Our next chairperson is Dr. Anuradha, who is at present the head of the department in Chettinad Medical College and Research Center. She has served in Tamil Nadu Medical Service for more than 2 decades. She has teaching experience. Adam has started winning her awards right from the beginning of the career. Next speaker is Dr. Veni. Madam has got 32 years of experience in Tamil Nadu Medical Services. She's presented papers in national and international conferences, contributes to the community in her work in adolescent health education, cancer screening services, and yoga and exercise. Now, Madam is a consultant in obstetrics and gynecology in Apollo. Madam, over to you, Madam, to introduce the next postgraduate.
Thank you very much for the introducing us. And I really thank OGSSICON, Team OGSSICON, and especially Dr. Palaniappan for inviting us. And it was a really wonderful experience for joining us. Can I have the first session, first speaker, yes or no speaker? Can I have her?
Yeah, it's already there.
Yeah.
Dr. Vidya, this is the first speaker. Hello.
Okay. This is changed. Okay. I'm very glad to introduce Dr. M. Sangeeta Janani, who is a 3rd year postgraduate student from RM line in Hospital Stanley Medical College. And she will be talking on innovation in electronic fetal monitoring.
Yes, ma'am. Good morning, one and all.
Yes.
Shall I talk, ma'am?
Yeah, definitely. Why not?
Can I have the presentation, please?
Share your presentation.
Good morning, one and all. Now I'm going to talk about the recent innovations in electronic fetal monitoring. For decades, CTG is the gold standard for fetal monitoring during labor and is used globally on a daily basis. The interpretation of CTG traces proves challenging, and many inter and intra-observer variation is present for the same CTG trace. Next slide. It appears that continuous use of CTG in the current form significantly reduces the risk of neonatal seizures, although it doesn't decrease the risk of fetal hypoxia and acidosis. It is also associated with significantly higher rates of cesarean section and instrumental deliveries. The existing observer variability in CTG can be minimized by use of artificial intelligence and electronic algorithms implanted in expert systems. Expert system is nothing but a group of experts give their opinion on with a knowledge engineer, will work with a knowledge engineer to create an interface which will be useful for a user who may not be an expert in that subject. So the expert system has high efficiency and it is expertise in a domain, no memory limitations, high security, and it considers all facts. Next slide. Expert system is an applied artificial intelligence designed to assist in complex decision making. It synthesizes a computerized knowledge base derived from expert opinion with individual patient data to guide users towards possible diagnosis and treatment decisions. So the expert system used is a Nexus obstetric system. It uses 3 CTG domains, which consist of fetal heart rate, that is the FRQ, which is the fetal heart rate, and the decelerations is DEC, and the third one is micro fluctuations, which is the baseline variability. If the CTG tracing is there is scoring based on these 3 domains, and the scores range from 0 to 6. The lowest will be 0 and the highest will be 18. The lowest 0 is normal and 18 is abnormal. Based on the findings, the QCTG algorithm, it calculates the predicted pH value of the which are updated every 5 minutes. Next slide, please. This is the interface. We can see the fetal heart rate, and this is in the right corner, we can see the predicted pH value of the baby. Using the average of the last 6 pH values, we can, without fetal blood sampling, we can predict the pH value of the baby. Next slide. Next innovation is a fetal electrocardiography. The fetal ECG, like the adult ECG, displays PQRST waves corresponding to the electrical events in the heart during each heartbeat. The P wave represents atrial contraction, QRS ventricular depolarization, and T wave ventricular repolarization. Repolarization of myocardial cell is very sensitive to hypoxia and metabolic dysfunction and gets reflected in the ST changes in ST waveform. To obtain fetal ECG, there are both methods, invasive method and non-invasive method. Invasive method, we use fetal scalp electrode using stand monitor, and non-invasive method using abdominal electrodes such as Monica AN24. Next slide. Stand monitor was introduced at Nine Wells Hospital, Dundee in October 2007. Stand is nothing but ST analysis, which is an adjunct to CTG. It combines CTG monitoring with concurrent assessment of fetal ECG. The STAN software analyzes the average waveform of fetal ECG over 30 consecutive heartbeats. It then compares this waveform with the average of subsequent 30 complexes. By doing it so, it is able to determine the ST segment and T changes over time and alerts the user by signaling occurrence of a STAN event. There are 2 electrodes. One electrode is kept in the maternal inner thigh and other electrode is placed on the fetal scalp. This is the actual picture. Next slide. The waves will be like in this form. There is what are we saying in the ECG is T wave, the amplitude of the T wave. We are going to see the rise in T wave amplitude or a fall in T wave amplitude and the biphasic ST segment. Next slide. In normoxia, TQRS waves, the amplitude of the T wave is corresponding to QRS is 0 to 0.25. In hypoxia, the amplitude of the T wave will increase and it will be displayed in the interface. Next slide. We can see the ST changes here. The event log is given here. Baseline TQRS rise is there and episodic TQRS rise is also there. Depending on the TQRS rise and biphasic ST changes, they have given guidelines for intervention. Next slide. So before starting stand monitoring, we have to consider the following categories. It should be a term gestation. The membrane should be ruptured before placing the fetal scalp electrode, and the baby should not be already hypoxic. If the baby is already hypoxic, the stand monitor cannot identify the changes in ST and T waves. After starting, the normal ECG waveform should be obtained with sufficient signal quality, and the event log message baseline of the events is measured, and then we have to classify the FHR. Next slide. So the CTG is first, it is an adjunct to a CTG and not an alternative to CTG. Normal CTG includes a baseline of 110 to 150 beats per minute with a variability of 5 to 25 beats and no decelerations or early uniform decelerations. An intermediary CTG baseline is 100 to 110 or above 150 with the short bradycardia episodes, and the variability is more than 25 beats per minute. So, and an abnormal CTG includes heart rate of 150-170 beats per minute with less than 5 beats per minute variability and sinusoidal pattern. And pre-terminal CTG where there is no total lack of variability and reactivity without decelerations or bradycardia. Next slide. Along with this, we have to see the episodic TQRS rise. In an intermediary CTG, if there is episodic TQRS rise more than the amplitude more than 0.15 or an abnormal CTG more than 0.10 or in a pre-terminal CTG, it is immediate delivery. Baseline TQRS rise, the episodic TQRS rise indicates that the baby has started to utilize anaerobic metabolism but has recovered from it. Baseline TQRS rise indicates that the fetus is continuously using the anaerobic metabolism for compensation, and the biphasic ST indicates that the baby cannot respond to hypoxia or doesn't have enough time to respond to hypoxia. Next slide. The Cochrane review of fetal ECG for fetal monitoring during labor, conducted in 2013 involving 15,000 women in 5 trials, showed fewer fetal scalp sampling and fewer operative vaginal deliveries and fewer severe metabolic fetal acidosis. But there is no significant difference in cesarean section or neonatal encephalopathy and low UPGAR. The NICE guidelines on intrapartum care does not currently recommend the use of STAN. The contraindications for STAN usage are maternal bloodborne infections and suspicion of any fetal bleeding disorder and an already hypoxic fetus, that is loss of baseline variability. Monica AN24, it is the first fetal heart rate monitor using non-invasive fetal ECG technology. It is commercially available wireless fetal monitoring device that allows remote non-invasive transabdominal monitoring of fetal heart activity, uterine electrical activity and maternal heart rate in real time. It is approved by FDA in 2011. It collects fetal ECG data from 5 electrodes placed on the laboring mother's abdomen. The ECG electrodes are placed on the maternal abdomen. It monitors the fetal ECG, maternal ECG, and uterine electromyography, and a powerful internal processor extracts in real time the fetal heart rate, maternal heart rate, and umbilical artery waveform validated against fetal scalp electrodes. A CTG interface device for AN24 connects it via Bluetooth, receiving all data from the Monica AN24 worn by the pregnant woman. It is useful in abroad where home induction has emerged as an increasingly popular alternative to labor induction in hospital settings. The key negative factors in hospitals are the lack of comfort, privacy, and flexibility. The outpatient induction has shown to increase maternal satisfaction. The home environment is private, familiar, thus increases control. This is the Monica AN24. The abdomen electrodes are placed on the abdomen while the mother can wear the interface, wear the device, and the device will transmit the data via Bluetooth to the computer in the labor ward. The abdominal electrodes are placed in this procedure. Slide.
Geeta, your time is winding, Sangeeta.
Yeah.
I'm going to come.
I was about to tell her that.
Previously.
Immediately, thank you. Okay. Anyway, you have covered everything, and I just want to mention that there are many Indian equipments also in the market for the remote things. But what you should know is whatever we are talking about the electronic fetal monitoring, there is a clear consensus that this monitoring, when accompanied by other normal Apgar scores or normal umbilical artery blood gas analysis, which is inconsistent with an acute intrapartum hypoxic ischemic event many times. And sometimes they also say that many false positive results are there. So what is your opinion about that?
Yes, ma'am. In the
Madam, discussion we will have at the end, madam.
And these people should not leave then, because that continuity will go. Only one question I'll ask and we'll finish it off. This is what she has to answer. That's all. Palani.
It is an ongoing study, ma'am, that by using, by predicting the pH value using that algorithm and all, it is not used, it is not shown to reduce any fetal acidosis, ma'am. And the values are different from fetal blood sampling and the pH value shown in the interface. But it is an ongoing study, ma'am. There is considerable variation, ma'am.
Yeah. Thank you very much. Thank you.
Thank you.
We'll go for the next speaker and next chairperson. Thank you very much, Dr. Palani.
Good afternoon. Shall I introduce the next speaker? Good afternoon to one and all. At the outset, I would like to thank the organizers for giving me the opportunity. Dr. M. Sivasundari, she is professor of OBG in Savita Medical College and gold medalist and best outgoing MBBS student, and she has won many paper awards, oncology, AACOG, national chess, and she has many publications in national and international magazines. Now over to Dr. Sundari.
Thank you, ma'am. It's an honor to be introduced by my teacher. I'll share my screen, ma'am. Kishore, can you?
You need to.
Yeah. Can you project the thing? I'm not able to share the screen.
Okay. I'll.
Shall I cancel it so that you can? Thank you. Previous slide, please. Previous slide. Yeah. The next one. I thank Professor Palaniappan sir for giving me the topic fundal pressure during labor. Always Naradar Kalagam Nanmeke and Narada's good deeds end in goodwill. Fundal pressure, as we all know, it is always called as crystallis maneuver. Fundal pressure during labor is one of the most controversial, underreported, understudied topic in the world, even though it is got silent practice throughout the world. The next slide, please.
Sorry?
Yeah, the following questions came into my mind when the study was given. Okay, so the history, what is the history?
Concentration.
Previous slide, please. Previous one. Yeah, so what is the real prevalence and what is the physiology behind the normal labor? When applying fundal pressure, is it physiological or pathological? And what are the indications of fundal pressure? And do we have any modifications in application of fundal pressure? What are the real complications and what does evidence say? The next slide, please. Okay, the history behind the fundal pressure. Previously, so many centuries before the vacuum, before the oxytocin, forceps, the women were tied to ropes, then they were made to hang with weights, they were pulled and pushed. In modern obstetrics, we don't support all those barbaric acts. So what happens to fundal pressure in 2021 COVID era? Next slide, please. So what is the prevalence? What is the truth? There are 80, this is a recent publication in 2021, 80 data sets from 76 studies, including 8,98,544 women were studied, including India. This was reporting data from 22 countries. The prevalence of fundal pressure ranged from 0.6 to 69.2% between the studies. The highest prevalence was noted in low resource countries with a pool prevalence of 23.2%. It studied regarding the prevalence, the previous one, please. When I tell the next one, please change it. The prevalence of uterine fundal pressure during the second stage of labor for women. Okay, this is a recent publication in 2021. The next slide, please. Okay, so can you press 1? So whatever data, the thing, I couldn't find a definition in any of the standard textbook of obstetrics, including how it is to be given, how often it has to be given, how frequently it is given. Okay, what is fundal pressure? It is a manual pressure which is applied to the uppermost part of the uterus in the direction of the birth canal to assist spontaneous vaginal birth in order to avoid prolonged second stage operative birth, including the cesarean birth. The next one, please. The next slide, please. Yeah. So thanks to Professor Ajit Burkud for the wonderful concepts. Okay, according to second Newton's law, to move a mass, we require a force. So what has God has given? There are two forces, primary force and the secondary force. The primary force is with the help of the uterine contractions. The secondary force in directive pushing is with the help of Valsalva maneuver, in which the mother raises her respiratory efforts against the closed epiglottis so that it causes voluntary contraction of her external abdominal muscles, which helps in vaginal delivery. The next slide, please. So this tertiary force, the so-called fundal pressure, which is followed through centuries, what happens? The force, it presses the fetal head against the bony part. At the same time, the major blood vessels, including the aorta, can get compressed, which can compromise the blood flow to the baby, which can result in hypoxia. So can we consider this as physiological? No. The next slide, please. So what is fundal pressure during cesarean section? It is a different ball game. Here, an incision is already made and the head is already in line with the incision, and application of the fundal pressure is only for brief duration. What does evidence say? Application of brief fundal pressure during cesarean section, even though it produced a reduction in the cardiac preload and the heart rate, it doesn't compromise the maternal and fetal well-being. The next slide, please. So is fundal pressure associated with complications? So shoulder dystocia, a big yes. Cervical tears, yes. Perineal tears, yes. Has ever been a case reported regarding inversion of uterus or rupture of uterus? The answer is yes. Does the mother have pain and psychological trauma? Big yes. Do we have evidence to substantiate it? Again, a big yes. The next slide, please. So the aim of care in labor is a healthy mother and baby and fulfilling emotional experience. The next one, please. So when I searched for the literature, I could find 4 Cochrane review and 33 trials. And for want of time, I'll be quoting only important studies. The next one, please. The next one, please. Yeah. So do we have Indian studies? I could find 2 Indian studies. This is a study which is done along with collaboration of WHO in rural Rajasthan. It studied the childbirth practices and its implications for neonatal health and services. 18 women were included and some questionnaire were asked, and 8 women were directly observed during birth. And fundal pressure was noted in nearly 97% of the women. 3 methods were used. One, the arm was hung over the mother's abdomen. The second method, knee was kept over the mother's abdomen. And when it was applied by health worker, they used to stand on the footstool and give the fundal pressure. And in few women, right, for 3 out of 18 women, 50 to 180 times of fundal pressure was used. And one case, baby fell 1 foot away during delivery. And one case, they observed the fundal pressure given at 2 to 3 centimeters. And both the cases were have to be shifted to tertiary care center for cervical tears and traumatic PPH. It was like seeing a horror movie when I went through this article. So this is again a famous study which is included in the famous systemic review by Hofmeier. It was done in a medical institute in which 209 women were recruited. Half were given fundal pressure and half didn't receive fundal pressure. They observed no significant reduction in the duration of second stage of labor. But at the same time, interestingly, and there was no significant difference between the Apgar score between the two groups. But 6% had extension of episiotomy versus 1% couldn't receive fundal pressure. Pain requiring analgesics was noticed in 33% of the women who had to have fundal pressure versus 6%. The 6% required mild analgesics like paracetamol. The next slide, please. Okay, so do we have any systemic reviews? This is a famous systemic review by Hofmeier, and which was published in 2017. They studied 5 trials, including 3,057 women who received manual fundal pressure versus no fundal pressure. And 4 trials, they compared between the inflatable belt was used to give fundal pressure versus no fundal pressure, and the maternal and fetal well-being were studied. Next slide, please. Yeah, the fundal pressure. So what did they conclude? Fundal pressure is not associated with changes in the duration of second stage of labor, instrumental birth, cesarean birth. And interestingly, there was no significant difference between the card arterial pH between the groups or the Apgar score less than 7 at 5 minutes. And they noticed cervical tears were more in women who received fundal pressure with a risk ratio of 4.90. The next one, please. So what do they conclude? There is insufficient evidence to draw conclusions on the beneficial or the harmful effects of fundal pressure, either manually or by inflatable belt. There is no evidence on the use of fundal pressure in specific clinical settings, such as inability of the mother to bear down due to exhaustion or unconsciousness. There is currently insufficient evidence for the routine use of fundal pressure by any method on women in the second stage of labor. The last few slides. The next slide, please. The next one, please. Yeah. So do we have modifications? Again, it is a famous study done by Hofmeier. It is a 3-arm open label randomized controlled trial, which was done in South Africa. The next slide, please. Okay, here they gave gentle assisted pushing, but the woman was delivering in the upright posture. A trained personnel would give the fundal pressure by hanging her arm over the mother's abdomen, maximum 3 times, not exceeding 30 seconds when the mother starts pushing. The next method is by inflatable belt. It was devised in South Korea, where 200 mm of air pressure will be given, maximum of 7 times in 15 minutes, and not exceeding 30 seconds each time. So what was their conclusion? The next one, please. That is currently, again, they concluded by saying there is no benefit was identified from gentle assisted pushing the second stage. Some women found the position uncomfortable. With the inflatable belt, even though it caused a slight reduction in the duration of the second stage of labor, many of the women felt it very uncomfortable. The use of fundal pressure should be limited to further research to determine techniques or settings in which it can safely assist vaginal birth. The next one, please. Okay, so I thought I would conduct a mini poll. My simple question was, fundal pressure, do you apply in second stage labor? Yes or no? Can you click it so that I can have the results? One click, please. Kishore? One click. Okay. So 90 obstetricians participated. I thank every one of them. And nearly 91.11% they said no. The remaining, they said, occasionally they will give a gentle abdominal pressure by bringing the uterus to the center line. And when the woman is really exhausted and the head was crowning, they would apply a very gentle pressure before resorting to instrumental delivery. So what about me? A small story, it will take hardly 2 seconds. When I entered my post-graduation, first of the few deliveries, third gravida, she said, "Amukka poriya illaya." Then I realized my mother also got a promise that I should not scold any laboring women. So I started giving fundal pressure. Okay, in fact, it ended up giving fundal pressure to my mother even in my sleep. Luckily, nothing happened. But over the past 2 decades, okay, the undoing was very, very difficult for me. Now my answer will be no for routine fundal pressure during second stage of labor. The next slide, please. So there is insufficient evidence for the use of fundal pressure in labor. There is no justifiable use of fundal pressure in modern obstetrics. The next slide, please. This is a famous quote which I adore the most. Yesterday's research is today's treatment, and today's research is tomorrow's treatment by late Shanta Madam. And so can we just abandon the century-old fundal pressure during labor? We require more research to find out, to substantiate the benefits of fundal pressure, how it has to be applied, how frequently it has to be applied, and when it has to be applied. So we require more research to substantiate its beneficial efforts. Next slide, please. I thank my alma mater for teaching me how to respect the laboring women. Thank you, Oxy team, for the wonderful opportunity.
Thank you, Sriti. It's a very good presentation, excellent presentation.
Thank you. Thank you, ma'am.
And yes, of course, this topic itself is out of blue, I should say. Are we giving this fundal pressure nowadays? Definitely no. Working in a teaching hospital, a tertiary center, government hospital for more than 30 years, I know many cases are referred as a rupture uterus. The main cause of rupture uterus is fundal pressure. Because especially in the periphery, rural area, those midwives, they don't know when to stop. When I used to inquire, they say they have been giving fundal pressure for more than 45 minutes or 1 hour. It's really barbarous. Yes, I totally agree with you. There is no place, I will say, for fundal pressure at all. If there is a delay, you pull from below. You either apply forceps or right, never push from above.
Now we have kiwi cups also, so
yes. Yeah. Okay, thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you.
Shall I introduce who? Dr. Veni. Dr. Veni, please unmute.
I invite Dr. Rajdev to give a talk on decreased fetal movement count as an indicator of fetal ill-being. Over to Rajdev.
Oh. Thank you, ma'am. Can I share my screen? Are you able to see? Hello?
Yes.
Yes, Rashmi, go on.
Yeah, thank you. Good afternoon, one and all. I thank Oxy, particularly Dr. Palaniappan, for giving me this opportunity. Traditionally, for both pregnant women and her obstetrician, presence of good fetal movement definitely reassures a fetal well-being. Thus, decreased fetal movement indicate fetal well-being. Let us look at what evidence says. How do we assess fetal well-being or ill-being? We have a subjective assessment where the pregnant woman counts the fetal movement, or also called as a kick count, and we have the objective assessment by cardiotocography and ultrasonography. What is the basis of fetal movement count? A normal quantity and quality of fetal movement confirms the functional integrity of the fetal regulatory system as well as adequate oxygenation. When there is mild hypoxemia, there is a compensatory fetal behavioral response, and the fetus, there is a decreased fetal movement, and thereby the fetus conserves its energy. And the compensatory physiological response will be redistribution of blood flow to the essential organs. When the hypoxemia is severe and prolonged, these compensatory responses will fail, and it results in organ damage and death. Therefore, intrauterine fetal demise is commonly preceded by a reduction of perceived fetal movements for some days. This led to the concept of monitoring fetal movements to detect a deterioration in the condition of the fetus. What are the advantages of the fetal movement count? It is a low-cost, low-tech method. You don't have to invest on it. You don't have to be illiterate. Anybody can count the fetal movement. It can be repeated several times in a single day, as many times as the mother wants. And it also improves the maternal-fetal bonding. Will it waste the obstetrician's time? Will it increase the prenatal visit? The answer is no. Only 4 to 15% of pregnant women will contact their care provider because of persistent decreased fetal movement in the third trimester. Then, what is the confusion surrounding the use of the fetal movement count? First is, how do pregnant women assess the fetal movements? What method do they use? Second, when do they report following a decreased fetal movements? And third, how, as care providers, how do we evaluate women who report with decreased fetal movement? First question, there is no universally accepted method to assess the decreased fetal movement. That is, first is the quantitative alarm method, wherein the fetal movement counting is done with different alarm limits. Say a fixed time or a fixed number of movements, count to 10 in 2 hours of rest, 10 fetal movements in 12 hours of normal maternal activity, or 4 fetal movements at rest when focused on counting for 1 hour. The last one is preferred by working women. The next is the qualitative perception of fetal movements. With this method, there are 2 pitfalls. One, there are biological variation in movements even among healthy fetuses. That is, their diurnal changes. We all know that the fetus kicks well between 9 p.m. and 1 a.m. in the morning. And the fetus has its own sleep cycles, which may last from 20 to 40 minutes and may even extend up to 90 minutes. And we know that the fetal movement increases with gestational age and it decreases when mother is on medications like sedatives or with maternal smoking. Another pitfall is a variation in the maternal perception of fetal movements. So the perception can vary with maternal posture or position. It's maximum when she's in lying posture, little lesser in sitting position, and it is least in the standing position. The perception is also reduced with reduced amniotic fluid, anterior position of the fetal spine, anterior placenta. Physical activity also, physical activity, the mother perceives less of movement, and when she's mentally distracted, also the perception is less. So what does evidence say about assessment of decreased fetal movements? A maternal concern of decreased fetal movements overrides any definition of decreased fetal movement based on numbers of fetal movements. So when a mother says she's concerned about movements, she needs to report and we need to evaluate. There is no, it overrides any definition of numbers. Next, when does a pregnant woman report following diminished fetal movement? Women with concern about diminished fetal movement should contact their healthcare provider immediately. There's no question of waiting. I will wait till tomorrow morning. The woman should be told to report immediately to the healthcare providers. The next question is, how do we evaluate a woman who reports with diminished fetal movements? Studies in Norway have shown that inappropriate response to maternal perception of diminished fetal movement and suboptimal care by the healthcare providers accounted for 30 to 50% of stillbirths and neonatal death. Therefore, we should have a protocol to evaluate these women when they come in, and the evaluation has to be done immediately. The first thing is to have a clear history, including the risk factors for stillbirth, and confirm the presence of decreased fetal movement. The next step is to do a clinical examination, check her pulse, blood pressure, and then do an examination, look for uterine tenderness, feel the symphysis, look for the symphysis fundal height to see if there is any FTR and SGA, and then finally listen to the fetal heartbeat and L-Doppler. Once the presence of fetal heartbeat is concerned, the fetus is viable when it is confirmed, then we have to proceed with a cardiotocography, perform at least 20 minutes or until satisfactory. Do not forget to use maternal fetal movement recorder. If the NST is reactive and the mother starts feeling fetal movements, we are done. If there is confusion, if it is not reactive, the mother still says that she's not able to feel fetal movements, then we proceed with ultrasound to do amniotic fluid volume, biometry, and placental fetal Dopplers as indicated, as also a biophysical profile. Now, let us look at the association between decreased fetal movements and stillbirth. In a prospective population-based study in Norway, fetal death rate in women who presented with decreased fetal movement was 8.2 per thousand compared to 2.9 per thousand in the general obstetric population. In another case-controlled study from England, a perception of fetal movements 2 weeks prior to stillbirth was evaluated. Decreased fetal movement increased the risk of stillbirth, and an increasing strength of fetal movement resulted in decreased risk of stillbirth. So while we are about to say yes, it does increase the stillbirth rate, came this trial in a 2020 meta-analysis of 5 RCTs comparing pregnancy outcome in women who received counseling about fetal movement count versus those who did not. The incidence of perinatal death was same in both the groups. But this meta-analysis was dominated by a single cluster randomized trial, the AFFIRM trial, where the number of pregnancies involved was 385,552 pregnancies. The criticism of this trial is that this trial is done in Scotland, in a country where the baseline stillbirth rate was extremely low. And therefore, fetal movement count may not have made an impact and could not reduce the stillbirth rate still further. For any tool to be effective, it should be given a chance at a place where the prevalence of that particular incidence is more. In a country like India, where the stillbirth rate is high, fetal movement count will still make an impact in reducing the stillbirth rate. The next thing is association between the decreased fetal movements and fetal growth restriction. A case-controlled study from the UK reported that fetal growth restriction was present in 11% of women with decreased fetal movement compared with 0% in the control group. And another case-controlled study from Australia found that among pregnant women in the 3rd trimester who reported the decreased fetal movement, 16% had a baby with FGR. Therefore, fetal growth restriction appears to be a major factor contributing to adverse outcomes in pregnancies with decreased fetal movement. Finally, adverse pregnancy outcomes in women with decreased fetal movements in the 3rd trimester at a tertiary Australian centre with clear clinical management algorithm. And in a cohort study of more than 100,000 women, decreased fetal movement was significantly associated with small for gestational age, planned early term birth, operative birth, and a composite of adverse perinatal outcomes, including in ICU admissions, severe acidosis, 5-minute AFGAR score of less than 4, and stillbirth or neonatal death. To conclude, persistent decreased fetal movement is often associated with an ill or vulnerable fetus, and when ignored, can result in an adverse perinatal outcome. Just as we say a reactive NST is reassuring, and with a non-reactive assuring, it does not always mean a fetal distress. So we need to evaluate a woman who reports with a persistent decreased fetal movement further. We cannot ignore her, and we should have a clear protocol of evaluating her, and the evaluation must start immediately without delay. Thank you.
Sir? Am I audible?
Thank you, Rashmi. That was wonderful, and wanted to congratulate you on that. You were above the expectations of what I wanted you to talk to, and thank you very much. With that, let me just introduce the next speaker, Dr. Niranjana. Dr. Niranjana is a fellow in gynecological endoscopy, Joseph's recent free paper sessions, and Dr. Niranjana will be speaking to us and telling us whether low molecular weight heparin for APLA patient, APLA negative patients, would you still give or would you not give, yes or no? Over to you, Niranjana.
Thank you, sir, for the kind introduction. And thank you, Dr. Palaniappan, sir, and Team Oxy for giving me an opportunity to be a part of this conference. So the topic given to me in this session is low molecular weight heparin for APLA negative patients, yes or no? This is a very common dilemma which we all encounter, and I hope by the end of this session, I'm able to find a definite answer to this question. Going with the basics, recurrent pregnancy loss is defined as 3 or more consecutive miscarriages less than 20 weeks of gestational age. But the recent X-ray guideline also offers us to evaluate when the patient is having 2 or more miscarriages to improve the clinical research and to give a better outcome. There are varied reasons for recurrent pregnancy loss, from anatomical causes, thrombophilic causes, immune causes, but about 50% of the cases have no identified cause. So when a woman comes to us with recurrent abortions, there are various investigations we advise, but one common investigation we advise her for is the antiphospholipid antibodies. These antibodies can cause venous or arterial thrombosis, and they are also associated with pregnancy loss in terms of recurrent pregnancy loss, a UGR, or an early onset preeclampsia. So they are diagnosed by using the Separo criteria, and once a woman is diagnosed as APLA positive, guidelines recommend us to use prophylactic low molecular weight heparin or aspirin or a therapeutic dose depending on her criteria. But what do we do when the woman is APLA negative? There are no standard guidelines in those cases. Extrapolating this same mechanism, pregnancy is a procoagulant state. There's increase in the thrombogenic factors, and the increased thrombosis can lead to late or early miscarriage, preeclampsia, placental abruption, fetal growth restriction, intrauterine death, or stillbirth. So what happens in these conditions is that in the early pregnancy, small placental vessels undergo thrombosis. And this thrombosis, these vessels have not undergone remodeling. So it leads to partial or total occlusion of both the arterial and venous supply and ends in the loss of nutrition, leading to fetal compromise. So if we are going to counter this, we are going to address this occlusion. And to prevent a thrombosis, the drug we go to is an anticoagulant. So the anticoagulant which we are going to discuss in this session is a low molecular weight heparin. Heparin, a well-known anticoagulant, has a molecular weight of 5,000 to 40,000 Daltons. Low molecular weight heparin, as the name suggests, has a molecular weight of only 8,000 Daltons. Why it is preferred over an unfractionated heparin is that it has a predictable effect, it doesn't cause significant side effects, and doesn't require extensive monitoring. There are various types of low molecular weight heparin available, and the commonest forms which we use are enoxaparin or dalteparin. So what is the mechanism of action when concerned with the low molecular weight heparin is that coagulation cascade, that is one clotting factor activates another factor and ends in thrombosis. So in the coagulation cascade, the heparin inhibits the factor 10A and factor thrombin and inhibits formation of thrombus. Whereas a low molecular weight heparin inhibits only the factor 10A and doesn't interfere with thrombin. So what does it do in terms of pregnancy? In terms of pregnancy, it has a specific action on the placenta. It acts on the trophoblast endometrial interface and alters the chemokines and molecular receptors. Decidua of women with recurrent pregnancy loss have shown to have necrosis, features of acute or chronic inflammation, and so it has been thought that the anti-inflammatory action of heparin can counter these effects. Excuse me, sir, just a minute. I'm sorry about the interruption, sir. So The heparin also has an anti-complementary effect, immunomodulatory action. It also has improves the embryonic implantation. That is, it interferes with adhesion molecules, matrix degrading enzymes, improves the endometrial receptivity, increases the trophoblast invasion. This is thought to be the mechanism by which heparin usage in IVF pregnancy improves the implantation and the clinical pregnancy rate. So when you think of these mechanisms of action, the usage goes into deep vein thrombosis, pulmonary embolism, myocardial infarction, IVF pregnancy and thromboprophylaxis, and the main use which is in question now, recurrent pregnancy loss. So this takes us back to the question we started with. Do we use it for women with APLA negative? So we'll try to answer the question by looking at various reports and studies that have been done with low molecular weight heparin. The study in 2008 used the drug and found usage of low molecular weight heparin brought about a significant reduction in both early and late miscarriages. Another study in 2013 used low molecular weight heparin for women with implantation failure and found the usage improved the live birth rate by about 79%. This amount is thought to be significant, and so the drug is being recommended as per the study. Another study in 2014 showed the decrease in the abortion rate, improvement in the live birth rate. However, they reported that there is no change in terms of pregnancy complications or obstetric complications like preeclampsia, IUGR. They documented no evidence of heparin-induced thrombocytopenia. There was no congenital bleeding, proving the safety of the drug for both the mother and the fetus. Another study in 2020. Here they analyzed the effect on uterine artery blood flow and found it reduces the resistance and maintains the perfusion. This continuous perfusion ensures continuous blood flow. We already saw that when there's a stoppage of the blood flow, that leads to fetal compromise. With continuous blood flow, there can be a fall in the spontaneous abortions, which was reflected in this study and made a recommendation for heparin. Another study analyzed various studies, and they reported that usage of heparin in all studies reported with an improved live birth rate. However, they couldn't find any difference in terms of complications like preeclampsia, growth restriction. Also, they didn't document any adverse drug reaction. So based on the risk-benefit ratio, they suggested low molecular weight heparin can be preferred to improve the pregnancy outcome. This very recent analysis in February 2021 also documented the same. They said it improved the clinical pregnancy rate and implantation rate, but it did not have a role in the live birth rate. Any drug is going to have advantages and disadvantages. Likewise, there are various studies that have also advised against the use of low molecular weight heparin. So let's look at those studies for now. So this study compared aspirin and heparin and found that injection site reactions was found in 40% individuals, and usage of low molecular weight heparin with aspirin led to increased bleeding. There was no significant benefit in terms of pregnancy or obstetric complications. And so they recommended there is no role for anticoagulants in unexplained RPF. Another study used the low molecular weight heparin in about 14 university hospitals. They compared dalteparin with multivitamins and found that there was no difference in terms of viable pregnancy rate or live birth rate between heparin or controls. The ESHRE guideline again suggested there is no role for heparin in unexplained RPL. When a patient is presenting with RPL, the only indication for usage of heparin or aspirin as per this guideline is only presence of antiphospholipid antibodies. However, this recent study in 2019, they used 818 women with low molecular weight heparin. They stratified them into different groups. They found that group A, women with history of VTE, required thromboprophylaxis as per guidelines. Women with group B, that is, they were given heparin to prevent gestational vascular complications. This was not by any guideline, but when they gave this drug, they found that they had a 99% live birth rate with only a 0.7% fetal loss. And when they used it for IVF, optimizing the IVF outcome, again, they reported there was an increase in the clinical pregnancy rate. They also reported 1 injection site allergy and 1.6% of clinically relevant non-major bleeding. So they summarized this saying that the sample size was only 818, and this improved outcome could be because heparin countered some undiagnosed antibodies. Because RPL, as I said earlier, there is 50% cases where the cause is not known. So they thought that it could have countered some undiagnosed antibodies or some very low level of antiphospholipid antibodies, which led to the improved outcome. This guideline, they said that low molecular weight heparin is being used unscrupulously, but they did not give a recommendation for using the drug. They said it needs to be evaluated further before deciding if it is causing the significant effect or not. So comparing all these studies, There have been studies which showed improved live birth rate, better clinical pregnancy rate, and reduced abortion rate. But the problem is not all studies gave us the same report. Different studies gave us different reports, and so we don't know the effect if it was completely due to low molecular weight heparin. On the other hand, the guidelines issued by ESHRE, RCOG, or ASRM do not recommend usage of heparin for unexplained RPL without antiphospholipid antibodies. So going by this, I'd like to answer the question I first asked with. Low molecular weight heparin may not cause any harmful effect to the mother or the fetus. There can be studies that has hypothesized that it could counter some unknown antibodies. In unexplained RPL, it could counter some conditions which we are not aware of and give an improved pregnancy outcome. But low molecular weight heparin is not recommended for usage for APLA negative patients as per guidelines. But practically, it is being used, and it is to be seen by future large numbered prospective randomized control trials to see if this low molecular weight heparin is causing an effect. And if we can prove that, maybe we can change the guidelines in future. But as of now, it is not recommended for APLA negative patients. Finally, I'd like to conclude saying that everything in life has some risk. What you have to learn, what you have to do with this is then you can navigate how to navigate it. The same applies to low molecular weight heparin. Thank you.
Thank you, Niranjana. I think we lost you. Yeah, Niranjana is still there. Yeah.
Yes, sir.
Yes, Niranjana. Thank you very much. Yeah, over to you, Dr. Anuradha.
Yes,
Dr. Anuradha.
Dr. Manipriya Arun, who is a fellowship in reproductive medicine, and she's a consultant in Aishwarya Women's Hospital and Polytechnic Center. She has 23 publications and many presentations in international and national conference. Over to Dr. Manipriya.
Thank you, ma'am. Thank you for the introduction. Okay, so I would like to thank Palniappan sir, Vijayalakshmi madam, and team Oxy for giving me this opportunity today among so many eminent professors. And my topic is control cord traction in the active management of third stage labor, whether to do or no. So historically, following the original recommendation of Aristotle, in 1786, control cord traction fell into disuse until the papers of Brand in 1933 and Andrews in 1940 described this technique as lifting the uterus. So it is also called as Brand-Andrews technique. And we know that after the signs of placental separation, it involves a downward traction on the cord with the other hand placed suprapubically to lift the uterus upwards. If the first attempt is unsuccessful, the maneuver can be repeated after 1 to 2 minutes. So what does evidence say? According to the Cochrane review published in 2015, which was undertaken to evaluate the effects of control cord traction during the third stage of labor, either with or without conventional active management, the review included only randomized control trial and one very large trial conducted by WHO across 8 countries, including India, involving over 23,000 women were included in this study. Another trial was conducted in France involving 4,000 women, and the third trial was a single-center trial from Uruguay involving nearly 200 women. All 3 trials administered a routine uterotonic. Generally, oxytocin was given intramuscular or intravenously. All 3 trials also used some form of deferred cord clamping between 1 to 3 minutes. So the review found a difference in mild PPH, with no difference in severe PPH blood loss of over 1,000 when control cord traction was used compared to the no control cord traction group. And there was also no difference identified in the use of additional utrotronics, blood transfusion, maternal death, or severe morbidity. The manual removal of placenta was reduced in the control cord traction group, although this outcome was assessed only in the WHO and the French trial. In the WHO trial, the reduction in MRP with CCT disappeared to 0.7% in both the groups when the center started using oxytocin plus ergometrin. However, the final data had excluded this analysis. The French trial also showed a reduction in the manual removal of placenta with the CCT group of 4% compared to 6% in the group with no control cord traction. This review also found a small reduction of blood loss over 500 ml, and the length of third stage of labor was shorter among the control cord traction group. So the third stage of labor was an average of 6 minutes longer among the women who did not receive the control cord traction. The author acknowledged that this may be an important amount of time, not so much for the parturient, but definitely for the management of doctors, for a busy labor room and delivery units. Next came the TRACO trial, the traction on cord trial, published in 2013, a randomized control trial done in France across 5 universities. The effect of routine control cord traction as a part of active management of third stage labor was studied on postpartum hemorrhage. And they concluded that the incidence of postpartum hemorrhage did not differ between the CCT group and the standard placental expulsion group. However, the need for manual removal of placenta was significantly less in the control cord traction group compared to the standard placental expulsion group. Women with control cord traction reported a significantly lower intensity of pain and discomfort during the third stage than those in the standard placental expulsion group. Both the groups did not have any issues as uterine inversion. So now coming to what the WHO says. CCT is recommended by WHO for vaginal birth if the care provider and the patient regard a small reduction in blood loss and small reduction in the duration of third stage labor as important. The guideline development group found this guideline to be a very strong recommendation based on moderate quality evidence. The recommendation was based on a large RCT in which oxytocin 10 units was used for the prevention of PPH in all participants. Based on this evidence, CCT was regarded as safe when applied by a skilled birth attendant, as it provides small beneficial effects on blood loss, an average reduction of blood loss of 11 ml, and on the duration of third stage labor reduction of about 6 minutes. In settings where a skilled birth attendant is not available, control cord traction is definitely not recommended. It was a strong recommendation with high quality evidence. They also recommended CCT method for the removal of placenta in cesarean section. So this table shows the recommendation status of individual components of the active management of third stage labor based on who delivers the intervention. And for control cord traction, it's unconditionally recommended if a skilled birth attendant is available, and completely against if a non-skilled birth attendant, and self-administration of the procedure. So the RCOG and the NICE Green Top guidelines also suggested control cord traction as an important part of the active management of third stage labor, with the evidence level 1++ with high quality evidence based on several systemic reviews of RCT over the years, which has very low risk of bias. They also had added a very important point that women who prefer less interventional approach to the third stage of labor can be assured that when a uterotonic agent is used, routine use of CCT can be omitted from the active management package without an increased risk of severe PPH. However, the risk of manual removal of placenta may be increased. Another Cochrane review emphasized that CCT may result in complications such as uterine inversion, particularly if the traction is applied before the uterus has contracted sufficiently and without applying effective counter pressure to the uterine fundus. Its use is limited to settings with access to birth attendant with reasonably high levels of skill and training to deal or tackle with postpartum hemorrhage. However, CCT is definitely recommended and has major implication for effective management of third stage labor in settings with limited human resource. So therefore, I would like to conclude saying that the evidence suggests CCT can be routinely offered during the third stage of labor, effective in preventing mild postpartum hemorrhage, definitely reduces the incidence of manual removal of placenta, provided that the birth attendant has the necessary skills. CCT should remain as a core competence for the skilled birth attendants. Its use is limited in terms of severe PPH, and if the parturient is not willing to do this, to undergo this procedure due to pain, the birth assistant can safely ignore, as there is no risk of increased severe PPH, but the risk of manual removal of placenta may be increased. Thank you.
Thank you, Dr. Malikia. It's a very good presentation. As you know, one of the common causes of PPH is mismanagement of the third stage of labor. So gone are for the days, no? Previously we used to say wait for the separation of the placenta, signs of separation. All those things have gone. Now we are into active management of the third stage of labor. And one of the components is controlled card action. As you already mentioned, there is a lot of reduction in PPH, retained placenta, and also the patient also agrees that there is less pain. Thank you. Thank you so much.
Thank you, ma'am. Thank you so much.
I'm happy to introduce the next speaker.
Next speaker. Shall I introduce, madam?
Yeah, because I was told. Okay, go ahead.
No. You can go ahead, madam. I'm just listening.
Go ahead, madam.
Yes.
Please, madam.
Vidya, please go ahead and introduce Dr. Sheila.
Yes, madam.
Okay, madam. Dr.
Vidya, are you there? Dr. Vidya, are you there? Dr. Vidya.
Oh, sorry. I had muted myself. Yeah. It is my pleasure to introduce Dr. Sheila Pillai. She's an associate professor, OBGYN Srihar, Chennai, undergraduate and postgraduate teacher who has published many articles at international and national levels and journals. She has been a part of organizing team of various academic events in Srihar. So over to Dr. Sheila for her talk. Are you there, Dr. Sheila? We are not able to see. Yeah, we can see you.
Am I audible now? Yes.
You are audible and visible also. But again, you are not visible. Yeah. So she is talking on progesterone in fetal neuro.
Yes, ma'am.
Yeah. You share.
Yes, ma'am. Please proceed, ma'am.
Yeah.
Okay. At the outset, I would like to.
Ma'am, please change to slideshow mode and start off, ma'am. She's lost.
Madam, start sharing your slides, ma'am.
Akila, she's lost her connection.
No, she's there, but she's having network issue.
Network issues there, yeah.
Network issues there, but her slides are seen and her voice is breaking.
Sheila, we lost you, Sheila. So I will call her and find out what happens. Yeah. Meanwhile, Akila, if there are questions in the chat box, please put them to the previous 4 speakers. I'll just find out what is happening with Sheila.
Akila, you are muted, Akila.
There is a question
audible now, ma'am?
regarding the funded pressure.
Yes, doctor.
Okay, 1 second.
Yeah, till you share screen, Akila will ask questions. You start sharing, ma'am. Paini sir, she has come. She has come. Akila, go ahead.
She's starting to share.
Akila, madam, please start screen share, madam. Please start screen share. There's just
we
one.
have actually given screen sharing, ma'am. I'm sharing my screen now. I think there's some problem with the internet, ma'am. 1 second, ma'am.
Ila, your screen is seen. Change it to the slide mode, slideshow mode, and start presenting.
Yes, sir.
You can start presenting.
Again gone, madam. You have to share again. It is not there. In the meantime, there was just one question for Sivasundari. Dr. Hoffmeyer has advocated self-applied fundal pressure.
1 second.
Describe. Any obstetric center is practicing it, and Sivasundari has answered, no, their center is not practicing it. That's the answer. Now, the chat box can't be read by the delegates, so that's the answer for the delegates.
Ma'am, is my screen visible now, ma'am?
Yes, Sheila.
Yes.
Is it? Yes. Okay. Thank you, sir. So what is the background for this topic of progesterone and fetal neuroprotection? Prenatal brain is constantly exposed to elevated levels of progesterone and its metabolites, with highest exposure happening in the 3rd trimester. Levels of allopregnanolone, which is actually 3-alpha, 5-alpha tetrahydroprogesterone. It is also a GABA A receptor active progesterone metabolite. The levels of allopregnanolone also will increase in the 3rd trimester. Human fetus is also exposed to abundant levels of estrone, estradiol, estriol, and estetrol in the 3rd trimester, and all these have cerebroprotective functions. So what is the origin of the various pregnancy steroids? Progesterone is mainly of placental origin. 5-alpha dihydroprogesterone and allopregnanolone are mainly formed in the placenta and the fetus as well. Androgens are mainly of fetal origin. How do we detect these pregnancy steroids? Currently, we use gas or liquid chromatography coupled with mass spectrometry or tandem mass spectrometry to analyze these steroids. So what do you mean by neuroactive steroids? The steroids that are synthesized within the nervous system itself by neurons and glial cells are called neuroactive steroids. Actually, both de novo synthesis within the brain and also synthesis from the circulating precursors will happen. And what is the evidence for this? Many enzymes, especially the aromatase enzyme, is expressed in the fetal brain. So we can understand that the synthesis of progesterone and other compounds, especially allopregnanolone and other protective steroids, does not rely only on the placenta because there is de novo synthesis . Whereas progestins are the synthetic compounds and they do not get converted to the neuroactive metabolites, and they act mainly only on the progesterone receptors. What are the effects of progesterones on fetal brain? What do animal studies say? So rodent studies have shown that progesterone receptors are present in numerous regions of the brain. There is a transient expression of progesterone receptor in cerebral cortex as well as cerebellum, and this progesterone receptor activation promotes the differentiation of developing cerebellar Purkinje neurons, and this is also important for the formation of neuronal connections and also for the maturation of neuronal networks. And GABA A receptor activation, which leads to neuronal depolarization. This is crucial for the neurodevelopmental actions of allopregnanolone. What are the effects of progesterone treatment in early pregnancy? The neural progenitor cells will develop, proliferate, migrate, and differentiate into neurons and glial cells during early embryonic growth. The synaptic connections, the formation of these synaptic connections will start during the 2nd trimester. And sex steroids have been shown to stimulate the proliferation and differentiation of embryonic neural stem cells in rodent studies. Please note that most of these studies have been conducted only in rodents. The progesterone receptor expression is upregulated in these cells during their differentiation to dopaminergic neurons as well as to any other types of neurons. And allopregnanolone, which we already said is a reduced metabolite of progesterone, it increases the intracellular calcium levels in rat hippocampal neurons through GABA A receptors. In mice also, progesterone has been found to protect neurogenesis in the embryonic brain, and it protects against inflammation-induced changes. Progesterone and also many progestins stimulated rat adult neural progenitor cell proliferation. In vitro studies strongly suggest that exposure to progesterone and similar steroid hormones influence very early stage of neural development. What do we know about the fetal brain vulnerability in the third trimester? As we all know, third trimester is an important stage of brain development. Brain growth spurt happens in third trimester and brain volume triples. Intense synaptogenesis occurs in third trimester as well as the myelination of axons will start in the third trimester. Maximum vulnerability of the brain towards any kind of damage is present during the period from 24 to 32 weeks of gestation. That is why typical lesions in preterm babies born below 30 weeks include intraventricular hemorrhages and periventricular leukomalacia, which can lead to cerebral palsy and motor skill dysfunction. Intraventricular hemorrhage is mainly caused by fluctuations in cerebral blood flow in the vascular bed of germinal matrix. These vessels are very fragile and thin-walled till 32 weeks. They break down, causing periventricular leukomalacia. Also, vascular cells are very active metabolically and they rely on good oxygenation during this gestational age. After 32 weeks, the cerebral vasculature develops significantly and the germinal matrix becomes no longer apparent. Periventricular leukomalacia is the principal form of brain injury in preterm infant and it is an underlying finding in cerebral palsy. So PVL actually mainly involves the axons and the immature oligodendrocytes near the lateral cerebral ventricles, and they cause irreversible damage to the periventricular white matter. The white matter is very vulnerable to hypoxia and ischemia between 23 and 32 weeks of gestation when these immature pre-myelinating oligodendrocytes predominate. An injury at this gestational age leads to myelination failure and neurological problems. Axon myelination starts in human fetus at around the 32nd week of gestation, and this also marks the end of the period of major vulnerability to hypoxia. What about the animal models of fetal cerebroprotection? As we already said, the studies have been done in animals like sheep, guinea pigs, as well as in rats and mice. Mammalian species have rapid brain growth taking place before birth, whereas rats and mice have rapid brain growth just soon after birth. There are similarities between the stages of brain development in sheep and humans. A sheep fetus at 95 days is functionally and structurally similar to a 24 to 28 week human fetus. And rat and mouse brain at 1 to 10 days postnatal period also equates the third trimester gestation in humans. And animal studies in sheep have shown that elevated levels of progesterone and allopregnanolone towards the end of pregnancy are crucial for cerebroprotection. Studies show that any acute hypoxic stress that can happen following occlusion of the umbilical cord, there will be increase in the levels of allopregnanolone and also 5-alpha reductase enzyme. And these actually offer neuroprotection against hypoxia-induced cell death. What is the role of progesterone in myelination? As we all know, myelination is required for the rapid saltatory conduction of nerve impulses. Also, myelination offers trophic support to the axons and is essential for the functional integrity and survival of neurons. Progesterone promotes both developmental myelination as well as regeneration of myelin in the adult brain. The role of progesterone in oligodendrocyte maturation, which actually leads to myelination in the central nervous system, and developmental myelination was demonstrated in cultures prepared from the cerebellum of rats or mice. This pro-myelinating effect of progesterone involves the progesterone receptors, and it can be mimicked by the selective progesterone receptor agonist promegestone. Progesterone stimulates proliferation and differentiation of oligodendrocyte progenitor cells or OPC, again through a progesterone receptor dependent mechanism. And this is something that could be inhibited by mifepristone in animal studies. Also, progesterone has a positive effect on the remyelination of axons, which have been demyelinated using lysophosphatidylcholine. These are all animal studies. Nesterone is a 19-nor progesterone derivative which also targets the progesterone receptor, and this also efficiently remyelinates axons. It also stimulates the proliferation, migration, and differentiation of oligodendrocyte progenitor cells. And therapy with progesterone or nesterone promoted the repair of severe chronic demyelinating lesions induced in female mice using cuprizone, which is an oligodendrocyte toxin. So both these compounds increase the density of oligodendrocyte progenitor cells and mature oligodendrocytes in the brain and stimulated the formation of new myelin sheaths. This pro-myelinating effect was actually progesterone receptor dependent. They also decrease the neuroinflammation, in particular activation of astrocytes and microglia. Progesterone protects against demyelination, or it promotes myelin regeneration in animal models of toxin or lesion-induced demyelination. Progesterone also exerts remyelinating, neuroprotective, and anti-inflammatory actions and improves the neurological outcomes in mice after an experimental autoimmune encephalomyelitis or EAE was induced in mice in an experimental model. Modifications in the synthesis of progesterone and allopregnanolone within the brain play a role in diseases like multiple sclerosis. And also it was studied and found out that allopregnanolone therapy, which is a reduced metabolite of progesterone, it limits the neuroinflammation, myelin damage, axonal injury, and also improves the neurological outcome in mice with experimental autoimmune encephalomyelitis. Steroids in early preterm infants. So as per our knowledge, we feel that an abrupt removal of an early preterm infant from a progesterone and estrogen-rich environment will contribute to neurodevelopmental disorders. So the effects of postnatal supplementation of estrogen and progesterone replacement therapy has been tried in extremely low birth weight infants at less than 29 weeks gestation and of weight less than 1,000 grams. In this study, it was found that there was no negative side effects of hormone treatment in these neonates, and those on hormone replacement had improved bone mineral accretion and also reduced incidence of chronic lung disease. Cognitive and neurological outcomes at 5 years showed slight improvement only in these babies. Optimum study, as we all know, is a multi-center randomized placebo-controlled clinical trial for the usefulness of vaginal progesterone in prevention of preterm birth. Ultrasound examination of the neonatal brains in the babies involved in the study revealed a significant reduction in injury because of the use of progesterone. So what are the questions unanswered? Actually, we do not really know about the extent of deprivation of protective neurosteroids to the developing brain of very preterm infants, because brain itself is a significant source of neurosteroids. So even if the preterm delivery happens and the baby is separate from the placenta, it may be again able to make use of the benefit of the de novo synthesis of progesterones by the brain. Also, we do not really know about the brain neurosteroid levels in preterm infants. And also, we do not really know how long the adrenal fetal zone in preterm infants continue to be a source of all these steroid precursors, whether it really regresses soon after the preterm birth or it continues to produce high amounts of DHEAs till the termed birth. So how can we find out all this? Actually, we need to do precise steroid profiling by mass spectrometry methods in preterm infants urgently to clarify this. So what is the conclusion? Animal studies have definitely shown the significant role of progesterone and its metabolites in fetal neuroprotection. But actually, we need a lot more research into the role of progesterone and its metabolites in the neurodevelopment and neuroprotection of human fetuses. So my reference is Best Practice in Research, Clinical Obstetrics and Gynecology, September 2020. So thank you all for the patient listening.
Thank you very much.
Yeah. It was a very nice talk. We are having any questions in the chat box?
Not much.
On this progesterone?
No, ma'am.
Or any other 4 talks?
There are not much questions, madam.
Kila, usually the questions come 5 minutes later and we translate it to them. That's the disadvantage of having the webinar modem of.
Yeah. I agree.
They come 5 minutes because they are supposed to type and it's supposed to get translated here. So we will take the questions as and when it comes and give it to the.
Yeah. So it was all the speakers were excellent, what I want to say. And the last talk was also, it completely covered the role of progesterone. And we all know that progesterone supplementation may reduce the risk of preterm birth and other things. So shall we move to the next session?
Yeah, we'll move on to the panel. Yeah, over to you, Akila.
Yes, sir. It was indeed an intellectual seat for all of us for the past couple of hours. The next in the itinerary is a panel discussion. Our panelists are Dr. Rajshreep Tank and Dr. Preeti Kumar. Dr. Rajshreep Tank, this personality has set a mark and standard in the field of obstetric and gynecologist. He is the Secretary General of Federation FOXC and is the project lead for FOXC. Sir has carved a place for himself in number of committees like Chair International Federation of Obstetric for Safe Abortion, and his contribution to the underprivileged women in urban slums, taking care of their menstrual hygiene, and he deals the social problems in grassroots level. And Sir has, in par with the electronic era, he has contributed to the FOXC by implementing electronic membrane management system and e-voting. His contribution to OXY and the society are endless. Very honored to introduce Dr. Rajshreep Tank for this panel discussion. Next we have, next slide please. Next we have Dr. Preeti Kumar, who is a chairperson of the Safe Motherhood Committee FOXC. She has published research papers and in journals and contributed chapters in textbooks of FOXC. Madam has been appreciated by the FOXC for her work in ASCOG 2020. She is an organizing secretary in various societies. To her credit, there are many awards. She is showing her interest to the society. Madam has delivered Dr. Meera oration during UPCOG 2018. Next, our panelist is Dr. Tenmuri, who is associate professor in OG Changalpat Medical College. Madam has presented papers in national and international journals. Next slide, please. Dr. Kalaivani, she's a director in KGH. She's a recipient of Best Doctor Award in Tamil Nadu MGR University. She's extending her services to the society by delivering lectures for adolescents in various schools regarding anemia and menstrual hygiene, screening for cervical cancer, and conducting workshop for obstetric skill and emergency. Madam is executive committee member in OXY and a member in FOXY and Menopause Society. Next slide, please. Dr. Vairamala, she was awarded Best Doctor Award in 2015. She's an associate professor in Tiruvallur Medical College. Her field of interest is high-risk obstetrics and gynecology endoscopy. She's a trainer in emergency obstetric and endoscopy. She has presented papers in national and international conferences. Next slide, please. Professor Rani, Madam, is an associate professor in IOG. She is in government services, served in Vellore, RSRM, and 13 years of service in Institute of Obstetric Gynecologist. Madam has presented papers in many national conferences. Next slide, please. Dr. Jayashree, Madam, is head of the department in Savita Medical College. She retired as a director in Obstetric Institute of Obstetric and Gynecology. She's a past president of OXY. Madam is a recipient award for Best Doctor Award from Tamil Nadu Medical University. She has presented papers both in national and international conferences. Next panelist, please. Dr. Maya Menon. She is working in ESI Hospital KK Nagar as a professor and head of the department in Obstetric and Gynecology Society. She is a member of FOXY, ISAR, and so on. She's been teaching undergraduate and postgraduate students for more than a decade. She has her publications, several papers in national and international conferences. So I hand over to the moderators.
Yeah, thank you, Akila. Thank you so much.
And, Dr. Preeti.
Yeah, I'll just share my screen.
Hello.
Yes, madam.
So is it visible now?
Yes, madam, visible.
So thank you so much. Thank you so much, Dr. Akila. And at the outset, I would like to thank Dr. Palaniappan and Dr. Vijay Lakshmi and OXYCON, the team of OXYCON, for inviting both of us here and bringing us all together to discuss a very, very important and relevant topic today, that is intrauterine fetal demise work in progress. So I, on behalf of Dr. Jaydeep Tank, will welcome all the panelists here And as just now introduced by Dr. Akila, most of them are very senior members. And we are really looking forward to listen from all of you, because let us talk something very practical. What is doable in our country, and what we can do for these pregnant women, and how can we bring down the incidence of stillbirth. So with all the panelists on board, we all understand that this is a neglected tragedy and we need to face it. So the entire panel will be basically focused on definition, epidemiology, etiology, approach to the management, and then approach to the management of subsequent pregnancy. And I'll request the panelists to be very concise in their responses, because we are already running late and I want to finish it off in 40 minutes. The time duration for this panel was 1 hour, but since we are late, we have to finish it fast. So coming to the first question to Dr. Thanmoji, how do you define intrauterine fetal demise? Because there's several criteria, WHO criteria, RCOG criteria, ACOG criteria, exactly how you should define intrauterine fetal demise. Dr. Thanmoji, your comments on this.
Yes, madam. Good afternoon, madam. Thank you, Oxy, for giving this opportunity. So accordingly, intrauterine fetal demise may be said as a single, in a singleton fetus, when the fetus doesn't show any signs of life, such as there is no heartbeat, no voluntary movements of the voluntary muscles, or any breathing movements like that. And the age criteria differs according to the WHO, RCOG, and ACOG. So in RCOG, they say as in the period of more than 24 weeks, and ACOG, they say more than 20 weeks, and WHO criteria, they say more than 22 weeks, or more than a weight of about 500 grams. So when the gestation age is not required, but we can concisely say that when after the period of viability, when the fetus doesn't show any signs of life, we can say it is a intrauterine fetal demise.
So thank you so much, Dr. Thanmoji, that for putting it up. What WHO says that the pregnant women can have antepartum stillbirths, or they can have intrapartum stillbirths, and the incidence is really very high. And for the reporting purpose, we should define the stillbirths as a birth weight more than 1,000 grams, or if it is more than 28 weeks of gestation, or the body length is more than 35 centimeters. So just to define the criteria for reporting, we need to take this as late stillbirths from a birth weight of more than 1,000, more than 28 weeks. And if it is more than 22 weeks, then 500 grams is taken as the cutoff. So coming to Dr. Kalevani, what do you think is the magnitude of problem in our country? Because it is very important for us to understand the magnitude of problem of stillbirth in our country. So whether you talk about IUFD or stillbirth is one and the same. So what do you think is the magnitude of problem in our country?
Good morning, madam.
Dr. Kalevani, yeah.
Yes, ma'am. The global prevalence of stillbirth is roughly around 1.9 million, of which nearly 0.34 million is contributed by India. Nearly 5 countries are contributing to stillbirths, of which India contributes nearly half of the stillbirths in India. Our current stillbirth rate is roughly around 13.9 stillbirths. We were roughly around 22 in the year 2000. With the Indian Newborn Action Plan, our stillbirth rate have been reduced for the past 2 decades. And our main SDG goal is to reduce our stillbirth rate to a single-digit number. And if we plan to reduce by nearly 4% per year, we can reduce and reach that level. At present in India, the reduction of stillbirth rate is roughly around 1% per year.
Yeah. Thank you, Dr. Kalevani. I'm really privileged to have you here because I've taken some of the slides from your article as well. Thank you so much. And this is what I am presenting, one of the presentation by WHO, that India has shown 53% decline in stillbirth rate, and it's among top 15 countries globally with the highest percentage of decline in the stillbirth between 2000 and 2020. But the fact remains that still in India, we are having 933 stillbirths every day and almost 1 stillbirth every 2 minutes. And what Dr. Kalevani has just now mentioned, that every newborn action plan, the target is that we need to achieve the single digit of stillbirth by 2030. So this is what the statistics show, that 3/5 of the stillbirths at the time of delivery, also in the facilities, which are very preventable. And 59% of the stillbirths are occurring in the intrapartum period, where we need to work and we need to look into, or we need to introspect ourselves what is actually happening wrong in our country. So nearly 1 in 3 women in SEA, that is South Asian region, still do not get the pregnancy or delivery care, and they need to, which can reduce the stillbirth dramatically. So as we see, there is a Pradhan Mantri Surakshit Matritva Yojana, and so many programs are running for antenatal women. The coverage is 90%, but the stillbirth reduction is not that high. So we need to really look into the preventable causes of stillbirth in our country. So coming to the Veramala, can you just predict or prevent stillbirth? What are the maternal factors that warn you, or there can be fetal factors or the placental factors? How can you predict or prevent stillbirth whenever you are seeing an antenatal women or a pregnant woman? Dr. Veramala, your comments on this, please.
Yes. Good afternoon, all of you. Unexplained causes account for more than 25 to 60% of all fetal demises. The incidence increases with increasing gestation age. There are causes clearly identified. The cause can be attributable to maternal, fetal, or placental pathology. In maternal, we have the diabetes. It is, as we said, it's multifactorial. Maybe due to diabetes mellitus, poorly controlled, prolonged pregnancy, it's more than 42 weeks, hypertension, eclampsia, extremities of maternal age, antiphospholipid syndrome, either hemoglobinopathies or uterine rupture. There are too many causes in maternal. And fetal, it could be due to multiple gestation or intrauterine growth restriction, congenital or genetic abnormality, or infections. Placental causes are like cord accidents, abruption, vasa previa, or premature rupture of membranes. These factors are identified.
Yeah, thank you so much. Yeah, thank you so much.
Prevention and prediction, madam, we can always, better education can directly influence the implementation of reproductive health. Several causes like chromosomal abnormalities are not preventable even with modern technology, but others like post-maturity are completely preventable. So proper prenatal care and diabetic and other diseases control can help in the prevention of high-risk IUDs, extensive fetal monitoring.
So it's very important to just identify the high-risk pregnancies right at the beginning and then start the surveillance accordingly so that we can decrease the incidence of stillbirth. But there are certain conditions like diabetes where we cannot just predict. There can be no parameters as such which can predict the stillbirths. So as rightly mentioned, there can be fetal causes, there can be maternal causes of the stillbirth, and FGR remains one of the very, very important cause of intrauterine fetal demise. And so whenever you do a scan, you need to focus on the placenta as well. There are so many causes which are related to placenta that can lead to intrauterine fetal demise. So coming to Dr. Rani, when to investigate and to what extent regarding the infections, because as mentioned earlier, there are certain causes which are, you may not find certain causes, they may be unexplained, but the infections also play a very, very important role. We can have the viral infections, bacterial, fungal, parasitic, a list of infections are there. So what do you think, to what extent should we investigate, when to investigate? As they can be transplacenta or ascending infections. So Dr. Rani, your comments on this, what do you practice in your clinical setting?
Good afternoon, madam. Whenever a woman has stillbirth, she will be extremely traumatized, and it is absolutely essential to investigate and find out the cause so that we can give her an idea of the chance of it recurring in a subsequent pregnancy. And bacterial infections as such could be an ascending infection, like for example in a patient with PROM, or it could be a hematogenous spread where it could be some viral infections. So the various infections can result in severe maternal systemic diseases, which can cause fetal death, or it could be placental, affect the placenta, resulting in villitis and therefore death of the placenta, like in a malaria, or it could be a severe fetal systemic infection, like in a case of E. coli infections. So the common bacterial infections would be the Listeria, Treponema causing syphilis, and also Klebsiella, Group B Streptococcus, etc. And viral infections, CMV, rubella, herpes simplex, varicella zoster are some of the very common viral infections. The parasitic infections like malaria and toxoplasmosis and fungal infections like candida can also cause intrauterine fetal deaths. And the idea is to look for these infections by serological testing or in some situation when there are markers on ultrasound, we can also do invasive testing and cytogenetic testing. You can do a amniocentesis also to look for these infections by doing a amniocentesis, and the fluid can be used for PCR.
Okay, so Dr. Rani, I just want to have your opinion. Suppose if you don't find any clue of infection, would you still like to go ahead with the testing for certain infections in the baby, or maybe the cultures from the placenta, or maybe serology testing from the mother? Do you routinely do even if you don't find any clue for infection?
No, madam. Only when there is some clue pointing towards an infection, when the mother has a history of fever or any markers in the ultrasound which may be suggestive of an infection, only then we go ahead and do the testing. And serological testing is also done only when there is a suspicion of infection.
So, Dr. Kalavani, I just want your opinion as well. Do you routinely, as suppose a dead fetus is born, a pregnant woman has IUFD, do you routinely ask for the cultures from the surface of the, or maybe between the chorion and amnion, you take the swab, or maybe some vaginal, any infections? Do you routinely test for any infection, even though if you don't find any clue? Suppose if it is unexplained, you are not able to find the cause, you still go ahead with the testing, or you just look at the infections? If there are evidences, you just send those infections?
Yeah, we send only if there are evidence of infection. Usually we don't send.
So it is very important to understand, if you have the antenatal clue for any infection, either in the form of a sonography marker, or if you find any clue, like a pregnant woman may be having some fever or rash or something like that, then only send these cultures. Otherwise, it is not advisable unless you find the cause. But definitely, to rule out the other causes, you may, if you have the facility, you can send these cultures. So most of the risk factors are modifiable and preventable. And I must tell you, anemia is one of the very, very important cause. Despite Anemia Mukt Bharat Abhiyan, the latest NHFS data, 22 states, still 12 states show a prevalence and a higher incidence of anemia. So this is where we are lacking. We need to focus on these preventable and modifiable factors of stillbirths. So coming to the intrapartum fetal surveillance, Dr. Jaishree, your comments, where, because we know that 3/5 of the fetal deaths can occur in the intrapartum period, and a country like ours in a low resource, we may not be having so many facilities which are well equipped. So what can be your take on this? How can we prevent? What are the alerts in intrapartum period where we can prevent these fetal demises? Dr. Jaishree.
Good afternoon, everybody. Labor occupies the shortest period during the long journey of pregnancy. And if we are not going to be alert and vigilant, we are going to miss the bus. The bundle of joy is not going to be given to the mother. So as a natural process phenomenon, labor always gives us some red alerts, and we should be prudent enough to identify, recognize that, and act accordingly. Like intrapartum period is very, very crucial, and we may have fetal death during this because of uterine rupture. It may be because of malpositions, or because we have missed the malpositions, or it may be a case of TOLAC going in for VBAC. We have missed because we didn't put our hand on the abdomen and felt for the SP tenderness and SP bulge, suprapubic bulge, or in case of abruption, we have not felt that the uterus is tense and tender, or on doing ARM, we have not found that it was a blood-stained liquor, or we missed it, or just like our teachers used to say, Dr. Lalita and Subramaniam, always after doing ARM, push the head presenting part little above, so that from the hind water you will know whether it is a meconium stain or blood stain, and all these factors. And our teachers, Dr. Colin Srinivasan used to say, bless the uterus. We have to put our hand on the abdomen and feel for the contractions and for the tenderness, all these things. Clinical acumen is very, very important, and nature always gives us alerts. We should be, keep our eyes open.
Yes.
And
So,
these
Dr.
are all
Jayashree, what I will like to share my experiences here in UP. Most of the centers which are in the private sector, they are not using partogram, except for those who are Baneta centers which are trained. But most of the centers, they are not using partogram. How do you think is partogram helpful? Should all the centers be using partogram? Or a paperless partogram is good enough? What do you think that the healthcare workers should, or the doctor should chart the partogram in each and every facility in our country? But in the Jharkhand, we did a program in Jharkhand also. We did the program in UP also. Most of the centers are not following partogram, except for institutions. They are doing, but most of the centers are not doing. So how do you emphasize that partogram should be a very important component?
Partogram is mainly for the for everybody, but it's mainly for the lower centers to pick up cases where there is no progress, and they have to send it across to the higher centers.
Yes.
But
so
in case in medical colleges, what usually happens is they plot the partogram after everything is over, when they get time, because the chief will come and scold.
Yes.
That should not be the thing. But partogram is really a boon which directs everybody, or just at a look at the paper, you will know what is happening to the baby, to the mother, to the progress. Everything is seen. So very conscientiously, everybody has to plot the partogram in the right way.
So this is what we are doing, pushing every center of Manyata to use partogram. Whichever centers we are enrolling, we are pushing them to use partograms so that we can identify those high-risk pregnancies, and the labor can be monitored properly, and therefore we can reduce the fetal demise.
Yes, we
so
have added it to the case sheet. We are doing everything possible to see that each case has its partogram on it.
But Jayashree, you brought up this point very clearly. Most of the centers, they fill the partogram after the delivery. Most of the centers. So this is a very quite common practice, but we need to fill the partogram during the labor. So coming to the first case, thank you, Dr. Jayashree. 35 years old privy gravida, a BMI of 28, conceives after infertility treatment, had regular antenatal checkups till 22 weeks of gestation. The personal and the family history does not reveal anything significant. The blood tests and scans were done normal, which were normal. She reports at 29 weeks with loss of fetal movements for 2 days, and she complains of mild fever. On examination, the blood pressure was 140/80. Systemic examination was normal. Abdominal examination shows a 28 weeks fetus, and the fetal heart sound is not audible. And it was a cephalic presentation. Now coming to Dr. Maya. Now this is a patient which has come to your clinic, and a patient who was a pregnant woman who was booked earlier, but now she reports with loss of fetal movements. How would you approach this IUFD query? Maybe she may be IUFD, she may not be. So Dr. Maya, your take on this.
Good afternoon, Oxy, and I also thank Palniappan sir for including me in the panel. Now, how do I approach this, ma'am? See, absent of fetal movements, but when by auscultation and CTG, they are not the diagnostic tool when you have a suspicion of IUD. So you have to supplement with an ultrasound. So ultrasound along with color Doppler of the fetal heart and the umbilical cord has to be done. And ultrasound will give us many more markers. It will help us to know whether when the FH is gone, like it will help us to know the gestational age. If there is any overlapping of the cranial bones, it will help us to know if the FH is lost more than 24 hours. And also you can see some gas in the blood vessels, high drops. High drops also can be diagnosed. That gives us an indication that could be a parvovirus infection or all these. And if there is any placentomegaly, all that can be made out in the ultrasound. So ultrasound will be a diagnostic tool. And then since you said, madam, there is a mild fever, you should also ask history of any PROM. So that is very important. So you should do a perspiculum examination, do a high vaginal swab, and send necessary investigation, a complete blood count, a CRP also should be sent, a urine culture also should be sent for the patient. Along with COVID being a pandemic in this thing, we should also take a throat swab for this patient. Along with, and then thinking of intrauterine fetal death, we should also do the coagulation profile. That is the serum fibrinogen, the platelet count, and other coagulation profile also has to be sent for this.
So, Dr. Maya, when we were PG students, we were used to we were asked to send the pregnant women for X-ray. Do you think X-ray has any role now?
Ma'am, those days actually ultrasonogram was not available in all government institutions. So that's why we used to do X-ray. That is because that will pick up the overlapping of the cranial bones. That itself gives us a clue that there is been an IUD. But now we have sonology in all, even the public health centers have sonology given by the government of India. So I think scan is the ideal tool to diagnose the intrauterine fetal.
Scan is the ideal tool, but where you don't have the facility of a scan, definitely X-ray can have some role. Yeah, the scan. So but nowadays, definitely X-ray is obsolete. We diagnose IUFD only by sonography. So establishing a diagnosis, accurate diagnosis is very important, as you mentioned, Dr. Maya, and ultrasound plays a very, very important role. It gives us the idea of the fetus. It gives us the idea of the fluid. It gives us the idea of the placenta, and many things can be seen in this. So coming to Dr. Thenmoji, how should you break the news now? Now you have diagnosed that she's a case of IUFD. Now, how should you break the news? Whom should you tell? First, the pregnant woman, or you want to tell to the relatives, or you will call the husband? Whom should you call first?
Yes, madam. So before breaking the news, first we must be very much confident that there is no signs of life or IUD, and we must tell her along with a companion. So we should not tell her in separate. So we must tell the patient along with one companion, so that she'll be having some support. She'll be having some moral support and psychological support, and she can able to express her guilt feeling or emotional feelings. So that has to be expressed along with one companion. And during that period, we have to be such as a counseling session, as you have put in slide. It has to be a counseling session which has to include what may be the causes and what is the plan of management, and what is the further investigation she have to undergo, and further what have to be followed up in the next pregnancy, and everything at last for our safety and for legal purpose. It has to be in a written document.
So yes, it is very important. There could be disbelief, there could be mixed anxiety, anger, shock, guilt, denial, despair, fear and anxiety, and it is very, very important to counsel them before breaking the news. You need to confirm the diagnosis, take the privacy into this thing, and it should not be in a very hurried manner. So make them aware what Dr. Maya just now mentioned, that there is no specific cause in more than 50% of the cases. And you should, regarding the planning of future pregnancy, the investigations about the fetal biopsy, and about the test and the complications while delivery. So counseling plays a very, very important role, and restore and reinforce the patient's sense of self-worth. That is COPE protocol, where we have the components of communication, options, physical, and as well as the emotional support. And SPIKE protocol, where we need to set up a privacy, a perception, how much the patient knows about it, then ask the patient what level of detail she wants to hear in knowledge, empathy, and the strategy. Now, coming to the second case, Dr. Jaideep has joined. Has Dr. Jaideep joined? He was busy with the case.
Yes, he's joined, Preeti. Dr. Jaideep Tank is here, and happy
welcome,
to have
Dr.
Dr. Jaideep.
Yeah, please take up the second case.
Thank you, Preeti. Thank you, OGSSI, and thank you, Dr. Palaniappan, Dr. Vijay Lakshmi, for this very kind invitation. I hope I'm audible.
Yes, you are audible.
Yes, Jaideep, quite
I
clear.
do apologize for being delayed. I was stuck with a case. Fortunately, it was not a case of intrauterine fetal death. It had a happy outcome, but the patient still had some PPH, and that's why I got a little delayed in joining. Touch wood, she's fine now. I must first again thank Preeti. She has worked really hard on this panel, and I will ask her to intervene when she thinks that I'm missing a step in this panel. So I have been here for a little while now, and the panel is going extremely well. Thank you to all the wonderful panelists. Preeti, this is the second case that has been described in the panel. Mrs. X, a second gravida, previous normal delivery 3 years back, baby alive and healthy, a BMI of 30 with a family history of diabetes and hypertension. She was unbooked, presenting at 34 weeks with a BP which is 140/100 with complaints of diminished fetal movements and pain. And the ultrasound is showing a 34 weeks intrauterine fetal death with no retroplacental clot or collection and AFI5. Just before you move on, Preeti, there was a bit of confusion, actually, Dr. Palaniappan. Dr. Palaniappan told me that do a panel on IUD, and I thought I have to do it on intrauterine devices. And so I said, Preeti. Luckily, Preeti phoned up Palani, and he said that, no, it's intrauterine fetal death. So sometimes that one letter can make quite a lot of difference. So Dr. Kalaivani, how will you investigate this patient? In this instance, could hypertension be a cause of intrauterine death? And what investigations will you prescribe, maternal, fetal, and placental, if any?
So she has come with an ultrasound report of an IUD, and now I have to confirm the case if it is a case of IUFD with an ultrasound. And could hypertension be a cause? Here, this patient has a BP of 150/100. So possibly, I think it could be due to hypertension because this is the only positive finding in her history. But with single BP of 150/100, we can think that it could be a cause, but could not implicate that is the definite cause for IUD for this case. In this case, when you look into the history, her BMI is high. Obesity could also be a cause of this. And then we did not have the opportunity of doing the investigations in the initial period since she is an unbooked case. And since she has a family history of diabetes and hypertension, she might also have diabetes as a cause of IUFD. So we must think of diabetes, we must think of hypertension, obesity as a major cause. And she also has a positive finding of oligohydramnios. Mostly, we think that preeclampsia leading on to IUGR and leading on to IUD is mostly the common sequence that we come across. And IUGR is mostly a single independent risk factor for IUFD. So I think the cause of IUFD in this case may be due to hypertension.
Okay. Well, this is really the problem, isn't it, Dr. Kannan, with
yes,
association and causality. And the fact that IUFD is typically a multifactorial kind of a thing which occurs in a chronic situation. It's quite different to have an IUFD when there is an accidental hemorrhage or there is a cord prolapse or something of that sort where the cause is obvious. But in this kind of a patient, even if you have a positive finding, it's quite difficult to actually make out, what exactly
the cases are also due to unexplained causes. So we cannot exactly pinpoint, but we can think it could be hypertension.
Sure. And I think that sort of proves the point which Preeti was also mentioning and the previous speakers were mentioning that, you have to counsel the patient very well. Most patients will want to know, why did this happen? And the fact of the matter is that we aren't always able to tell them, an exact and specific reason. Preeti has put up some of the investigations, and these investigations are more to do with the management of the further management of the cause of the patient rather than finding out exactly what is the cause of the whole thing. And therefore, we need to take into account the whole scenario before we make a decision on how to proceed. So if you would like to investigate the cause, and I will move on then to ask Dr. Rani this question. If you would like to investigate the cause, of this IUFD, besides the investigations that you will see on the screen, for example, the CBC, the bile salts, the Klehover, etc., there is a case to be made for some more investigations also. So what investigations besides these fairly routine investigations will you think of?
There is a place for cytogenetic testing in the patients with intrauterine fetal demises. But it is generally reserved for patients who have family history of chromosomal abnormalities, or patients with inherited disorders or congenital anomalies in the family, or if the mother is a known carrier of a particular translocation or a gene defect, or if the mother has been exposed to teratogens, or she's had any history of fever or infections, or the ultrasound shows certain markers which could point to chromosomal abnormalities, or a positive screening test when we do the testing for Downs. All this would prompt us to suggest the patient, request the patient to have a cytogenetic testing, for which we need to get the patient's consent. We can go for a chorion villus sampling or an amniocentesis, which will take about 1 to 3 weeks for the report to come, or we can do more rapid tests in the form of fluorescent in situ hybridization, which will take 48 to 72 hours for us to find out if the patient baby has any chromosomal abnormalities.
Thank you. So I think that's important that you pointed out that not all patients will need cytogenetic studies. There are some markers which you have to take into account. And the fact remains that these cytogenetic studies are sometimes a little expensive. And therefore, the patient needs to be told that, there is a certain expense. And after you spend this money, there's no guarantee that we will be able to actually tell you the reason. It is more by way of closure than anything else that these studies are actually helpful. Dr. Vairmala, if you want to do these kind of studies or any other studies, when would you prefer to do them? Dr. Rani mentioned that, you could do an amnio, for example, or you could do a chorion villus biopsy and so on. So when would you prefer to do it? So, I suppose the question I'm asking you, Doctor, really is that what is your preferred way of doing a cytogenetic study? Or for elucidating the cause, and when do you think you should do it?
Investigating the cause, certain tests have to be done at the time of diagnosis, and a few tests can be done after delivery. So at the time of diagnosis, it starts from the maternal and the family history. Already as mentioned, ultrasound and amniocentesis can also be done for the cytogenetic studies or to rule out any infections even before delivery. And of course, maternal blood test, as already mentioned, including the blood counts, blood sugar levels, liver function test, coagulation screen. And there can be some special investigations also be done as regards to thyroid function test or any culture sensitivities also, if it is required. And other additional tests in this situation can also be diagnosed with the maternal antibody screening if there is anything suggestive of like fetal hydrops or so, and lupus anticoagulant or anticoagulopin antibody testing or thrombophilia panel if required. But after delivery, the requisites are the external examination of the baby to rule out any external anomalies, whether the growth was adequate or if it was a fresh dead bone or a macerated or how severe it is. And the infant blood test can also supplement tests with the cord blood sample can also be taken and cultured. If there is any infection, they can assess the fetal inflammatory response too. And infant microbiology is actually more informative than the maternal serology for infections. And the most important thing I would prefer in this case is the placenta membrane and cord histopathology. Usually, in karyotyping and cytogenetic investigations, we have at least 6% of the patients have this chromosomal abnormality, of which some are potentially recurrent. So culture provides the greatest range of information, but the range of tissue that can be used can be from the skin, placenta, the cartilage. The placental biopsy, we prefer at least 1 centimeter diameter near the cord insertion along the fetal surface, which can be sent for both aerobic and anaerobic culture also. And postmortem examination provides additional information and throws more light into the situation. And postmortem radiological examination, it is the skeletal survey by plain X-ray or the CT or MRI. If the facility has, the MRI throws more light into the CNS abnormalities and other soft tissue. The depiction of CNS abnormalities is more precise with MRI.
Yeah. Thank you. Thank you very much for that very comprehensive kind of an answer. Dr. Vairmala just talked about investigating for placental and cord abnormalities, and she spoke about where one needs to take the biopsy from. Obviously, one needs to take the biopsy from as close to the cord as possible to reduce the incidence of mosaicism reports, because those reports can actually be quite confusing. So, Dr. Thenmuzi, can I ask you, when you have done these kind of investigations, particularly histopathology investigations or you have sent the placenta or the cord blood for karyotyping. What has been your experience and what has been the yield, really speaking, from the investigations that you have sent?
Actually speaking, that after delivery, the baby and the placenta has to be examined thoroughly by a senior most or experienced person. So to see whether there is any gross abnormalities, any gross variations were there. And then it can be when there is an associated placental anomalies or fetal anomalies or any dysmorphism, we can send her for the pathological and for cultural examinations.
Okay, thank you. But in your experience, what has been the yield of, for example, in how many cases, say, in the last 10 cases of intrauterine fetal death, have you sent these investigations? And if you've sent them, in how many of them have you found any positive kind of result?
No, sir, we have not. We have sent only when there is a gross abnormality and when there is a request from the patient. We have sent.
Right.
Only two or three patients we have sent, and that too no positive results. One patient have cytogenic abnormalities we have, but it's not very significant.
I think that's a very important point that you have brought out. That you don't need to do everything for everybody. You need to select what investigations you'll do, and of course, what investigations you do will not only depending on the clinical situation, but also on the wishes of the patient. Some patients may or may not want to do all the investigations. And I think that's a very important point that you have brought about, Doctor. Thank you. Dr. Maya, one of the sort of a theoretical, if I may say so, investigations that has been recommended, particularly for what appears to be an unexplained intrauterine fetal death at first glance, is a fetal autopsy. Now we know that there are several problems with the fetal autopsy, starting from the expertise which is required to do it, to the permissions that are required to be done, and the fact that women who have delivered or a couple who has delivered may not necessarily want to have a fetal autopsy. So how much importance do you place on fetal autopsy to arrive at some kind of a conclusion or closure in these kind of cases? And if the couple refuses a fetal autopsy, would you actually say that, this is absolutely a must and you must undergo it? Or would you say to the couple that it's all right, if you don't want to undergo it, and that's fine, we are still going to be able to arrive at some kind of a conclusion from other investigations?
Sir, actually, they say that postpartum gives the highest diagnostic yield. It reveals the cause and also the time of death. But it will also help if they want to think for medical legal also, it is useful. But what I have seen is in my practice, many a times, other than obvious congenital anomalies, I have not seen any relevant information that I have got in this autopsy. And if at all the patient is not willing for an autopsy, we can ask them to undergo some minimal invasive testing, sir. Like we can do a transcutaneous tissue biopsy. We can ask for, along with that, body cavity aspiration can be sent for cytology, and also a full X-ray or an ultrasound with MRI also can be done to detect any renal, heart, brain or lung abnormalities which were not detected earlier. All that can be made out. So this option also can be told to the patient, so that it is we can explain all this to the patient. And these days the patients are also very anxious, not like the olden era, where now they are very much informed, so they want to know the cause of death. And so we can tell them that these are the options that are there, and if they are willing, we can do this. Minimal invasive testings can be given as an option for them to know the cause of death.
Sure. And Dr. Jayashree, I think that leads me very nicely to the next question, that, there is this whole issue about finding out the cause vis-a-vis expense, vis-a-vis counseling, vis-a-vis patient desire. And of course, the fact remains that, as Dr. Maya just mentioned, that in this kind of a situation where there is no obvious anomaly, the fetal ultrasound seems otherwise to be normal. what really are we adding in terms of value or knowledge, both for us and the patient, by prescribing the entire gamut of tests? So for this particular patient that we are talking about, she's got a single reading of a high blood pressure. Although she has a family history, she is not diabetic. And it's essentially what appears to be at first glance as an unexplained IUFD. So for this kind of a patient, specifically, what would be the tests that you would say are absolutely essential, and what would be the tests that you would say may not necessarily be needed?
See, about diabetes, we have to confirm. Then thrombophilia, we have to make out. Then autoimmune diseases. All these things we cannot just say by seeing the patient or just examining. So all these things are very important. And more than that, again, maybe 6% only is the chromosomal abnormalities, but try to get the permission for an autopsy, which might reveal so many things. And this may be helpful in giving them the cause, as well as trying to avoid it in the next pregnancy, or the prognosis in the future, how it is going to be. All this can be told. So actually, Maya has enumerated all the tests. So we'll have to be choosy about it.
Sure. Thank you. I think that's really a very important point that you have brought out. Dr. Preeti, can I hand the panel back to you, because I need to go and check if the patient's uterus is still well contracted.
Okay, thank you so much, Dr. Jaideep. Now, coming to Dr. Maya quickly, we have just 10 minutes to go. How would you deliver this patient? 34 weeks, IUD, the VP next, the second reading was normal. The blood parameters are normal. How would you deliver her now?
Ma'am, actually, 85% of them will deliver in the first 3 weeks, ma'am. They go into spontaneous labor in the first 3 weeks, but we should give them the option. We should tell them that there is all the possibility of going for DIC. So it is seen that within the 4 weeks, 10% of them can go for DIC. So after doing all the parameters, if at all we are waiting for 48 hours, we have to do the coagulation profile bi-weekly. And most of them might get into labor. And if at all they don't get into labor, like there are indications where we have to immediately terminate the pregnancy. That is if the mother's BP is
Dr. Maya, the patients get so panic after hearing that they have IUFD. Do you think they would like to wait for 3 weeks? No, I would like to have the opinion of the panelists, all the panelists. How many of you really wait for the sometime, or you directly induce? We'll have the opinion from all.
Patients usually don't wait, madam. They're more anxious to get rid of it.
Yeah. So, Dr. Thenmoji, would you like to wait? We'll have the opinion from all. Dr. Thenmoji.
Induce, madam.
Induce.
We have to induce.
Yeah. Dr. Varemala?
Yes, madam. We depend on the Bishop score. We can decide whether she's already in labor, we can accelerate with Syntocinon or ripen with gel.
Okay. So it's very difficult to hold on the patient. They will not listen to you. They will eat your head. So they are already very anxious. So you have to induce them. And it's very difficult to wait for 3 weeks. So what is the best way how you can induce? What is the best?
Misoprostol, ma'am. Usually give them misoprostol followed by misoprostol. Because it's 34 weeks, we can give 50 microgram every 4th hour.
Okay, so the recommendations are that these are FIGO recommendations that I'm mentioning, that fetal death 27 to 28 weeks, 100 microgram per vaginal or sublingual or buccal every 4 hours. If it is more than 28 weeks, then 25 microgram per vaginally every 6 hours, or 25 microgram per orally every 2 hours. Then again, it depends upon the contractions. You need to increase the dose, but these are the recommendations of FIGO that I really wanted to put it here. Now coming to next 5 minutes less, so we'll quickly wind up this panel. Any specific thing in the intrapartum management? What worries? Why are you concerned about this? Because she has IUD, she's going into labor, you have induced her. What are the problems that you expect in this women? Dr. Thenmoji and Dr. Kalavani.
Yes, madam. If there is possible thing, we can allot her a special labor room along with her companion, and also that should not be compensated her safetiness. So along with it, we have to give her bedside BGCT blood bleeding time, clotting time has to be assessed, and the detailed analysis of the coagulation profile has also been sent. And if preferred, we can give her an anesthesia, the pain relief can be given.
So do you give antibiotics routinely in these pregnant women who have IUFD, or you are selective in giving antibiotics?
Selective way, if there is signs of infection, we can give her antibiotics. No routine antibiotics as per the guidelines.
Dr. Maya, again, this is a thing that I really want to have the input from all the panelists. Antibiotics during labor in IUFD. Dr.
But we give antibiotics in government hospitals.
Dr. Kalavani.
Yes, madam. We give broad spectrum antibiotics.
I also give a shot of antibiotics. So this may be recommended, but we usually give one shot of antibiotic unless until the pregnant woman is having sepsis or signs of this thing. Now, next is placental histopathology, Dr. Veramala. Although I've taken this from Dr. Kalavani's article, can it be selective, or you have to send all the placenta for histopathology?
Pathological examination of the placenta should be recommended, madam. It should be examined in all cases. Examination reduce.
Yeah, it's a beautiful article. Yeah, can you just read it out? The placental examination is essential. Can you read out these indications?
Yes, madam. The placental examination is essential in cases of stillbirth, late miscarriages, severe fetal distress requiring admission to NICU, prematurity, FGR, fetal hydrops, and maternal pyrexia. It is desirable in prematurity of gestational age from 30 to 36 plus 6 weeks. Placental abruption, fetal congenital malformation, RH incompatibility, morbidly adherent placenta, twins or other uncomplicated multiple pregnancy, two-vessel cord, abnormal placental shapes, prolonged rupture of membranes more than 36 hours, GDM, maternal group B streptococcus infection, maternal coagulopathy, maternal substance misuse, and preeclampsia maternal hypertension. It is not indicated in cholestasis of pregnancy, pruritus of pregnancy, hepatitis B, HIV infections, other mental disease with normal pregnancy outcome, placenta previa, postpartum hemorrhage, polyhydramnios, and normal pregnancies. See, these are recommended.
Yeah, this is I really wanted to put in here. If you find the cause of IUD, then you need not to investigate much. Otherwise, if you are not able to find, then you have to. Dr. Maya, can you just quickly tell us how you process and store the placenta and send it for histopathology?
Madam, if it is sent for plain histopathology examination, we can send it in formalin. But if you want to send for karyotyping, then you have the cell culture tubes are kept in the refrigerator. It should be removed out. It should be thawed, and then the specimen should be kept and then sent it for examination.
So thank you, Dr. Maya. The post-delivery care is again very, very important. They are very disturbed. These patients are very depressed. So you need to take the care of the family as well as the patient. You need to do the grief counseling, lactation suppression, and contraception. Then quickly, Dr. Rani and Dr. Jesse, your comments on the subsequent pregnancy. This pregnant woman now delivered the IUFD baby. You have investigated. You have told certain investigations to done it later. Now, what about the subsequent pregnancy? Suppose she gets pregnant again. What would be your management protocol in this? Quickly.
She should be under my... yes, Rani, carry on.
Carry on.
Actually, she should be having a pregnancy counseling, and everything must be done. Roll out rubella, or if she has not been vaccinated, give rubella vaccination, improve her anemia, and diagnose diabetes, HBS. All these things must be done. And she should be in a good frame of mind to enter pregnancy confidently. Even if it takes 6 months, doesn't matter. She should feel confident, because evidence has proved that the interval is not going to matter much. If there's going to be a prolonged one or one.
So very important question. Yeah, thank you so much, Dr. Thenmoji. Dr. Rani, your comments, just one question. Torch. Should we do it or should we not do it after this?
Torch is not known to cause recurrent miscarriages, and so...
No, this is IUFD. This is IUFD.
Yes, madam.
Should we do torch in these pregnant women or not?
No, madam, not as a routine. Even if the previous cause was due to a torch infection, it does not tend to recur in a subsequent pregnancy. Acute infections are more commonly associated with IUFDs rather than a recurrent mild infection. And so there's no role in a routine testing.
Okay, so thank you so much. And for the subsequent pregnancy, you have to
subsequent pregnancy, in the pre-pregnancy counseling, modifiable factors like smoking and obesity, all this the diseases have to be stabilized and controlled before the patient contemplates another pregnancy. And
so what about just one comment, Dr. Rani, from you? When would you like to deliver the next pregnancy? Suppose she had IUD at 34 weeks. Now, next pregnancy, when would you like to deliver? And then I'll have the opinion from Dr. Thenmoji. If she has any high risk factor, then when to deliver?
I would want to keep the patient under constant surveillance, starting right from 32 weeks onwards, or at least 1 to 2 weeks prior to the previous stillbirth. But yes, I would not want to deliver the person early because there is a problem of iatrogenic prematurity. I would definitely want to continue the pregnancy, but there is the increased risk of recurrence of IUD after 39 weeks. I would not want to continue after 39 weeks, but constant surveillance in the form of NSTs and kick count and ultrasound for any growth disorders should be done, and the patient reassured, and I will induce only after 38 weeks.
So, Dr. Thenmoji, suppose this IUD happened at 37 weeks. Would you like to again go ahead till 39 weeks, or would you like to deliver her earlier after giving steroids?
So we can deliver with after a course of steroids. We can induce her.
So that all depends upon the next pregnancy. What are the high risk factors, whether they are present or the patient doesn't have any high risk factor. Then strict surveillance of the fetus is very, very important. And this is a summary of preventive strategies that we have already discussed. Again, this is very, very important chart that I have taken, that there are 15 steps that need to be taken in a preconception, pregnancy care, labor, and potential postnatal care, where we really need to bring down the stillbirths. So we need to raise the voices, increase the awareness, strengthen the healthcare system, need to teach every healthcare worker regarding the high danger signs and about the monitoring, the counseling and everything, and improve the measurement of stillbirth, support the bereaved family, and realize the equity in every state and region through sustained investments. So every baby is important, each baby counts, and each of us can make a great difference. So thank you so much. And with this, we close the panel after taking one comment from all the panelists. The last comment, Dr. Thenmoji, your comment on IUFD, how you can prevent it. We'll have just last one comment from each and every panelist.
We have to educate the patient regarding her, how to monitor herself, the petty count like that. No? We have to educate the patient.
So education is very, very important. Dr. Kalavani?
Madam, preventive obstetrics, good antenatal checkup,
good antenatal checkup is very, very important. Dr. Veramala?
Psychological support is very much needed.
Psychological support is very, very much needed. When I was a PG, one of the pregnant women, she jumped from the first floor after delivering IUFD. So it's very important. They are very disturbed. We need to support them psychologically. Dr. Rani, your comment?
Ultrasound early in the pregnancy to correctly determine the gestational age, and also looking for markers which may indicate that there is a possibility of recurrence.
Okay, thank you so much, Dr. Jayashree, and then Dr. Maya.
Yeah, I told psychological support is
okay, Dr. Maya.
She should be taking her tablets regularly, good nutrition, and also the family support is very, very essential.
Okay, thank you so much. A grand round of applause for all the panelists. Thank you so much. On behalf of Dr. Jaideep and myself, I would like to thank you all. And once again, Dr. Palaniappan and team OGSSICON for inviting us and having us here for this wonderful discussion. Thank you so much.
Ma'am, we also enjoyed
this. I thank Dr. Palaniappan and OGSSI team for the opportunity. We enjoyed it. Thank you.
Thank you to the OGSSI team, madam. It was a nice panel and very interactive, enlightening session. Thank you, madam.
Dr. Jaideep is there. Dr. Jaideep?
No, yes, no, I'm sorry. My patient is contracted. So
thank you, sir. Thank you, madam.
Thank you.
Dr. Jaideep,
I apologize for this. It was an IVF patient, came in an emergency, so I had to rush for her. Thank you very much, all the panelists. Thank you, Preeti. Thank you to the conference team. And my very dear friend, Dr. Palaniappan and Dr. Vijay Lakshmi for getting this all together. And mainly thank you, Preeti, for working so hard on the panel. Thank you very much.
Thank you so much.
Thank you, Jaydeep and Preeti. That was fantastic. And this IUFT panel couldn't have been made better. Of course, it was a tough topic given to you with the point of confusion, the pinch of confusion. But you made a lot of difference, and the panel could not have been made better. And thank you for taking time, both of you. Extremely busy people in Foxy, Jaydeep and Preeti. And thank you very much. I'm indeed honored by your presence. And we're just waiting for Professor Kipros to join again. And if time permits, please do join us for the oration in a couple of minutes more from now. Thank you very much, Jaydeep and Preeti.
Thank you so much.
Thank you, sir. Wishing all the obstetricians and IUFD free practice.
Okay. Thank you. And thank you all the panelists. You've been doing a wonderful job. And I know the panelists were very, very interactive. And now that we have come to the close of the panel and we are somewhere near lunch, I'm going to intervene and interfere your lunch. And I'm going to say that the dance over entertainment will probably be shifted up to the evening because Dr. Kipros Nikolaidis is having some problem logging in. He's been trying to do that for the last 15 minutes. So the tech team has sent another mail and whatever. So we're trying to do that now. And while we get connected with Dr. Kipros from the UK, so I request Dr. Meenakshi to take over. And Kishore, can we have Meenakshi's slide, and we'll have a bit of entertainment, and all of you can hide and have lunch if you want.
Sir, please, we can't do that now. We just have another video to be played that we will do now.
Okay,
and
you can play the video.
Before starting that video, because we're closing the entire forenoon session, I would like to thank our dear coordinator, Dr. Akila Ayyappan, who's been behind, the whole day and throughout the entire program. You have really did a good job in coordinating, Akila. Thank you very much.
Thank you, madam.
I would like to introduce the next coordinator to the team. We have with us, and can I have the, before introducing Meena, Kishore, can we have that video which Meenakshi sent you now? We want all our Oxy members to know what we have in store for you. Starring Team Oxy 2020 and our Oxy members, our senior delegates who have taken the trouble to put up a show, and we are having it in the evening following the entertainment program. So all of you, please do stay back and log in for the same. I would like to introduce our afternoon person, coordinator, Dr. Meena. Can I have that slide, Kishore? Meena is a very enthusiastic executive committee member of Oxy. She's a senior assistant professor, Institute of Social Obstetrics, Government Kasturba Gandhi Hospital. She's undergone special training in urogynecology, microsurgery, laparoscopic hysterectomy, and she is member of Oxy. And there is no this thing. Meena is such a sweet and wonderful person, a very good person at heart, very, very helpful always. And we are very happy to have you with us in our Oxy committee, Meena. And over to you for taking over the entire afternoon session. We'll just see if Dr. Nicholas has joined in, then Parni sir will tell you what we are going to do.
Ma'am, am I audible?
Yes, Meena, you are audible. You are audible. Your video.
Right now, a mail has been sent to you 5 minutes back to your personal mail ID.
Can I start, ma'am? Shall I wait for
we have to wait, no, Meena? We have to wait for Professor Nicholas to join us.
Yes, yes.
is having some difficulty in joining.
Okay, okay, ma'am.
But we are unable to have the entertainment because we'll be running behind schedule already.
Okay, okay.
So evening will get delayed.
Okay.
And inauguration program, dear delegates, all of you please stay back for the inauguration program. We have the health minister as our chief guest, and the inauguration will be followed by the entertainment program by OGSI members. Meena, anybody else there already for the next session?
Madam? Yes.
Do we have Dr. Monisha with us? Is she logged in already? Dr. Monisha, are you there? Dr. Monisha?
I don't think so, Vijay. It is not shown in gallery.
No, ma'am. Monisha is not logged in so far.
Can you call her, please? Ask her to log in immediately.
Vijay, what time roughly the inauguration be?
It is supposed to be at 4:15, madam. But we have to conduct it at 4:15 because health minister also has, it's an important dignitary, and we have Dr. Shanta Kumari, madam, who is there as our guest of honor, and she has another webinar to attend. So we have to start at 4:15. Meena, are you calling Monisha?
Yes, ma'am.
Sampath madam is there.
Sri Priya is also there, Raviji. She might have her number, isn't it? Sri Priya.
Sampath madam is there. Madam, உங்களுடைய start பண்ணிடலாமா madam, if you don't mind.
Shall I introduce, ma'am?
Wait pa. They have to be prepared, illa. We can't.
ஒரு 10 minutesல வந்துட்டேன் நான் இன்னும் to be frank இந்த நைட்டில இருக்கிற வந்துடுறேன் ஒரு 10 நிமிஷம் வெல்கம் பேக்
டாக்டர் ப்ரொஃபசர் நிக்கோலாக்ஸே வந்துருவாரு.
3 மணி தானேன்ட்டு இப்பதான்
கரெக்ட்
பையன் இப்பதான் தூங்கினானா.
சரி we are online. Okay. Are the chairpersons of the afternoon sessions there, pa? If we can introduce.
Yes, ma'am, they are there.
Tamachelvi madam. Shanti madam, is it okay if we introduce the chairpersons now, just to save some time?
If people are there, we are going to continue this session, isn't it?
Yes, madam. After the oration. Okay.
Who are the chairpersons?
Myself and Palniappan sir. President and secretary.
Yeah, naturally.
Yeah. So, shall we introduce the next session chairpersons, ma'am? Is it okay?
I don't.
Or is it wrong to do that?
I don't think so, Vijay.
Okay.
Suddenly, if he comes to the show.
Meena, is that little girl joining?
Yes, ma'am.
அப்பனா அவதையாவது முடிச்சிடலாமே இல்ல?
அப்ப அந்த
if he is logged in and you're going to start the session, even one thing, then you can introduce the
ma'am. Monisha has joined, ma'am.
Joined,
Monisha.
Okay, Monisha is there. Do we have Dr. Meena? Dr. Meena is there.
Meena madam is there, madam. She is Meena, ma'am.
Meena madam, can you join, please?
She's joined, ma'am.
Meena ma'am.
The joined இருக்கணும்ல. மீனா
இருக்கணும்ல join. You don't.
Meena, I'll call Meena.
I'm calling, ma'am.
Dr. Meena, Dr. Tamilchelvi, Dr. Shanti Rani.
Yes,
Any one of you, please.
N.
I'm calling,
Tamilchelvi.
Okay, I'll call.
N. Tamilchelvi.
I'm calling T.S. Meena, madam.
Okay, call. Dr. Shanti Rani, madam, are you there?
I'll call her, ma'am. She's not. I'll call her.
Fine. You can tell them all to join and tell them that we may have to start their session.
Dr. Monisha also joined.
Yeah. Okay, can I have Dr. Monisha's slide, please? Monisha will start with your presentation. Okay.
T.S. Meena madam is coming online, ma'am.
Yes, madam. Join Panneedran.
Can I have Dr. Monisha's slide, pa? Monisha, stop screen share. Yeah, we are very happy to start the afternoon session. Meena, can you introduce Monisha? We will we'll do only Monisha and then we will take the oration.
Madam, no need to introduce chairperson, madam.
Now you introduce Monisha, please.
Okay, ma'am. Okay.
Hello?
Madam, join panning, madam.
Yes, joined.
I am very happy to introduce Dr. Monisha Rajashekar, who has completed her MBBS from Mumbai and she is a final year postgraduate of Ramachandra University. Welcome, Monisha. Please start your session. Meena, madam, I apologize. I have introduced Monisha. We will start.
No problem.
Okay.
Yeah.
And N. Tamilchelvi madam has also joined, ma'am.
NT has joined. Shanti Rani, anybody has called?
Ma'am, we are online, ma'am, so let's not disturb. Monisha, please screen.
Ma'am, can you hear me?
Yes. Start screen share.
Yes, ma'am.
You are a candidate.
Ma'am, is my screen visible?
Yes, ma'am. Go to slideshow. Please, all others kindly mute. All others kindly mute, please. Yeah. Start, Monisha. And
Good afternoon, everybody. Good afternoon, everybody. I would like to thank Dr. Paraniappan sir for this opportunity and the entire OXI team. I'm Dr. Monisha Rajashekar, a final year postgraduate from Sri Ramachandra Medical Institute, Chennai. I am going to be presenting the risk factors for the progression of gestational diabetes mellitus to the postpartum type 2 diabetes. Gestational diabetes mellitus, that is GDM, complicates 6 to 8% of the pregnancies every year. Among those, up to 50% of them progress to type 2 diabetes within 5 years, which makes GDM one of the strongest risk factors for diabetes mellitus. ACOG and the American Diabetes Association recommends that women with GDM undergo a GTT tolerance test at 4 to 12 weeks postpartum every 1 to 3 years thereafter. However, less than 50% of the women return to postpartum follow-up. Therefore, it's important for us to identify the risk factors of women during the pre-pregnancy and pregnancy period. As there aren't any set protocols known to reduce the risk of progression, if we could probably identify these high-risk women across a course of life by strategizing them to reduce the risk by dividing into the pre-pregnancy, pregnancy, and the postpartum period. In the pre-pregnancy phase, we have the genetic association, that is, wherein the family history encompasses about both inherited and lifestyle components. The overall data is not clear regarding if family history of diabetes puts GDM at a higher risk of developing diabetes or not, even though the studies have identified that family history of diabetes is a main risk factor for developing diabetes. Whereas, on the other hand, we have the genetic risk scores, which is developed based on multiple genetic variants, which have shown that it is a better prognostic factor than the family history alone for predicting the progression. Secondly, when we come to the socio-demographics, the incidence of the progression from GDM to type 2 DM is more common among the non-white ethnicity, among whom the Black, followed by the Hispanics, followed by the Caucasian. A study conducted in the UK have shown around 35% of Asian women had a persistent glucose tolerance test 6 to 12 weeks postpartum, consistent with diabetes, while only 7% of the Caucasian and 5% of the Afro-Caribbean show the progression. Thirdly, we have the metabolics. A higher pre-pregnancy weight and BMI are associated with a higher risk of progression. Every 1 unit increase in the pre-pregnancy weight is predicted both independently the impaired glucose tolerance as well as diabetes mellitus at 4 to 8 weeks postpartum. In the pregnancy, we have the metabolic and the clinical. Among the metabolic, we have the gestational weight gain and BMI. Weight gain in early postpartum. Weight gain in the early postpartum in the highest tertile is identified as a risk factor.
My name is Evelina Litvinska. It's a different computer now.
Okay, so
weight gain in the early postpartum. Weight gain in the early postpartum period in the highest tertile is identified as the risk factor at 1 to 6 months postpartum. 1 unit increase in BMI increases the risk for progression by 16%. A BMI of more than 30 kg per meter square doubles the risk in 8 years postpartum for the progression of type 2 diabetes. There is an increase, every 1% increase in the HbA1c is associated with a 2-fold increase at 6 weeks postpartum. An HbA1c of more than 5.6% and a 2-hour glucose equal to a more than 183 milligram per deciliter is strongly associated with the progression within 1 year postpartum. Women requiring insulin are at a 3-fold increase for developing type 2 diabetes. The progression of on the other hand, the progression of use of oral hyperglycemic agents during the pregnancy has not shown any association so far. In the clinically, with respect to parity, recurrent pregnancies after pregnancy complicated by GDM is associated more than 3 times of increased risk of progression to type 2 diabetes. The pregnancy complications like hypertensive disorders and preterm delivery are also associated with the same. These 2 complications, that is of hypertensive disorders and preterm, are more common in obese women. In the postpartum period, under behavioral, we have diet and exercise and breastfeeding, which contributes to development of diabetes and identifying the risks.
Sorry to interrupt, Monisha. After your lecture is over in 2 minutes, we'll be starting the oration, and we are happy to have Prof. Kipros here with great difficulty in logging in. And
yes,
and after you finish your talk, we will start the oration. Viji, yeah. Kishore?
Yes, Meena madam and Tamil Chelvi madam, we will do it that way. Thanks for stepping in early.
Yes, sir. Thank you, sir. Under behavioral, we have the diet, exercise, and breastfeeding. Diabetic prevention program study showed a decrease in risk by 53% at 3 years and 35% at 10 years with weight reduction of 7% the baseline through more than 150 minutes per week exercise with a low fat and low calorie diet. With an increased intensity and duration of breastfeeding, there is a decrease in the progression of diabetes. A SWIFT study has confirmed that a 36 to 57% relative decrease in the risk of diabetes in the first 2 years. In the metabolics, we have the postpartum weight gain, postpartum glucose levels, and metabolics. That is, in the postpartum weight gain, independent of BMI before and during pregnancy. The ACOG and ADA, as said earlier, recommends an OGTT at 4 to 12 weeks, but an OGTT done 2 days postpartum has demonstrated a comparable ability to predict an impaired glucose tolerance within 1 year. The C-peptide levels more than 450 picograms and ghrelin levels are both associated with an increased odds of developing diabetes within 8 to 10 years as per another study, when done within 12 weeks of postpartum. The diabetic prevention program has also shown that use of metformin prophylactically has decreased the incidence by 50% of development within the first 3 years and 40% in 10 years. Troglitazone, though not used nowadays, and along with pioglitazone have also shown the efficiency. Among contraception, progesterone-only pills have also shown has an influence in insulin sensitivity. I would like to conclude by saying that though the causal pathway remains unclear, based on the multiple studies that have been available and the data that is showing evidence, I would like to say the risk factors for progression would be the pre-pregnancy obesity, genetic predisposition, the women requiring insulin during pregnancy, maximum postpartum weight gain, and unfavorable diet and low physical activity. These could be prevented by proper postpartum weight management by diet and exercise, proper glucose metabolism tests regularly, nutrition and lifestyle management, and use of metformin prophylactically. Thank you.
Thank you, Monisha. Yeah, we start on the proceedings of the oration.
Sir, shall I introduce, sir?
Yes.
Shall I introduce yourself and ma'am, sir? First?
Yes.
Yes. Good afternoon, everyone. So it's my highest privilege and honor to introduce our president and secretary who do not require any introduction. So, okay. Can it be put in the slide share?
Kishore, that black band keeps coming, Kishore.
Yeah, can you present it as one view, Kishore? Kishore, yeah.
It is
President and Unit Head Department of OBG, Sri Ramchandra Medical College and Hospital, Chennai, won the Indumati Javeri Award in 1994, Young Scientist Award, 1994.
Meena, you can make it short, Meena.
Okay, sir. He is the president, the dynamic president of Obstetric and Gynecology Society of Southern India in the last year, 2020, and he is chairperson of Safe Motherhood Committee, POGSI, 2017 to 19. Next. And Dr. Vijayalakshmi Gnanashekaran ma'am is known to everyone, very active academic person to OGSI, and she is associate professor at ACS Medical College and now executive committee member OGSI 2021. She is honorary secretary last year, honorary secretary TNFOG 2021. Field of interest is high risk obstetrics, adolescent gynecology, and infertility. I hand over the chair session to the chairperson Palaniappan sir and Vijayalakshmi Gnanashekaran madam and take over the proceedings. Over to sir.
Thank you very much, Meena, and we welcome Prof. Kypris Nikolaidis from the UK, and we've had him with great difficulty in logging in, and we are extremely happy and privileged to see you, Prof, through the web, and may we have the slides of Dr. Krishna Menon, and yeah, Kishore slides. This is Professor M. Krishna Menon, our doyen of South India. Slide. Kishore slides. The Obstetric and Gynecological Society of Southern India, and this is the 31st MKK Menon oration. Slide. Padma Shri Dr. M.K. Krishna Menon, an educationist and clinician par excellence, was born on 25th of January 1980. At the age of 30 years, he passed the BA from Zamorans College, Calicut, MBBS, DGO, MD from Madras Medical College. Slide. He was a research scholar and research fellow of the Madras University under the famous obstetrician and gynecologist Dr. Sir A.L. Mudaliar, and he served the country by joining the army to work as an emergency commissioned officer in the Indian Medical Wing from 1940 to 1945. From 1945 to 57, he worked in various capacities at different medical colleges in southern India, Andhra. He was an invented scientist and contributed lytic cocktail regimen for eclampsia, the standard care for many years. Slide. One of the original signatories is Memorandum of OGSI, organizing secretary of the 6th OGSI Congress, Madras, and 1958 to 61 he was the president of OGSI for 6 terms. He was appointed as director and professor of IOG, Madras Medical College, 1957-70, and the IOG earned its name during that time and retired from this post 1970, and thereafter he was appointed as professor emeritus at the same institute, and post-retirement he took various challenging positions both nationally and internationally. Member of the expert committee of the WHO on maternal and child health, member chairman of the Indian Council of Medical Research subcommittee on mother and child health, human reproduction and fertility control. Government of India appointed him as a committee member on MCH, fertility control and medical education. He was a committee member of the human reproduction of the FIGO in those days. He had 150 publications, co-authored along with Dr. A.L. Mudaliar the textbook of clinical obstetrics, postgraduate obstetrics and gynecology, and in 1968 was appointed as visiting professor at the Department of OBG, State University of New York, and visiting professor at the Department of OBG, Oxford University. In 1962, he was awarded Fellowship of the Royal College of Obstetrics and Gynecology. He became the president of Foxy Ahmedabad and vice president of the AVFOG in 1963 and Padma Shri in the year 1973. In 1983, he was the chairman of the organizing committee of the 27th Foxy Congress, Madras. In 1984, Sanjay Gandhi Memorial Award for MCHFP and founder fellow of the National Academy of Medical Sciences. He was also awarded the honorary fellowship of the AVFOG in 1987 and given the Kedarnath Das Golden Jubilee Oration of the BOGS. Slide. 1988, leaving a big legacy of students in the field of clinical OBG, Padma Shri M.K. Krishna Menon passed away at the age of 80 years. And we have been delivering this oration after some time, and these are the stalwarts who delivered the oration throughout from 1989. Slide. 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 And these were the slides. In 2015 was given by Dr. Jaideep Malhotra. Slide. 2019 by Dr. Evita, 2018 by Dr. Tony Tan, 2017 by Dr. Revati Janakiraman, and now we are in the year of 2020, that is the last year's oration, to be delivered by none other than Professor Kypros Nikolaidis from UK. It's an honor to have you, Prof. And now let's have Dr. Kypros introduced by Dr. Vijayalakshmi Gnanasekharan, our secretary.
Yeah. It's really a privilege to introduce you, sir. The moment we hear your name, we think of the Fetal Medical Foundation. They both are the same. Professor of Fetal Medicine, born in Cyprus, he studied medicine in King's College, London. He trained in obstetrics and gynecology and specialized in fetal medicine. He has been conducting extensive research in many aspects of fetal diagnosis and therapy, leading to publication of more than 1,400 peer-reviewed papers in scientific journals. He provided training in fetal medicine to more than 600 doctors from 50 countries and has supervised 55 doctors to undertake research leading to PhDs and MDs. In 1995, he founded the charity Fetal Medicine Foundation, which has donated more than $45 million to promote research and training in fetal medicine throughout the world. He is the recipient of many highly prestigious awards, including Iron Donald Gold Award and Early Holland Gold Medal of the Royal College of Obstetricians and Gynecologists, and honorary doctorates from several European universities. Most recently, in 2020, he was awarded a membership of the USA National Academy of Medicine. We are indeed very proud and happy to have you with us, Professor Kypros Nikolaidis. We are very, very happy to welcome you to deliver our most prestigious A.L. Mudaliar and Menon's oration. Thank you so much for joining us. Over to you, sir.
Prof, you are muted. Prof, please unmute yourself.
Yes, I hope that this is, thank you very much. I'm very grateful for this great honor. Unfortunately, you have had problems with joining in, so I will not use any slides. I was a medical student at King's College Hospital in the last year when a new professor arrived in our department, a young, enthusiastic Scotsman, a student of Ian Donald, and he gave a lecture on this new technology of ultrasound, and the year was 1979. And after the lecture, I was extremely excited by this new development. I asked him whether I could spend my elective. We had 3 months of an elective in the last year of the medical school. Most students would go to exotic destinations like the Seychelles or Hawaii. I decided to stay at King's in his department and to see what is this ultrasound about. Once I saw the moving images of the fetus on the screen, I immediately fell in love with this new field of medicine, because 1,000 questions were raised in my mind as to what is the relationship between the mother and the baby, how does the baby grow, what is the interaction between the mother and the baby, what happens when things go wrong. I, at that moment, acquired a purpose in life, because previously I was not particularly interested in medicine. Remember, in the 1970s in London, we were going through a period of turmoil. There were ruthless dictatorships in Latin America by the CIA, like in Chile. There was the Mandela movement in South Africa that Margaret Thatcher at the time, the Prime Minister of England, was referring to him and the ANC as a terrorist organization. And on the other side, under the USSR, there was a ruthless dictatorship in most Eastern European countries. So my interest at the time was politics. I was participating in demonstrations in London against dictatorships and for the freedoms of people. So medicine was not really my top priority. But after I heard that lecture of Professor Campbell, Stuart Campbell, after I saw the moving images of the fetus, I immediately fell in love with this new, potentially new field of medicine. I finished my studies and then I worked for a year to do my very junior house jobs. And then I became a research fellow in fetal medicine. Within a very short period of time, 2 or 3 years, already everything that we were seeing by ultrasound was a new experience. We were describing fetal growth, fetal movements, the diagnosis of various fetal abnormalities. By 1984, I introduced chordocentesis, which is ultrasound-guided puncture of the umbilical cord and fetal blood sampling, and we described the whole of fetal physiology. We were taking blood from babies that had various fetal abnormalities like exomphalos and diaphragmatic hernia for karyotyping, because at the time it used to take 1 month to get the results from amniocentesis, whereas by analyzing fetal blood and the fetal lymphocytes, we could get the results of karyotype within 24 hours. So we were doing fetal blood sampling for karyotyping, and I was using this fetal blood to also establish normal ranges of fetal hemoglobin, hematological, endocrinological, metabolic parameters, insulin, triglycerides, and so on. So we established what is normal in fetal physiology, and then we went on to study small for gestational age babies. And we were describing intrauterine fetal hypoxia, acidosis, intrauterine starvation, and a metabolic profile that was very similar to that of Kwashiorkor syndrome. This was then the middle of the 80s when Doppler was being introduced, originally by Professor Campbell, to look at the uterine arteries, and then with color Doppler, we could visualize various fetal vessels in the brain and in the periphery. And with Katia Bilardo, who was a colleague at the time, now the ex-president of ISWOC, working at the same department, she was doing Dopplers. And in cases where we are suspecting fetal hypoxia, I was confirming that by taking a fetal blood sample. So we had a direct correlation between fetal Doppler parameters and fetal blood gases. So it was the best confirmation on the value of fetal Dopplers. By the same time, I was devoting a lot of my time on fetal therapy. And the most important condition at the time was red cell immunization. A lot of babies were dying because they were becoming anemic from isoimmunized women. So with chordocentesis, I introduced a method where we could take a fetal blood sample, measure the fetal hemoglobin concentration, establish normal ranges of fetal hemoglobin, and then looked at fetal anemia predicted by Doppler, and then giving fetal blood transfusions. So babies that would have otherwise died were now being saved, and the condition where the death rate was 90% or more now was converted into a condition where the survival rate was more than 90%. Also in the 1990s, we were seeing by ultrasound now various collections of fluid within the fetal cavities. We were seeing fluid in the pleural cavity. We were seeing fluid in the bladder, obstructive uropathy, pleural effusions. And we developed techniques where we were introducing thin catheters into the pleural cavity to drain the fluid into the amniotic cavity. And that has remained a very good success story that it is being used today in babies with pleural effusions. We were also placing shunts in babies with obstructive uropathy, but unfortunately, that is an area that has not been proven to be useful. I'm discussing now 1980s, so 40 years of clinical practice where various centers have been placing shunts in the case of obstructive uropathies with no clear evidence of benefit from such treatments. We were then coming to the beginning of the 1990s. At that time, I was doing a study comparing amniocentesis, early amniocentesis, with chorionic villus sampling. Why that? Because I felt that it would be silly to wait until 16 weeks to do an amniocentesis. Why not do an amniocentesis at 12 weeks? The reason why in a previous era, in the 70s and the 80s, people were doing an amniocentesis at 16 weeks is because they were not using ultrasound. So they had to palpate the uterus, they could feel it, and then introduce blindly most of the time a needle into the uterine cavity. But now with ultrasound, there was no reason, I thought, why we couldn't do an amniocentesis at 10 and 11 and 12 weeks. So I was conducting a trial comparing amniocentesis early against CVS to see which is the better technique. And we found actually that by doing an amniocentesis at 12 weeks, we were increasing the rate of miscarriage because the amniotic membranes were not attached to the uterine wall. And there was still an empty space, the coelomic cavity, and that was causing leakage of amniotic fluid and a miscarriage. So CVS was found to be the safer technique. At that time, one day, I noticed a black space behind the fetal neck, and I thought that looked a bit strange. I was lucky because the woman was taking part in the trial, and 24 hours later, I was told that the baby had Down syndrome. So I thought, is it at all possible that there is a connection between Down syndrome and this collection of fluid behind the neck? I was reminded of what I had discovered in 1986, when again, by almost accident, I noticed one day that there was a strange shape to the head and the cerebellum in a baby that was subsequently found to have spina bifida. That was in 1986 when I described the lemon and banana signs of the head and the cerebellum as important markers of an underlying spina bifida. And here we were in 1992, where I was suspecting that perhaps this black space behind the neck, nuchal translucency, was going to be an important marker of trisomy 21. We spent the next few years studying 100,000 pregnancies to find out whether that observation was correct. And not only did we find that increased nuchal translucency was an important marker of trisomy 21, but also of many other chromosomal abnormalities, genetic syndromes, fetal malformations, diaphragmatic hernia, skeletal lethal abnormalities, cardiac defects, and genetic syndromes. So nuchal translucency then became the method of screening throughout the world. And I know that many, many colleagues in India have been using that in the last 30 years as a method of screening for chromosomal abnormalities. Also in 1992, I was very frustrated by the fact that we had another patient presenting with twins and polyhydramnios, where we were making a diagnosis of twin-to-twin transfusion syndrome. We were allowing these patients to carry on, and they were often miscarrying, or the babies were born and they were handicapped. What we could do at the time was do an amniocentesis to drain the excessive amniotic fluid from the recipient twin. But again, the pregnancies were ending with death or handicapped babies, and I was frustrated by that. At that time, in London, where my research fellows were Yves Ville, now a very famous professor in Paris, and Kurt Herker, a famous professor in Germany. And one night, when we had another patient with twin-to-twin transfusion syndrome, we decided to try something new. And the something new was to introduce an endoscope inside the uterus. I was good in endoscopy because in the early 1980s, that was the method by which we were taking a fetal blood sample to diagnose beta thalassemia and hemophilia. We were doing fetoscopy, looking at the umbilical cord and puncturing it to take a fetal blood sample. Of course, that became obsolete at the end of the 80s because you could now diagnose these conditions by molecular biology and DNA. But I kept my fetoscope in a museum. Museum means a drawer in my desk at home. So that night I decided to go home, pick up the endoscope and see whether you could put the endoscope inside the uterus and identify the connecting blood vessels between the two twins. And indeed, we used then laser that we stole from the ophthalmology department that night. And at midnight of December 1992, we carried out the first endoscopic laser surgery to separate identical twins. I was delighted that the babies survived, and that event is an episode in the surgeon's cut in Netflix, the history of the first endoscopic laser surgery. Many thousands of babies have been saved now throughout the world using this method of fetal intervention. We spent most of the 1990s perfecting the methodology for screening for chromosomal abnormalities. And my obsession had then become that we must train people and we must ensure that people that offer nuclear translucency do so properly. Otherwise, this important invention could be abused by anybody pretending to know what they're doing and actually causing a lot more harm than good. And that is why I established the Fetal Medicine Foundation. What is this Fetal Medicine Foundation? I decided to open up a private clinic, and all of the income from the clinic went into the Fetal Medicine Foundation so that I could give scholarships to people from all over the world to train and also establish a system of certification and audit of results that was offered to doctors from all over the world free of charge. So doctors had to attend a theoretical course free of charge, send images every year to confirm that they knew what they were doing free of charge. And in exchange for obeying these ridiculous rules, they were receiving software with which they could become very wealthy. And indeed, many people became wealthy using this approach. So that was in the 1990s, perfection of the techniques, certification and training in nuclear translucency. Of course, the years went by, and in the last few years, cell-free DNA testing has introduced itself into the market as the most accurate method of screening for chromosomal abnormalities. But in most countries of the world, we have the combined test, which combines nuclear translucency, maternal age, free beta HCG, and PAVA as the primary method of screening 30 years on. And then on the basis of the results that you get from there, people are now having the offer of having non-invasive cell-free DNA testing as a method of diagnosing or refuting the suspicion of a chromosomal abnormality. So that is the story around the chromosomal abnormalities. Soon after the association of nuclear translucency with chromosomal abnormalities was assessed, we were beginning to realize that when we do an ultrasound scan at 12 weeks, we can do a bit more than just look at the black space behind the neck. In the meantime, the technologies had improved. We could see a lot more of the fetus. And we introduced the idea that we should look at the fetus, not just the neck. And we could diagnose a series of fetal abnormalities in the first trimester. And in a study that we published last year involving more than 100,000 pregnancies, we established a list of the conditions that should always be detected by a proper, routine 12-week scan, like anencephaly, hypoplastic left heart, body stock anomaly, severe obstructive uropathy. So we have seen then a shift during the last 20 years of ultrasound scanning for the early diagnosis in the first trimester at the back of nuclear translucency screening of a wide range of major fetal abnormalities. We were then beginning to realize that in women where the nuclear translucency was increased, but the baby's chromosomes were normal, there could be other conditions. So we advanced a methodology of follow-up of these patients to diagnose cardiac defects and other abnormalities and genetic syndromes. Also, we realized that if the baby looked normal and the biochemistry was abnormal, meaning that the free beta HCG was increased or the PABA was decreased, then it was possible that something else was wrong with the pregnancy. We were realizing that in pregnancies where the PABA was very low and the chromosomes were normal, there was a much higher risk that these women will miscarry, or they would end up with a stillbirth, or that they would develop preeclampsia. So, stimulated by this, I spent a lot of the time in the year 2000 developing an approach where we could combine the information from the maternal history together with the findings of the 12-week scan to predict preeclampsia. So after many attempts, we managed to come up now with a new approach that we use the 12-week scan now not to diagnose fetal abnormalities, but to predict pregnancy complications. And that is when we combined maternal history together with the measurement of PABA or subsequently PLGF, placental growth factor, together with the measurement of mean arterial pressure and uterine artery pulsatility index to achieve a new method where we could identify at 12 weeks the vast majority, 90% of the women that will develop subsequently the most severe type of preeclampsia before 32 weeks. About 75% of preeclampsias before 37 weeks, preterm preeclampsia. And then the question is, great, now that we can identify these women at 12 weeks, what can we do about it? And that culminated in a major study that was published 5 years ago now in the New England Journal of Medicine, the ASPER trial, where it took nearly 30,000 women. We screened them using this new approach in the first trimester, identified the high-risk group, and then randomized them into aspirin 150 milligrams per day versus placebo. And we found that in doing so, we can reduce the risk of very early preeclampsia before 32 weeks by 90% and preterm preeclampsia by about 60%. So to a great extent, we were beginning to have a major impact on the prediction and prevention now of the most severe types of preeclampsia. We were, however, left with the problem of preeclampsia at term, because screening in the first trimester was not great in identifying the women that would get late preeclampsia, and aspirin could not prevent late preeclampsia. So we went on to screen women now at 36 weeks for term preeclampsia, and we completed recently a big study of screening 30,000 women and giving pravastatin, 20 milligrams per day versus placebo in those at high risk of term preeclampsia. Unfortunately, that study showed that pravastatin was not effective, and the results were presented last month in the most prestigious cardiovascular journal of Circulation. So we are still left with the challenge of what to do to prevent term preeclampsia. In the meantime, I learned that all women should have a minimum of 3 ultrasound scans in pregnancy. One at 12 weeks for early diagnosis of major fetal abnormalities and assessment of risk for chromosomal abnormalities and preeclampsia, a scan at 20 weeks for fetal anatomy, and another scan at 36 weeks. Why 36 weeks? I call this the birth plan scan. It's the scan that will diagnose undiagnosed breaches. In my hospital, King's College Hospital, half of the babies born with a breach are diagnosed during labor. Half of them are missed by the antenatal period assessment, clinical. So I now believe that all women should have a scan at 36 weeks to look for breaches, to see whether the baby is very small or very big, if the amniotic fluid is reduced or increased, and importantly, also to screen for preeclampsia. And I believe that this is the only way in which we can prevent the high rate of stillbirth. England, unfortunately, has one of the highest rates of stillbirth in Europe. They call them unexplained. For me, they are not unexplained at all. They are late onset fetal growth restrictions or macrosomias because of diabetes. I was listening to the last lecture on gestational diabetes and its importance. So that is then where I have evolved things into the routine scans in pregnancy. In 2010, I realized that the biggest problem in obstetrics, of course, is preterm birth. So I was very anxious to see whether we could develop a method to identify women that would deliver very prematurely. So I carried out a study involving 50,000 women to establish that there's a very good relationship between cervical length in the second trimester and subsequent risk of premature birth. And then a series of studies in subsequent years where I took women, I screened them for cervical length at 20 weeks, and then we randomized them into cervical cerclage versus expectant management. We found that if the cervix is less than 25 millimeters, cerclage is useful in women that had a previous history of preterm birth. It reduces the risk of recurrence by about 30 to 40%. In women that are found to have a short cervix without a previous history, then we conducted a study. The results were published in 2007 now. It's many, many years. It's 15 years in the New England Journal of Medicine, where we showed that giving progesterone to these women reduces the risk of premature birth by about 40%. A subsequent study by Roberto Romero in the United States has confirmed the results. And that is now the established method of screening for preterm birth, measurement of cervical length at 20 weeks. And if the cervix is less than 25 millimeters, give the women progesterone, 200 milligrams every night vaginally, not 17-hydroxyprogesterone intramuscular injections that have been found not to be useful, vaginal progesterone, and reassess these women a week or so later. If the cervix is stable, great. If the cervix is now shortening, then you can consider also inserting a cervical cerclage. Then there was a question whether introducing a pessary, the Arabin pessary around the cervix, could do the same job as a cerclage. One study from Spain suggested that this is a fantastic method of prevention. We repeated the results and we published them in the New England Journal of Medicine, and we have found that this is not effective. So, as far as preeclampsia is concerned, we now have a method of early identification of the high-risk group and prevention. As far as preterm birth is concerned, we have a method of prediction from the measurement of cervical length at 20 weeks and treatment with progesterone to prevent this problem. In the last 10 years, we have been continuing to see whether we can improve the prediction and prevention of preeclampsia and preterm birth. And in terms of fetal surgery, in 1980, a great man that I admire, a pediatric surgeon, Michael Harrison, in San Francisco, had carried out animal studies where he put a balloon inside the fetal lung and inflated in the chest and inflated it. And he found that these babies were dying after birth because of pulmonary hypoplasia. This was an animal model for diaphragmatic hernia. He then did the same, and a few weeks later, he would deflate the balloon, and he showed that the survival rate was improved, proving that if you have a diaphragmatic hernia in the animal model and you treat the condition in utero, you can potentially prevent neonatal death. He went on to develop a method in the early 90s where he carried out a hysterotomy, brought out babies with diaphragmatic hernia, corrected the lesions, and put it back in a heroic way into the uterus. The babies, unfortunately, were not surviving by this method because the most severe types of diaphragmatic hernia, where the liver is herniating into the chest, when you try to bring the liver down, you are kinking the umbilical vein, and these babies were dying. In 2000, animal studies were beginning to show that an alternative method of treatment for diaphragmatic hernia was to introduce a balloon into the fetal trachea to prevent the fluid that is normally produced by the lungs into the amniotic cavity. The lung fluid would be retained within the lungs. It would expand the lungs, push the gut out of the way, partly, but most importantly, stretch the lungs, and by stretching them, stimulate lung growth. In 2002, I had a patient that came from Cyprus, my country. She was in her 40s. She had infertility, and then eventually she got pregnant. The poor woman had a baby with a severe diaphragmatic hernia, and they called me to see whether there was anything we could do. They said, I don't think that the baby can survive. It was very severe, but we can try something new. So I called my good friend, Eduard Gratakos from Barcelona, and Jan de Prest from Leuven in Belgium, that were carrying out animal studies for the insertion of a balloon. And they said, look, I have this patient, and I think we must try now. We have done enough animal studies. Now we need to see whether this works or not in the human. We did not know how we would do this. We did not know whether it would work or not. We were very scared. So we asked the woman to come at 33 weeks. And the logic for that is that if things went wrong during the procedure, at least you could deliver the baby and give it a chance rather than die in utero. But that logic was a stupid one, because in an attempt to potentially save a baby, we selected the late gestation. That was too late. We carried out the operation. It went very, very well. But unfortunately, a few weeks later, the baby was born and it died. We learned how to do it. We learned that it's not dangerous if you know what you're doing to insert the balloon in the trachea, but you also learned that 34, 33 weeks was too late. So in the next few cases, we went in at 26 to 27 weeks. We then spent the next 10 years. This is what it takes sometimes to establish a new method. It took me 10 years nearly to collect the 100,000 cases in the instance of nuchal translucencies to establish the new method of screening. It took 10 years to perfect the technique of introducing a balloon in the fetal trachea. And then we had a challenge. People were saying, yeah, but how do you know that this really works? So we had to prove it. And we started the randomized trial that lasted another 10 years. And in June this year, we published the results in the New England Journal of Medicine, again, where we proved that in severe diaphragmatic hernia, we have a dramatic improvement in the survival rate by putting in a balloon. Still, many babies will die from severe disease, but the survival rate improved from 15% to 40%. So still, the majority of babies will die, but a lot more will survive with than without this treatment. 20-year story to introduce a new method of treatment. A big challenge that we had, coming from Cyprus, we have what is also common with India, a lot of patients that have thalassemia. 1 in 10 people in Cyprus are carriers of beta thalassemia. I grew up with classmates of mine suffering from this horrible condition where they needed to have blood transfusions, and then they were dying in their 20s and 30s from the toxicity, from iron toxicity from the repeated blood transfusions that they needed. So I was always dreaming of the day where we could prevent this condition, and we did by early prenatal diagnosis and termination of the pregnancies, but I'm also dreaming of the possibility of correcting this condition in utero. So in 1992, I tried to do an intrauterine marrow transplantation with the rationale that I could change the blood group of the babies. We could change the babies so that they would have the production of normal hemoglobins. And I tried that at 17 weeks, and I then went on to do it at 12 weeks. And I found that, unfortunately, it was not possible. I was unsuccessful in producing a successful chimera. What is chimera? Chimera is from the Greek mythology, where you have a half man and a half animal. Chimera, in this concept, of transplantation is for the body to produce two different groups, a normal and an abnormal. The abnormal that is genetic in you, but the normal that you have transplanted, and they coexist. And unfortunately, we were not able to establish a successful chimera. What I did not realize, however, that was extremely important at the time, is that we established a tolerance. What is tolerance? If you expose an individual that is immunologically naive to a foreign body, then as they become immunologically competent, they will recognize the foreign body as self and they will not reject it. And people got a Nobel Prize for this concept in 1953, this intrauterine marrow transplantation in mice. So there is a lot of research now by colleagues of mine in San Francisco, where they are doing intrauterine marrow transplantation for alpha thalassemia, establishing tolerance on the basis of our research from 1992. And then once you become tolerant in utero, you can do definitive postnatal marrow transplantation without the need for immunosuppression and irradiation that carries many other side effects. I have taken you through a trip that has been my journey, a journey that takes a medical student that is not really interested in medicine and is much more interested in politics in the 1970s, being inspired by one lecture. Sometimes in life, we just need one lecture to meet one person that gives us a direction. And for me, that was my teacher, who's still alive and still full of enthusiasm and a very young brain, Professor Stuart Campbell. And then be in the right place at the right time. And I was a young doctor, just qualified at King's College Hospital, where at that time was the Mecca of ultrasound. Everything we did was new. And we developed the scientific methodology of observing things and then proving whether they were right or wrong. We went through the 80s, blood transfusions for rhesus disease, shunts for pleural effusions that have survived the day. We went through the 80s of validating by blood gases the results of non-invasive assessment of fetal oxygenation and anemia by Doppler. We spent the 1990s by perfecting the techniques of laser surgery for twin-to-twin transfusion syndrome and introducing nuchal translucency that has now shifted prenatal diagnosis into the first trimester. We then went on to introduce new methods of surgery like diaphragmatic hernia that took us 20 years to prove the value in the severe cases. And prenatal diagnosis of suspicion of preeclampsia and prevention in the most severe types by giving aspirin in those with a high risk in the first trimester, prenatal assessment of the risk for preterm birth, and prevention to some extent by giving progesterone. So for me, the journey has been extremely excited. People often ask me, would you have done something different if you had the opportunity? And I would say, but why would I want to do anything different when my life has been so fulfilled? And I was so lucky to be in the forefront of research and exciting new developments in medicine. I thank you very much for this honor and this opportunity to address your meeting and give this important oration. Thank you very much.
Thank you, Professor Kypros Nikolaidis. That was fantastic, where the ERA has used slides now to talk to people and to make presentations. I'm awestruck by the way you gave the oration, because we've not had an oration without slides, and I'm not sure whether any of us could hold the audience without slides, and that is what Kypros Nikolaidis could do, because he could hold the audience for the last 35-40 minutes only on lecture, and that is what the charm is, and that's what the grace you have, and that's the talent you have to hold the entire audience by just talking to us. And that was fantastic. The story of fetal medicine and how from a politician you could change to an academician to that of a fetal medicine person, and that was very, very nice indeed, and we're extremely honored to have you here with us. And Vijay, can we have the plaque being read?
Yeah.
Yes, the Obstetric and Gynecological Society of Southern India, Chennai, 37th Annual Conference, Professor M.K. Krishnamenon oration delivered by Prof. Kipris Nicolaidis, 28th August 2021. This is the silver plaque which is ready with us. We will see how it will reach you, Prof. And it is indeed our honor to have you. And thank you very much for your presence. And we are very much honored by your presence.
We are extremely honored and thankful to you, sir. And our sincere thank is we owe to Professor Stewart, who's behind all this, bringing you to this forefront like this with that one single lecture which you said. Thank you so much, sir. Thank you for being with us. Thank you.
Let me also acknowledge the help done by Dr. Gauri Shankar, who put us you, and of course your secretary, Eliza Tilke, who was constantly in touch through emails and WhatsApps. And thank you very much to both of them who have been instrumental in bringing you here to this particular oration. And MKK oration is honored as well.
Thank you very much. Thank you.
Thank you very much, sir. Thank you very much.
Thank you.
Meena, you can take over.
Thank you, Palani ma'am and Professor Nikolai sir. Many of us have done pieces from his inventions. And thank you. And now we move on to the next session. Session 6. Can I call upon Dr. N. Tamil Selvi ma'am, Professor of OBGYN at IOG, UG PG teacher for the past 21 years, trained in laparoscopy and colposcopy, field of interest, high-risk obstetrics and laparoscopy. Next, Dr. T.S. Meena ma'am, who is Professor and HOD at IOG, UG and PG teacher for the past 25 years, master trainer. NCD training program, area of interest is high-risk obstetrics. And former member board of studies at Tamil Nadu Dr. MGR Medical University. And next, Dr. B. Shantirani ma'am, Associate Professor of Theni Medical College, President, Talks Theni, UG at Thiruvannamalai Medical College. She is alumni from Madras and Madurai Medical College, founder treasurer of Theni OG Society, Secretary Theni OG Society, organizing chairperson, colposcopy, 2015 ARtCon, 2017 Eagle Project, organizing joint secretary, Endogyne Theni 2017, awarded Doctor of 2013 by IMA Theni, faculty in ACOG 2008, published research papers in various Indian and international journals. Over to you, chairpersons, to introduce the speakers and take over the session. Thank you, ma'am. And Dr. Monisha has already presented the Sprout, ma'am.
Okay, so the next topic will be cardiovascular diseases and pregnancy. We know that cardiac diseases contribute about 1 to 4% of pregnancy, and we are all aware that the compromised cardiac function is unable to cope with all the stress of pregnancy and labor, and definitely it contributes to maternal mortality and as well as morbidity and fetal mortality and morbidity. And of course, the successful pregnancy outcomes have come with efficient prenatal and antenatal care. And the next speaker is Dr. Jaya Vijayaraghavan, who will be talking about screening of cardiovascular diseases in pregnancy. And Dr. Jaya Vijayaraghavan is a professor of OBGYN, Sri Ramchandra University, Chennai. And he has been in charge of OBGYN unit since 1994, doing all major gynec, obstetrics, emergency, oncology, and laparoscopic work. And of course, she's been teaching and training undergraduates and postgraduate, and has been examiner in various universities. I'm handing over the mic to Dr. Jaya Vijayaraghavan.
While Dr. Jaya is sharing her slides, we also need to tell her that Dr. Jaya is in charge of the obstetric medicine course, which Ramchandra has introduced very recently, and she's the course convener, and obstetric medicine is her passion. And so let me put that word to this august audience who are here, and over to you, Jaya ma'am.
Thank you, Dr. Meena and Dr. Painappan, for those kind words of introduction. I would like to first thank the organizers for giving me this opportunity. And after a brainstorming oration, I do not know how much justice I would give to the topic, but however, I will try to do so. Cardiovascular disease, as rightly pointed out, is on the increase. And we do not have any screening method in place for those who have no cardiac disease. We do have algorithms in place for those who have already have a cardiac disease, but we have none. But before going on to those aspects, we need to justify whether we really need one. So to start, why do we need to screen patients without any cardiac disease? There is increasing mortality to cardiac diseases in pregnancy in the Western world. Hemorrhage is still our major problem. But however, if you see the incidence of cardiac disease, it is on the rise. And there are textbooks which have quoted anywhere 0.5 to 3.2% as the incidence of cardiac disease in pregnancy. So the diseases are on rise more because women are getting pregnant at an elderly age group and they are having comorbids like hypertension and diabetes. The congenital heart disease are now being corrected and all these patients are now coming into the childbearing age, posing problems to us as a cardiac disease complicating pregnancy. I put before you 3 scenarios, all real life situation to put you into thought whether we really need one, how do we go about it, when do we do the screening and other aspects of it. We had a 30-year-old primary gravida with no known comorbids who had an incidental 2D echo at 32 weeks and found to have an ASD. She did not have any other problems through labor or postpartum period and went on to have a healthy baby, a healthy mother and a healthy baby. So this puts us to thought whether we should have really done a T2 echo and caused the confusion, and now she's under cardiology consultation. The next was a 25-year-old primary gravida who complained of breathlessness in labor, and on auscultation she had a harsh systolic murmur, and the problem was that none of us really bothered to auscultate it in the trimesters. And this brings us to the importance of a clinical evaluation of any patient who comes to the OPD. She had a very stormy intranatal and postpartum period, and however went home with a near miss. The 35-year-old 32-weeker who was absolutely normal had again an incidental echocardiography, which is now a fashion in many institutions. But she was absolutely normal, went through pregnancy well, but in the immediate postpartum period, she developed breathlessness and was diagnosed to have PPCM. So in this case, the echo was not ordered at the right time. And we all become complacent. Both the patient and the doctor become very complacent as soon as the patient delivers. And this is one eye-opener where we should be continuously monitoring all patients even after their delivery. Now coming to the aspects of the screening in a non-cardiac patient, is it really necessary and do we have systems in place? And do we really have to screen a subclinical cardiac ailments? We do have systems in place for known cardiac patients like CARPREG, Zahara and modified WHO for patients who are known cardiac disease. But this is not the same for those who do not have a cardiac disease and they are suddenly diagnosed in pregnancy, resulting in a near miss as it happened in 2 of our cases. Now, this is the overall Zahara, CARPREG and WHO modified scoring, which we have for cardiac, and we have none such scoring for a non-cardiac patient. So the questions which bring to us is, should we screen at all? Is there a problem with recognition? If we have sorted out these 2 problems, when we should screen, how do we screen, and how do we follow up these patients once they become screen positive? Now, coming to the first thing, should we screen at all? If we look into the cardiovascular changes in pregnancy, we find that there are profound changes in the cardiovascular system, which starts as early as 5 weeks of gestation and it continues in the intrapartum period as well as in the postpartum period. So the changes which occur in pregnancy in the cardiovascular system are profound and found throughout pregnancy and even in the postpartum period. The ejection fraction goes up, remains the same, so CVP remains the same, the BP falls, and all these changes we are all well aware of it. And this is the summary of this. And even to talk to our problems, we have the colloid osmotic pressure, which goes down and results in pulmonary edema in these precarious patients who are on a precarious balance. So these profound changes can shift the balance at any time, and an asymptomatic or subclinical patient with no known cardiac disease becomes symptomatic. the pregnancy thus is a natural stress and it offers a window of opportunity as it does for GDM and for preeclampsia, and we should make use of it. I think I have managed to convince you, all of you, to say that a screening test for cardiovascular disease needs to be in place for all women who are pregnant. Now, what are the problems? We have multiple problems in recognition. The common symptoms in pregnancy like fatigue, palpitation, shortness of breath are also there in a normal pregnancy, and it's there adds to the confusion whether she is normal or whether she has a cardiovascular disease. Not only that, even the clinical examination, patient can have edema, she can have drop beats, she can have change in the apex beat, she can have the change in cardiac contour on palpation and percussion. And the heart sounds also add to our confusion. You can have a soft systolic murmur, a third heart sound, ejection murmur, and a mammary shuffle. And all this will add to the confusion to recognize whether she is normal or abnormal. Even the investigations, the ECG also has its own problems like left axis deviation, T wave in ST changes, T inversion, and Q waves in certain leads. And we have to recognize normal from abnormal. Echocardiography, however, is a very safe non-invasive method. And even there we have to know the changes from normal, changes of a normal pregnancy, like increase in the left ventricular mass. There are regurgitated murmurs on the right side, predominantly on the right side. And many of them continue through the late gestation and early postpartum. There are enlargement of the stanger, annular dilatation of the valves, and pericardial effusion even in a normal pregnant woman. And we should know about the ejection fraction, what is normal stroke volume, what is functional shortening, what is EA ratio, and deceleration time, and ventricular mass. All this, if we have a knowledge of all this, then we can definitely differentiate normal from abnormal echocardiography. So echocardiography is a useful tool for us to recognize cardiovascular diseases in pregnancy. It enables us to distinguish physiological from pathological, but we must be well versed in reading the echocardiography. 3D echo has now been introduced, but still it is not the order of care. However, we cannot say that echocardiography is end all of all screening procedures for cardiovascular disease. It has to be ordered at the right time, and which was not done in the third case of ours. So once the abnormality is detected, we are still not without problems. We have the BNP, NT-proBNP, which we all take into consideration. But these are also have tremendous changes in pregnancy, which we need to be aware of. We can also resort to exercise testing at 80% of the 80%, and also in MRI whenever necessary. So now, thus we are now convinced about two aspects. Screening, that we require a screening for all patients for cardiac diseases. We do not have a standard approach in place. And we also need to develop a cardio-obstetric team in every tertiary care center when the patients are referred to us. Now that brings us to the problem is how to screen. There are certain tools which have been developed over time which have not been validated. And we could use these tools as a basis and form our own tool screening system to help these patients out and take care of them through pregnancy, postpartum, and even after that. And I will just describe a few tools which have been put forward in certain textbooks. So this is one of them. This just describes based on the signs and symptoms. And in the first two columns, if you see, they are the patients are not known to have any cardiac diseases. They report mild symptoms. And in the first of them, there is shortness of breath, but no limitation in activity, chest pain, which is resolved with antacids or posture, palpitation, which is self-limiting. The vitals remain much within the normal range, and there is a soft systolic murmur, which is all normal. Yet the patient comes with some complaint, and we can be absolutely sure that this patient has no cardiac ailment, and she can be reassured and sent home. The third column, if you see, the second column, if you see, again is a patient who has no known cardiac disease, but has a slightly higher symptoms. She has moderate exertional dyspnea. She has new onset asthma. She has a atypical chest pain, and her BP is slightly on the higher range with a heart rate of more than. This patient definitely requires further evaluation, but however, it is not an emergency evaluation. The third column, if you go to see, is those with red flags. The patient has paroxysmal nocturnal dyspnea. She has chest pain at rest. She has a high BP. She has high heart rate. She has high respiratory rate. And these are the patients who require to be immediately followed up. And if you go deep into the history, they may even have a history of cardiovascular disease. So these are the patients with red flags, which all of us may be able to recognize quite easily. So there were two tools which were developed by the California Department of Public Health, and first one had all red flags, which I already told you. The patient had shortness of breath, she couldn't lie down flat, she had a high heart rate, a high diastolic BP, which all of us would recognize as an abnormal sign. But what was very intriguing in this tool was that, and this is how they followed the algorithm. Once they had red flags, they were immediately evaluated and sent to a cardiology team. And those who already had past history were, of course, sent to a cardiovascular team. So this was the tool which they developed, and it was a funded project, and it was developed in collaboration with the Maternity Quality Care Collaborative Cardiovascular Disease in Pregnancy and Postpartum Task Force. But what was most important in this, they analyzed this and it was validated in 64 maternal deaths. And they found the problem. What was the problem? That despite they had warning signs, they had red flags, in 45% of them, PPCM was not discovered. Probably they became complacent as soon as the patient delivered and failed to recognize the problems. There was this delayed response and treatment in 60% of these maternal deaths, a misdiagnosis in a third of them, and a failure to consult in a fourth of them. So this was the problem. They analyzed the problem. And even if you have red flags, we have to have the mindset to see that this is not abnormal and we need to refer them to a higher center in case we can't manage them. There was yet another algorithm which was developed without red flags in patients who had no known cardiac disease, and they had scored these symptoms and then had given an algorithm, which I'll come to later. And in this, ECO formed the basis of their treatment. Validation of this tool is yet not done. It is under validation, and we may get an answer shortly. This was developed by the same group, and they divided into 4 columns, one based on symptoms, one based on signs, one based on risk factors, and the 4th column where they already had cardiac murmurs. And and again, the symptoms were divided into those suggestive of cardiac failure, those suggestive of arrhythmias, and those suggestive of coronary artery disease. And the symptoms are all there on the slide for you to see. The next was the vitals. Of course, here again, the heart rate was high, the BP was high, the respiratory rate was a little high, and the oxygen saturation had dropped a little. And these are the risk factors which they put forward: age, BMI, pre-existing problems, substance abuse, and use of toxic chemotherapy like doxorubicin. They gave one point to each of the abnormal symptoms, and they gave a score. And if the score was more than 4, they felt that these patients should be referred to a cardiac care team. Patients who had abnormal murmurs and basal creps were directly referred to a obstetric cardiac team. And this is how they followed. If they had a negative, the score was less than 4, and it was screen negative, and they just followed up the patients. Wherever there was an abnormal score or the heart sounds showed a diastolic or any other abnormality, they were referred to a cardio-obstetric team. This tool was analyzed by Sander and Off in 846 patients, and they found that 8 patients were screen positive. That means as high as 64 patients, 65 to 70 patients were screen positive. And of these, there were 30% who had a cardiac problem and had required further follow-up. So this gives us an eye-opener that by using this tool, we can at least pick up at least 2 to 4% of patients without any symptoms who can develop cardiovascular problems in pregnancy because of the profound cardiovascular changes which occurs during pregnancy. So this is the algorithm which I followed, which I've already elaborated in my previous 4 slides. So to summarize, there is a definite need to screen pregnant patients for cardiovascular diseases. A thorough history taking and clinical examination is a must and it cannot be replaced. Ability to recognize normal from abnormal signs and symptoms is a must. And follow up at every visit, even if the previous visits were normal for cardiovascular system, should be done. Look for abnormal signs like pathological edema, abnormal heart rate, respiratory rate, and new murmurs on auscultation. At least every trimester, the patient should be auscultated. And with this corona times, I find no postgraduate carrying a stethoscope, no one auscultating a patient. And I think that trend has to change. We could devise our own scoring system in the model outline, and with our society bodies, we could probably devise a scoring system and further simplify it to use in the peripheral center for early referral. It's time for us to start a cardio-obstetric team available in most of the center who could take care of these patients. We should order echo at the appropriate time and other investigations as I have already outlined. A knowledge of the normal ECG, echo changes in pregnancy is essential. Arrive at a diagnosis, chalk a plan of action to manage these patients in the antepartum, intrapartum, and postpartum period. So don't forget that these patients may have residual problems and need to be followed up even postpartum with the cardiologist later on in life. To conclude, the window of opportunity offered in pregnancy, if utilized wisely, subclinical cardiac problems can be identified and can go a long way in preventing maternal mortality and morbidity. So I hope I have convinced you to the need for a screening protocol, which all of us can put our heads in and develop, just as we have developed the dystosis score in pregnancy. I thank you very much for this opportunity, and I hope I have managed to convince you to screen all our patients for cardiovascular disease. Thank you once again for the opportunity.
Thank you, madam. I think it was a very enlightening lecture, and I think you've convinced most of the audience about the importance of screening. In fact, one of the aims of the Tamil Nadu Pregnancy Heart Registry is to devise a scoring system based on the risk factors, based on the study which is being conducted in various government medical colleges and I think even SRMC also. So maybe the findings, you can have a better scoring system based on that. Thank you, madam. I think the next session, Dr. Shanti Rani.
Yeah, madam. Yeah, madam. Very good evening to all. Can I have the CV of Sambat, madam? Madam doesn't need any introduction at all. She's the secretary of TNFOG, founder secretary of TNFOG, national correspondent editor of JOXI, and she's the chairperson for OGSI Adolescent Health Committee from 2016 and 18, and director and professor of Institute of OBGYN, Madras Medical College, president board of studies, OG Tamil Nadu, Dr. MGR University, and ICOG governing council member from 2015 and 20. I know madam for so many years, and she's a tireless worker. I want to say a lot about her, but there is no time limit, and the topic is induction of labor. And we know that for induction of labor, when only the shortening of the pregnancy outweigh the risk of continuation of the pregnancy, only that should be induction of labor. There should be a definitive indication, and there should be no contraindication for a vaginal delivery. I know this madam is the pioneer in this topic. I think she will enlighten this so many aspects. Thank you, madam. Over to you.
Thank you, Dr. Shanti Rani, for your nice words. 1 minute, I'll share my screen. Is it visible? Yes.
Yes, madam. Yes, madam. You are visible.
Good evening to all. First of all, I thank Dr. Palaniappan and the organizers for the opportunity. And Shanti Rani, madam, I am retired from government. I was a deputy director and now present director is Dr. Vijaya. Okay.
Former director. Anyway, you are having the credit of former director, madam.
Anyway, okay. Now we'll come to the topic. The topic is the induction of labor. What is failed induction of labor? Why? And how it has to be managed. So if because the topic itself has the answer. Proper induction, no failure. Selection of the cases is very, very important. So the labor induction is what, with the use of medications and methods, we are creating the pain to the patient, a term patient, who she is not in labor. The ripening the cervix will help the cervix to soften and thin out the preparation of the labor. Mostly about 20% of the pregnancies go for induction. And of this, induction takes in 20% of the pregnancies. This is the fact. That is induction, 20% only is failure. But real fact, practically 40 to 50% of our indication for LSES will be failed induction. Why it happens? See, in the current practice, what is failed induction? It is diagnosed when the woman does not enter active labor, or the cervical score does not improve, or the cervix does not dilate more than 3 centimeters after a 12-hour period of artificial rupture of membranes and good uterine activity and oxytocin infusion. So what Foxy tells the failure when there is no good uterine contraction after the protocol, that is 3 gel or full catheter, whatever the protocol, if there is no good progress, it is the induction. What are all the methods we can go for induction? As all of us know, sweeping of the membranes, rupturing of the amniotic sac, prostaglandin and balloon tamponade, oxytocin and others such as propas. Now we have the vaginal pessary. These are all the methods of the induction. This selection of the induction and selection of the cases should be based on the Bishop score, depending on the dilatation, consistency, length, and the presentation part. If the Bishop score is less than 6, we go for the inductions, and if it is more, there is no. I will quote with the case scenarios which all of us regularly or frequently we see the cases. Now you see this is 25 years primary, admitted with 39 weeks plus 0 days for induction. From then she has no high risk, induced with cerviprim gel at 6 a.m. and at 12 noon, 2 cerviprim gel. At 6 p.m. after the second cerviprim gel, the induction, the dilatation is 2 to 3 centimeters. ARM was done, Liker was clear, syntocin drip started. But when after 4 hours, when the PV was done, at 9 p.m., the dilatation was 4 centimeter and caput was plus, but pelvis is adequate and FH is good. Emergency LSES done at 9.45 p.m. to 45 p.m. Indication being failed induction, baby weight is 2.5 kg. What happens with this if you are going to audit? Why it is a failed induction? Why this case is induced at 39 weeks, first of all. So whether it may be the request or the patient's indications or obstetrics indication, whatever it is, why it was induced. Then why ARM is done at 3 to 4 centimeter, 2 to 3 centimeter. Normally it has to be done after the 4 centimeter. Then why LSES is decided? That is emergency LSES, cervical dilatation 4 centimeters, caput plus, but Liker was clear and everything. Why it was done? So these are all the audit which, if these answers are given, we can be very sure that there will be no indications, not at least the indications of failed inductions will be reduced. So in this patients, what has happened? So the selection, as Shantirani madam was telling, the prerequisites for induction of labor is very, very important. Proper indications for induction. So 39 weeks indication means what is the induction you are doing means what is the indication? That has to be mentioned. And the return informed consent, why we are doing the inductions and what is the type of induction. The assessment of the pelvics and the assessment of the fetal maturity and fetal well-being is important. And the Bishop score, whether it is less than 4 or what is the Bishop score, 6, and the estimated fetal weight. These are all the prerequisites we need. No, we cannot tell that the patient wants to take up the exam and the obstetrician is going abroad. That may not be the indications for the inductions. Okay, that the proper indication should be there for induction. This is the guidelines, SOGC, which tells induction method and what is the indication has to be mentioned. And ACOG tells, depending on the Bishop score, the induction should be done, and the documentation of Bishop score is very, very important. Whenever you give an induction, mention the indications.
and mention the Bishop score and tell what about the pelvis assessment and everything. Then, as all of us know, the membrane sweeping. At completion of 39 weeks, all patients without high risk, if they are at cases, you have to do the pervaginal examination and do the sweeping of the membrane. The sweeping of the membrane itself will produce the will induce the labor. So it has to be done at when at 39 weeks, you can have the chance to assess the pelvis and do the sweeping of the membranes. And when it has to be repeated, it can be repeated after 1 week. In different, it depends on the case. If it is a high risk or if you have suspicions, in that cases, you can repeat even after the 2 days. The sweeping of the membrane is must for all patients without the risk. So this again, what happens? The recommended, the sweeping membrane itself will reduce the incidence of the inductions. So prior to induction, that is 2 days earlier, also at least you have to go for the sweeping of the membrane. Additional membrane sweeping may be offered if labor does not start spontaneously. So everything has a guidelines that has to be followed. This is one of the studies which tells that membrane sweeping, when it is done at 39 weeks, 40 weeks, 41 weeks for low risk cases, that is without any risk. In that cases, you can do even at 38 weeks and repeat at 39 and then at 40 weeks. Then comes our famous gel, which is all of us are very fond of this dinoprostat gel. It has to be kept at 2 to 8 degrees Celsius. If this temperature is not maintained and if it is not kept at the temperature, if you are going to induce with the gel means the effect will not be there and the cervix ripening will not be there. So it has to be maintained at the same temperature and it should not kept at the room temperature. As all of us know, 3 gram gel, 0.5 gram dinoprostat, it has to be repeated after 6 hours, maximum of 3 gel, but practically we are going with 2 doses. In 24 hours, 3 gel and ambulation for 30 minutes. It is not essential, but it is better if they have the ambulations. After the dinoprostat gel, we have to maintain the temperature, monitor pulse, respiratory rate, blood pressure, uterine contractions, what happens to the contractions, whether bleeding is present. Oxytocin has to be augmented only after 6 hours of the gel induction. So as per our case, it should not be done within 3 hours or 4 hours. So normally we do the PV examination only after the 4 hours. So oxytocin should be augmented only after the 6 hours of the last gel. Again, this study, rather than going for the national and international studies, I took the study of our Dr. Maya Menon, who she gave the talk in the morning itself, ESI. According to her research study, she has mentioned that the 2 doses of PGE2 gel, the patient is going for normal vaginal delivery rather than going for the 3rd gel. If the patient is going for the 3rd gel, there is the prolonged duration and increased incidence of LSCs. Induction of labor, why we are talking about the inductions? The induction, proper induction will reduce the cesarean rate. All of us know that nowadays that the cesarean rate is going on increasing and increasing. It has to be reduced. This pessary, now we have the pessary form also. This vaginal delivery system can be kept in the posterior fornix. This is the dinoprostat pessary, 10 milligram. It can be kept and it has to be removed after the 24 hours. And if needed, according to the studies, the pessary is around 65 to 73% of the success going for the vaginal delivery. And if needed, after removal of the pessary, you can go for the oxytocin augmentation. This pessary, I don't have experience, but there are studies which tells that the pessary is very, very useful. And this talk is also by sponsored by that pharmaceutical. Then the Foley's catheter, it comes. This is the mechanical method. In which case we have to go for gel and which case we have to go for Foley's. There is no rules and regulations. Depending if the cervix is little length, you can prefer with the Foley's. Gel or Foley's, whatever. This Foley's is kept transcervical. It is safe, cheap and easy to administer. You have to induce put the Foley's in the cervical canal, and after filling with about 30 to 40 or 60 to 70 ml, if give a slight traction, appropriate applications of the Foley's induction is very, very important. Slight tractions and the Foley's has to be tied to the inside of the leg. So the traction, after our Foley's, we have kept the Foley's, we can ask the patient will say something is pulling on near the vagina, something. So the proper applications of the Foley's method is very, very important. And the Foley's should be placed for at least 24 hours. We may a maximum of 24 hours. If the patient is going for induced and if it is working out, automatically the Foley's catheter will fall out. There is no necessity to remove that. So if you are going to remove after 12 hours, it is not a good method of induction. The Foley's, this is for ruptured membranes and the bleeding cases, there is no necessity to go for Foley's induction. So this is all guidelines. SOGC tells intracervical Foley's catheter or acceptable agents, and the double lumen catheter can also be, double catheter can also be kept. And the balloon catheter, WHO tells that it is useful and it can be combined with oxytocin. Foley's catheter is a reasonable and effective alternative. NICE guidelines tells that it should not be used routinely, that's all, but it can be used. As per all guidelines, a Foley's catheter can be used. And this meta-analysis, the Foley's catheter induction compared with vaginal misoprostol, it has mentioned that it has the lower incidence of uterine hyperstimulations, and the progress and the ripening of the cervix is also good as per this meta-analysis. The misoprostol, all of us are very scared to use this misoprostol, whether to use or not to use, because it is not FDA approved. But as per by the practical knowledge, the misoprostol is also very useful. But only thing is you have to monitor. Continuous monitoring is very, very important. See the guidelines, SOGC. Intact membranes, you can go with misoprostol. And the WHO also mentioned the misoprostol low dose of 25 microgram every 2 hourly with the ACOG or 50 microgram 4th hourly. So once before and continuous CTG monitoring and monitor the effect on the uterus and everything with the misoprostol. There are a lot of studies which tells that, which has a good induction. In some studies they have mentioned with the Foley's catheter, whenever they apply the Foley's catheter, they simultaneously start with the misoprostol 25 milligram every 4 hours. There are studies which that in that case, with the third dose, that is about 18 with the 12 hours itself, the cervix is getting dilated and it is getting ripening and the Foley's falls down and the progress is good. These are all the Cochrane studies, 75 randomized controlled trials, which tells that oral misoprostol appears to be least as effective and current method of inductions. They prefer for vaginal misoprostol. 9 trials showed that with 1 to 8 to women, oral misoprostol is equivalent to the infusion of the oxytocin induction. And 37th trial, which deals with the 6,417 women, it has compared and oral and vaginal, and they have mentioned equally both has the equal effect. But oral, there is no hyperstimulations. In the vaginal, meconium MCL baby is more. So like that, the 9 trials which compares oral misoprostol with the placebo and confirms that oral misoprostol is effective, and 5 trials has compared oral misoprostol with the gel. So there is no harm in using the misoprostol, but you have to be monitoring. Continuous CTG monitoring is very, very important. Or you can have one person can be kept for that patient and it has to be monitored. Then comes the amniotomy. When we are going to do the amniotomy is very, very important. In an unengaged head also, if it is 4 centimeter dilatation, you can go with the amniotomy. The fingers should be kept. It should not be removed because there is a possibility for the cord prolapse. And the monitoring the fetal heart before and after the ARM is very, very important. The oxytocin has to be commenced only after the amniotomy. That too after the 2 hours of doing the ARM. So ARM has to be done only after 4 centimeter dilatation. This is the ripening with a low dose syntocin. Nowadays we have a lot of methods. We are not going with, but if at all needed means it begins with 1 to 2 milliunits and it has to be increased incrementally 1 to 4 units at every 30 minutes. And infusion pump has to be used. And the same procedure, the oxytocin has to be maintained at 2 to 8 degrees centigrade and it should be kept in the refrigerator, and only half an hour before use, it has to be taken from the fridge. So the recommended regimen is same, which I have told. Amniotomy should be done after 4 centimeter and oxytocin has to be started after amniotomy of 2 hours. These are all, this is the old method with dilution. Now we are not following this method. So whatever the inductions you are doing, Cerviprim gel or misoprostol or Foley's or whatever it is, monitoring is very, very important every hour. But better continuous electronic and most frequent monitoring is important. And this vitals has to be monitored. So the failed induction is different from failed labor progress. The failed induction is, in that case, if you are failed with a misoprostol or Cerviprim gel, you can go for other method also. There is no harm. As long as the baby is good and the uterus is good, you can go for the other method also. Otherwise, you will end up in the cesarean delivery. So this is the methods of induction. And you can go with the epidural anesthesia also. It doesn't mean that epidural anesthesia has to be started only at the 4 centimeters. No need to wait for epidural anesthesia. It can be done even in the earlier stage, and it will not affect the progress of the labor. Methadone and opioid analgesia are given in the early labor because this pain relief, though it has not connections with the induction, but you can go with the reductions of the LSCS. So the pain relief is important. Most than all, the counseling is very, very, very important. You should counsel the patient. What is the method you are doing and how long it will be? What is the advantage and what is the disadvantage? When it will go for a normal or when it will go for an elective cesarean section, and electronic monitoring and expected duration, pain relief, option available, everything should be counseled to the patient. This is to say another case where we are going with the failed induction. 1 or 2 cases with a high risk time delay. This GDM admitted at 37 weeks with wide discharge PV. It is not even draining. And she had the previous term IUD. And now the CTG is normal, pelvis is adequate, baby weight is 2.8. Induced with a gel for the 2 gel with 6 hours apart. And since there was no progress, patient was taken for emergency illness. In this case also, what is the necessity to induce at 37 weeks? Previous IUD, yes, that. Once the GDM on meal plan, we have to follow the protocols. So if you follow the proper protocols, the failed induction incidence will get reduced. In the GDM, induction of labor, 40 weeks, if it is well controlled. Controlled on insulin oral weight at 38 weeks. So induction to be done at 38 to 39 weeks, not earlier if everything is under control. Similarly, for hypertension, depending whether it is a gestational or pre-eclampsia or anything, you can wait up and depending on the situations up to 37 weeks. This is another scenario. Gravida 2 P1L1 admitted with the USG of 6 centimeter and gestational age 35 weeks and 2 days and the previous normal delivery, baby weight 3 kg. Again, this has been induced with Foley's catheter, and the catheter is after the steroids effects. Foley's catheter was removed within 12 hours and the second gel kept after 6 hours. That time also the cervix dilatation was 2 centimeter. Since there was no progress with the descent and dilatations, emergency LSCS was done, and the indications being the failed inductions and oligohydramnios. Here, this case is not at all an oligohydramnios. The AF is 6 centimeter, and again the Foley's catheter has to be kept for 24 hours. And the dilatation also after 4 centimeters, you have to wait, and then only you have to start with the induction. So as per protocols, any gestational age, AFI less than 5 centimeter, only oligohydramnios. If it is less than 5 centimeters, assess with the Doppler every week, give hydration therapy. Though some studies tells that if that hydration is not effective, you can go with the hydrations. There are some studies which tells that hydration is effective. If it is normal, maintained at 5 centimeters, go up to 37 weeks, then go for induction. If there is any change in the Doppler, depending on the Bishop score, go for the induction. So oligohydramnios also, you can go with the inductions and you have to wait up to 37 weeks. There is another study which tells that the oligohydramnios detected by the ultrasound will not alone improve the mother fetus condition of the outcome. So this is another case which we face normally. Primary admitted with history of draining PV at 36 weeks. Draining plus USD, CTG, everything is normal. Antibiotics given, steroids are given. This is induced with the cerviprimgel. After 6 hours, no progress, decided for emergency. In the case of this, most of us follow only the cerviprimgel during the draining PV. Whether then that may be the reason for the failure of the inductions. There are the RCOG guidelines which mentions that misoprostol appears to be more effective than gel and the oxytocin in presence of ruptured membranes for induction of the labor. Oral misoprostol, which I told earlier, may be effective than vaginal misoprostol. Oral route is associated with less incidence of uterine hypercontractility. So in a case of draining, rather than going for the gel also is very useful, but misoprostol can also be considered to have a good induction, not going for the failed induction. In spite of everything, this misoprostol tablet is not FDA approved. That is the only reason we are afraid to use this. This is that PROM conditions, what the Foxy tells, that the patient has to be waited for the steroids effects, antibiotics, and if it is in the 32 weeks, magnesium sulfate has to be given, tocolysis depends. So we have seen all types of cases and all modes of induction. If you have an audit of any hospital for the LSCS audit, most of the time the increased incidence will be in the group 2 and group 4 where there will be the failed inductions. And if it is the repeat LSCS, fine. So the failed induction, what we have to do, proper selection of cases and proper method of induction. So stripping has to be done for all patients with no risk at 39 weeks. And induction has to be done only after 40 weeks with the monitoring, not earlier. And induction selection, what is the method, whether with gel or pessary or Foley's or misoprostol, that has to be dependent. And depending on the facilities you have and depending on the NICU center. And monitor and wait for the progress. Don't be in a hurry to do the LSCS. Wait for the progress. Unless you cut short the primary section, we cannot cut short the secondary section. So the failed induction has to be reanalyzed and such that the management should be depending. Analgesia can be used in the earlier stage itself, not only in the 4 centimeter dilation. And the counseling of the patient. You have to counsel the patient about the induction methods. Thank you. Once again, I thank the organizers for giving me the opportunity. Thank you.
Thank you. The case indication should be very definitive, and the cases should be individualized, whether it is a scarred uterus or what is the mode of termination we are planning for that patient and how long time we are going to give. And all should be done under institution with a continuous monitoring, where the facilities per cesarean section is very apt. So you have explained everything in a very good manner, madam. I have only one doubt I am having regarding this. A lot of talk regarding mifepristone for induction of labor. Yesterday also I have seen one question in this chat box. Mifepristone for induction of labor. We are using for induction of abortion and induction of IUD babies. Whether you are having any opinion regarding this mifepristone for induction of live baby?
No, sir. No, madam. I have not used mifepristone for induction. Next, our Bailey sir is there. We can ask. He is the pioneer for everything.
I also don't have idea. I don't have any experience at all. But yesterday, just like I was seen through the chat box questions, I had one question like that. So I thought we can clarify in this session.
No, I have no experience. No
Thank you so much, madam.
Thank
The
you,
lovely session. Thank you.
Madam, in AIDS, they have done a study as mifepristone as a first mode of induction of labor in live babies. I think it was done in 2018 or 2019.
Yeah.
But Maya, madam, there the case limit is only less than 100.
Yeah, the study should be validated with the number. And also, as madam told, Tamil Nadu government is not for misoprostol for induction of labor still now. So we are very scared to use misoprostol for induction of labor because it is against our government policy. So, but still we, for PP or OM and all, we don't have many options like Cervibrim gel and Foley's. So we are going for miso, but still government is not approving that. So thank you so much, madam. Thank you for the great
We will form the protocol, madam. Thank you.
Yeah, sure, madam. Sure, madam. You are the master of TNFOG. Definitely you should do something. Okay, madam. Thank you. Bye. Bye. Madam?
Good evening. Good evening to everyone. Good evening, sir. I invited Dr. Paili, sir, to give the keynote on cervical circlage. Sir, doesn't need any introduction. The past president, Kerala Federation of Obstetrics and Gynecology, and the state coordinator of confidential review of maternal deaths, Kerala, consultant Rajagiri Hospital, Ernakulam district, Kerala, special interests high risk pregnancy, endoscopy, pelvic floor, and urogynecology. Over to you, sir.
Thank you very much. Thank you, Palniyappan, and thank you, chairpersons, for this opportunity to share my views on cervical circlage. At the outset, I should say that I may be saying things which may not be acceptable to some of you because there are quite a lot of controversy about it, about cervical circlage. I would say that a very battered subject, battered in the sense there is so much controversy about it. Some even say that there should be any place for circlage in modern obstetrics. Whereas there are quite a lot of us, I hope some of you at least will be there, who feel that there is an indication. This survey article that came in 2008 said that by proper quality randomized trials, there is no indication to do cerclage in a singleton, and certainly in a multi, it will do harm. I cannot agree at all with this because we have felt and we have experienced that properly done, cervical cerclage is a very essential, useful procedure. I think the bad reputation has come because there's indiscriminate use of cerclage. There are centers where every IVF is cerclaged. There are centers where every multiple pregnancy is cerclaged. Anybody with a previous history of abortion, whatever be the type of abortion, getting cerclage. So when you select patients for cerclage indiscriminately, it's only natural that it may not give you the real good that is expected of it. And that is what I think has happened. I hope everybody will agree that at least there are some services which are not able to hold the weight of the products of conception beyond the first trimester. When the uterus has become 12 weeks and beyond, then the weight is more on the cervical sphincter and it may not be able to withhold it. And then it may slowly open up and abortion will occur. And that is a typical scenario. If cerclage is useful, even in some cases, the question is, how are you going to select what type and when to do it? In literature, if you look through that, especially the Western literature says that Shirodka cerclage is equal to McDonald's cerclage. I would say it's so sad to compare the two and say that they are equal. They are not. As far as I am concerned, I am convinced that probably there is no place for McDonald's cerclage. If you could continue pregnancy with McDonald's, then it would have continued even without it. Except on rare occasions of emergency cerclage, we don't do McDonald's cerclage now, even though I will show you a video of that. They cannot be equated because McDonald is put a little below the internal loss. And the whole principle of cerclage is, if you put the cerclage at the level of the internal loss, when the uterus is getting expanded, that internal loss will still hold the weight above that. But the moment the cerclage is below that level, and the internal loss is little yielding, then there will be pressure onto the upper part of the cervical canal, or what will become the lower segment. And that will stimulate further the contraction and will perpetuate the process and end up in a delivery, preterm delivery. So in a properly selected cases, if you put it at the right level, that is the internal loss level, there is a definite role. That is our conviction. ACOG and RCOG and the Canadian Society have all come out with guidelines. On most points, they all agree also. But personally, I have some disagreements with whatever they recommend. And even among them, there are some disagreements. No cerclage for after one typical loss. That is what the RCOG as well as the Canadians will say. But the ACOG says, if it's a typical case, even after one, you can do the cerclage. Personally, I feel that we can. The other recommendation is that no cerclage after 24 weeks of pregnancy. We do extend the indication for cerclage up to about 28 weeks because they say 24 weeks because beyond 24 weeks, they can salvage a baby outside better than continuing the pregnancy inside. But for us, even a 25-weeker to be brought up through our nurseries is so expensive and so difficult. So we continue to do cerclage even up to 28 weeks. No cerclage even with funneling if cervix is not very short. Below the funneling, if there is sufficient length, they say don't do a cerclage. Personally, I differ because if there's a funneling, that means there is always pressure at the upper part of the future lower segment, and there is a reason to do a cerclage. Serial measurement of the cervix will give you an idea. I am sure all of you would have had occasions where you would have seen that scan done 3.5 centimeter length and the next day painless dilatation of the cervix. So we feel that serial measurement of cervix is not the way to prevent insufficiency and a preterm abortion or a recurrent abortion. No cerclage for multiple pregnancy was a standard statement. And to the extent saying that it will do harm. But now, even in the literature, there are people who believe that if done at the right level, there is benefit for multiple pregnancy, and we are convinced about it. The other point that I say is that if there is an emergency cerclage or a membrane which is bulging, no point in doing a cerclage beyond 4 centimeters. I totally disagree. What we have observed is that even after full dilatation, we could push the membrane back, put a cerclage, and continue the pregnancy to a viable state. And I already told you, they all say that no difference between Shirodkar and McDonald. Totally disagree with that. There is a lot of difference between the two. And they say that there is no role for tocolytics. I disagree. If it's an emergency cerclage, after putting the cerclage, unless you give tocolysis for the uterus to quieten down, you may not get the desired benefit. So these are all many of the differences that I hold personally without much of literature support, but with experience. And so these are what you are going to hear. You may agree or disagree. The basic concept is reinforce at the level of the internal loss. That is our way. Now, painless cervical dilatation leading to recurrent second trimester pregnancy loss or birth of otherwise normal pregnancies, as per Bergela, which is probably the person who has written maximum about cerclage, as per the definition, this is as per him, this is the definition. And the ACOG defines it as inability of the uterine cervix to retain a pregnancy in the second trimester in the absence of clinical contractions or labor or both. So one thing we all agree, in the first trimester, if you have a loss, it may not be due to a cervical insufficiency. If it's an insufficiency, it should be beyond the 12th week. Cervical insufficiency cannot be diagnosed in the non-pregnant state. Remember, at least seniors among you, where we used to teach that if you can pass a size 8 agar, there may be insufficiency. If you cannot pass, there may not be insufficiency. If you can pull out a Foley which is distended with, say, 4 ml of fluid, then there is insufficiency. All these things have no role because in the non-pregnant state, it is not possible to diagnosis. So there is confusion likely to happen in all these cases. And if there is a mucus plug that is gone in a cervix which is open, then infection can go up and insufficiency may be the starting point and she may rupture the membrane and you will say, because she ruptured the membrane, she cannot be a cervical insufficiency. That again can be confusing. So going into the nitty-gritty of the history is very important to make a proper diagnosis. What are the methods available for us to do a cerclage? To diagnose? The most important point is the proper history. And then ultrasound, and then assessment of the cervix. History also will tell you if there's a reason to have an insufficient cervix, like an amputation of the cervix, like a trauma of the cervix before, that also has to be taken into account. But most importantly, the way the miscarriage happened previously. Was it a painless dilatation? Was it a slow, painless dilatation? Often coming out with the sac intact and the fetus live. That's a typical case of a cervical insufficiency. Now, you may remember that for a few years now, cerclage has been standardized into 3 groups: elective or history indicated, therapeutic or ultrasound indicated, and emergency or physical examination indicated. I think this is a good division into groups of cervical cerclage, and we follow that one. Shirodkar, as all of you are aware, and we are proud of, that Shirodkar was the first one to suggest that we can put a cerclage during early pregnancy and save the pregnancies. And he operated on 180 patients and had 80% success. He started with fascia lata as the material and later went on to serve the meslin tape. He used to dissect further high and then even posteriorly and put it, but later it was modified further. So there are a lot of modifications of even Shirodkar cerclage, just like Pomeroy's method of sterilization. Everybody has their own modification. So here also cerclage has got all sorts of modifications. We follow the Shirodkar cerclage as our standard. McDonald, the advantage is you don't dissect the bladder up. To some extent, it may help you to hold the pregnancy for a while, but it may not hold as well as the Shirodkar. Worm, just cross-stitching at the external loss, we don't do it as a whole. And the other thing is whether it's a place to put 2 cerclages, double cerclage. Again, there was a randomized trial, and finally the conclusion was that no real advantage. So what we believe is that put a cerclage at the level of the internal loss, put it with a tape rather than with a string-like structure because it can cut through. And you don't have to tighten it too tight if it is a prophylactic one. But if it is emergency cerclage, you have to tighten it well. So these are a few general points I want to say. Now, cervical cerclage, the abdominal cerclage After doing a laparotomy, we don't do it anymore. I will tell you why, because we have found that we can do it transvaginally. Now, I will just show you a clip of video of doing a Shirodka cerclage in this patient. So that will tell you the techniques that we suggest: cleaning, emptying the bladder, and then infiltrating the anterior surface of the cervix with a little dilute vasopressin. Dilute means 20 units diluted to 100 ml in saline, and you can incise the vaginal wall with scissors rather than with knife. You see that plain white surface of the cervix. So the bladder can be pushed up with the scissors itself. Hold that, adjust with an analyst, and you can see the thin-walled small speculum holding it up. And we are putting the cervical cerclage. As you can see in this, we are putting a bite anteriorly at the level where you want the stitch to tighten. Mercelline tape is being used. Pull the cervix towards one side. Hold that needle obliquely. Go to that side of the cervix, medial to the vascular bundle. You make sure it emerges posteriorly at the level of the internal os. The uterosacral ligament will be the landmark for that. Do it on both sides. Then you can put a stitch posteriorly, but this is not a must. This will help you to see where exactly it tightens. But again, you then tighten it. Only 2 throws to start with. Sorry, only 1 throw, because if you put 2, it may not tighten well. And then leave it cut about 1 inch or about 2 centimeters long. Don't put the knot under the bladder. If you have dissected and put the knot under the bladder, occasionally it can erode into the bladder. You don't have to stitch that back unless there is some bleeding and all that. So this is how we do the Shirodka. McDonald, on the other hand, you can see that you don't have to dissect the bladder. Keep it lifted up with a speculum, and at the junction of the bladder with the cervix, where you can put a bite and then take a bite laterally, medial to the vascular bundle. Here we are using Mercelline, not Mercelline tape, but umbilical cotton tape. Again, a tape rather than a string. Pull it down. You can take the same needle and this suture material, that is a umbilical cotton tape, anteriorly and put the knot anteriorly. So sideways, it is avoiding the vascular bundle, and you put the knot underneath. Because you haven't dissected the bladder, it may not do any harm. It is very unlikely to cause any erosion into the bladder. There are several occasions when high cerclage is required. And years ago, we used to do it abdominally. I'll just show you a clip. This is pretty old. As you can see, uterus is enlarged to about 12 weeks. And you have to handle the uterus very carefully. Make sure that it comes up at the level of the isthmus, medial to the vascular bundle. And you put the knot again. Here we are putting it posteriorly. You can put it anteriorly as well. You can dissect the bladder down and put the stitch anteriorly or posteriorly. You know that there are many people who do it laparoscopically now. We don't do it anymore. We do it actually only vaginally. I will show you how we can do cerclage at the same level vaginally. So it is very difficult to do if the uterus is more than 12 weeks. Can put the knot posteriorly or anteriorly, but prefer to do it. Here we are putting it posteriorly with a lot of difficulty. And this particular patient actually came up for cesarean later. We had to do a cesarean, and you can see that cerclage anteriorly and cerclage posteriorly. So the main disadvantage is that we have to do the cesarean being done. As you can see, the tiny baby, the fluid that comes out of it, as you can see, is very watery fluid, not with the vernix and all that. And the tiny baby is being taken. We are forced to do the cesarean here, not because of any problem with the cerclage, but the baby was, there is growth restriction. And so we had to terminate the pregnancy preterm. And that is why. And you can see what a tiny baby we had to take out. And anyway, the point is, this patient was happy because she has not had any children before, but we were not happy that we had to terminate early. But anyway, we are not doing such cerclages abdominally anymore. Until we saw this particular paper from France, where they were doing transvaginally cervico-isthmic cerclage using polypropylene mesh. And that is what we adopted. And you can see here, we are doing, just those of you who are doing vaginal surgery for non-descent uterus can easily do this. The whole same set that we have to develop. The important point here is anteriorly you dissect the bladder as we did for the Shirodka cerclage, and then posteriorly, this is the important part of the procedure. If you hold the posterior, you can see that that's a lip of the posterior lip of the cervix held with an Alice without teeth, or a Babcock like that. And that's a bridge of tissue which will have the peritoneum or the pouch of Douglas. Cut sharp into that bridge of tissue. You can see that fluid that came out, and then extend the incision laterally. Put your blade deeper inside. So what we are doing is, again, Michelin tape is being used. We are make sure that, just like in Shirodkar, we are putting the needle from front to back here at the moment on the right side. But before you release the needle from the needle holder, steady the tip with a clamp and then only release. Otherwise, the needle may recede in. So you pull it not towards you, but to the opposite side like that, so that it will not cut through and come to a lower level. So this stitch is emerging on the posterior surface of the cervix at the level of the uterosacral ligament. You do the same thing on the opposite side, front to back. Lift up the bladder. Hold the needle obliquely like this. Go to the point of insertion on the side of the cervix. And then holding the needle tip down, you emerge posteriorly the needle tip, the uterosacral ligament or just above that level, and then take the needle through and then tie the knot posteriorly in the pouch of Douglas at the level of the isthmus of the cervix. And then you come out. You close the opening that you made into the pouch of Douglas. We have counseled this patient that when she goes to term, we have to do a cesarean rather than remove the stitch and then allow her vaginal delivery. We can remove that stitch. Suppose, unfortunately, if she, say, rupture membranes or any reason to terminate the pregnancy before 26, 28 weeks, we can open into the pouch and remove that still. But when it has gone to full term, it may not be that easy to remove that cerclage. So we have to counsel these people that they may have to have a cesarean once you do an intraperitoneal cerclage like that. And these patients, and we have quite a few of them, I'll tell you, we have about 65% take-home babies for doing cerclage like this, intraperitoneally. Almost similar result as we have for emergency cerclage, which also I'll show you in a minute. So we have 17 cases and take-home babies in 15 of them. Sorry, not 65%, even 85% babies take home after doing intraperitoneal cerclage. One of the most satisfying procedures, because these patients would have lost many. As this particular 17 series, they had 48 unsuccessful pregnancies before, and 15 of the 17 could take home babies after we did the intraperitoneal cerclage. There are situations where the emergency cerclage will be required, and this is a video of that, how we do it. We push up the membrane, which has bulged out, using a Foley bulb, and the Foley catheter is stiffened by passing a catheter guide through that. So this is what we are seeing. At the point opposite to the water channel, you pass a sound through up to the tip so that this part becomes stiff and you have better control. Without this, if you try to push with the Foley will not go push it in the direction that you want. Make sure you don't cut off the tip. Some people say you cut off the tip. So the distended bulb here is the one that we are using to push up the bulb. Here we are using Michelin tape or umbilical cotton tape. That's the membrane which is bulging with all the mucus on the surface of it. You clean that and you can see that through that you see clear liquor. people used to say that if the liquor that you see through is not very clear, in other words, if there are sediments, you should not use the cerclage. But we have done and carried baby home even after that. So that is a service which is appearing now once the membrane has gone back. Patient is in head-low tilt with tocolytics, and we use even nitroglycerin drip for getting the tocolysis. And the cerclage at this stage, we are doing it like a McDonald's, but of late, we are doing this Shirodkar or intraperitoneal method even for emergency cerclage like this. Once we have done the reduction of the membrane back into the uterine cavity, pull down the anterior and the posterior lips of the cervix, and we do, as you saw, intraperitoneal cerclage also in some of these cases. And that gives the best result. Technically, it is a little more difficult, but as you can see here, once you have done the cerclage, the cervix is closed. You continue to give tocolysis for a few days, and after that, you may be even able to discontinue that. And so you can have the pregnancy continued, even those where the membrane has already been bulging. So these are the different types of cerclages. And as I told you, we use tocolytics, we use duodenine isosuprene hydrochloride, we use indomethacin, we use even nitroglycerin as a drip. And the nitroglycerin, 25 milligram, that is 5 ml, made to 50 ml, given at the rate of 5 to 10 ml per hour. But you should always keep in mind the phenylephrine as a bolus to be given, because some of them may have crash, fall in the BP. And so in that case, you should be able to rescue them with that. And 4 ml per hour is the dose that we use, head down tilt, so the membrane will easily go back. Don't try to push back a membrane when the uterus is contracting or the woman is pushing. So we need anesthesia. We used to insist on general anesthesia with halothane, but now halothane is not available. And that is why we changed over to nitroglycerin, and we can use under spinal anesthesia, this sort of a procedure. So these are a few thoughts we have. And post-operatively for 3-4 days, they will be on catheter. And after about a week, they are up and about. We have even people who started to go back to work and continue the pregnancy up to 37, 39 weeks and got pregnancies. We had 21 emergencies and take-home babies in 9 of them, 5 sets of twins, 3 of them took home 4 babies. So these are our experiences with emergency cerclage. 9 out of 15 patients. So put the cerclage at the right level. That's the most important point. And put it with tape rather than with a string like Proline, as some people recommend. If you are funneling like this, with even that much of service still intact, I would recommend a cerclage to be put here rather than put it at this level. Put it at the internal loss level. That will give you the best results. So to conclude, friends, we have to be careful in taking the history in history-indicated cerclage. It should be a properly taken history. Otherwise, you will take the wrong patient for cerclage. If the ultrasound proven cervical dilatation, we can certainly and we should put the cerclage. Again, try to put it at the high level. And whenever you want to do an emergency cerclage, make sure that you can push that membrane back with adequate tocolysis and put the cerclage at the right level, high up. So these are a few thoughts which I thought I would share with you. Thank you very much for this opportunity to discuss our experience with cervical cerclage.
Thank you so much, sir. It's very nice to see your novel ideas and novel techniques that we are not at all aware of, that intraperitoneal encerclage and all. Thank you so much for, at least we are lucky to see the videos at all. Thank you. Thank you for your ideas.
Thank you very much, Shanti.
And isosupreme and all, still you are using it, sir. With, as you said, it's always a lot of controversy.
There is a lot of controversies I have with the modern practice. People abandoning at the direction of medical companies and all that drugs which are really useful. Isosuprene is really useful. Only thing is it is cheap. That is its problem. So nobody is interested to promote it. We find it really useful, isosuprene as an IV process. Okay.
You are all producing your evidence-based techniques, sir. So that's that should be accepted. You are all giving evidence and you are proving everything. So thank you so much, sir. Thank you.
Thank you very much. Yeah.
We thank our chairpersons and the speakers for their excellent keynote address and the talks. Thank you, madams and sirs. And now I welcome our
we would like to
President and
take over.
Secretary, ma'am, to
Yes, ma'am.
take
Yes,
over
yes,
for the
yes.
inauguration.
Yeah.
Over to
Thank you
ma'am.
very much, Dr. Meena. Thank you so much, chairpersons and coordinator Meena. We now move on to the inauguration ceremony. Dr.
Thank you for the opportunity, madam.
Take over. Yeah, thank you so much. Sumati Premanand, tech team, Kishore, can we have the slides, please? And Dr. Palani sir, please take over.
Dr. Palani sir.
Okay, Dr.
Good
Palani sir.
evening, ladies and gentlemen. Most welcome to the most awaited inaugural ceremony of the 37th OGSSICON. And I have the proud privilege of introducing Dr. Sumati Premanand. Slide, Kishore. Dr. Sumati Premanand, who is an MD, Command Hospital Air Force, and a very active executive committee member of OGSSI, will be the coordinator for the entire inaugural program. And we have lined up a series of programs, and I'm very happy to have two people here as chief guests. One is Dr. Shanta Kumari, our FOXI president, and other is our very honorable health minister, who's just trying to log in while we start going on. And Sumati, over to you. And have to have both of them. They are just trying to log in, and we should be a couple of minutes of delay or seconds of delay here and there. Please bear with us when we have such important people as chairperson, and we should be able to go on with the meeting. Oh yeah, Dr. Shanta Kumari is here, and the minister is just logging, and I'm able to see his.
Ma'am, good evening.
Welcome, Dr. Shanta. It's indeed a proud privilege.
Thank you, Palani.
Sumati, you can take over.
Welcome you all. We welcome you all for the inauguration ceremony, the much awaited inauguration ceremony. Thank you very much for your kind words, sir. You've always been our solid support. The much awaited OGSSICON 2020, the online international conference of our prestigious society. This is the 37th annual conference of the Obstetrics Gynecological Society of Southern India. And we take pride in inaugurating this conference with the invited international and national faculty and the enthusiastic delegates in the presence of our Honorable Health Minister of Tamil Nadu State and our beloved President of FOXI 2021. Mother is the beginning of everything. Tamil, the oldest language on earth, is considered our mother. It is our bread, earth, and soul. We hence start our inauguration with the Tamil Thai Vaalthu hence.
Maybe 1 second. Take Kishore. Kishore, 1 second. Hold on, Kishore.
Yes.
Palani sir, should we wait for the minister to join?
I think you should if he's trying to join in, please.
Yes, madam. Yes, ma'am.
Because that's not proper.
Start off the Tamil Thai Vaalthu. Yeah, please. A few seconds, bear with us.
Because we have to give them the respect.
Yes, ma'am. Thank you very much, ma'am.
Thank you, ma'am.
We are
joining us in time, right in time. You're so
yes, we are aware that you have to log in for another program, so that is there, the back of our mind.
You know.
Yeah.
That was at 4 o'clock. I rescheduled it 5 so that this will be over, and we had a physical event in Hyderabad.
Okay, ma'am.
Dr. PC Mahapatra sir was here.
Okay.
We just finished that and I reached.
Okay. Kishore, just be ready. As soon as sir logs in, we will start.
Here it is. We are able to see his office getting ready, and the secretaries are getting ready to connect, and he's in a different room. He just has to come. Shanta, I'm extremely sorry for making you wait.
No problem. We'll wait.
Yeah, he's just joining in, and I said that Tamil Thai Vaalthu is ready, and so he's just joining in. He was supposed to go home and start, but then he found that it is very long, so he's joined into the DME office, and so he's logging in from the DME office halfway through, because to facilitate and it should match your timing. So we said we have to do the program because you're also busy. So I said, then he said we will log in from the DME office. So he's logging somewhere in between, he's logging in. So very kind of him to do that. And so they're connecting to the audio.
Very kind of you all to have started in time. Nice to see bright faces.
Not very nice to see virtually. It's better to see physically.
Yes, madam, in person. It would have been so nice to have had you here in Chennai.
I know. I missed my shopping also.
I know, madam. Not that you, you would have missed Prashavakam. That's what I feel.
Good evening, Dr. Shanta. How
Good
are
evening,
you?
I am
Nice
fine.
to
How are
see
you?
Yeah, fine. Nice to keep seeing you in different webinars all the time. You care so much that you are there for everything.
Yes. Sumati, we can start. He said he will join, so we can start the Tamiltai Vartha and other things, and we can go on while he's there. So we will start and go with the proceedings. Over to you, Sumati.
Yes, sir. Mr. Kishore, could we have the Tamiltai Vartha played? Thank you. Doesn't this bring goosebumps? It has always brought goosebumps to anyone who has come across this language. We shall now proceed to render the Oxy prayer. Thank you, God. In humility we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thus says the Oxy prayer. We now start off the Kuttuvilakku writing. குத்துவிளக்கேற்றி இன்றைய நாளை துவக்கி வைக்க உங்கள் அனைவரையும் அன்போடு அழைக்கிறோம். Let us dispel the darkness and invoke the divinity, knowledge and brightness from now. Can we have the video, please? Thank you very much. Can we have the next slide? Kishore? Thank you. And now, as we begin, we start off with one of the most beautiful, vibrant, and ever enthusiastic personality, charm and diligence are armor. Dr. Vijayalakshmi Sheshadri is the president of Oxy 2021. She was our vice president in year 2020. She is a senior consultant obstetrician and gynecologist of Sundaram Medical Foundation, Chennai. She is an executive committee member of TNFOG. She is a constitution committee member of Aisubhab, a member of Practical Obstetric Committee, FOXY, Quiz Committee member, IMS, Chairperson, Research Committee, IMS 2018-2020. She has received the Best Paper Award in AICOG 2014. Her special area of interest are high-risk obstetrics and midlife health. Next slide, please. We welcome Dr. Vijayalakshmi Sheshadri to deliver here to the august audience her welcome address.
Thank you. Thank you, Sumati, for that great introduction that you have given. Good evening to all, to the entire August audience and the dignitaries on this virtual dais and off the dais. I have a long list of people whom I need to welcome because Dr. Painiyappan has made it a very great conference, inviting people from all around. The most respected chief guest for the day, the Honorable Minister of Health and Family Welfare, Government of Tamil Nadu, Thiru M. Subramaniam. I welcome him from the bottom of my heart for this inauguration. Our guest of honor, ever smiling, ever energetic, President FOXY for this year, Dr. S. Shantakumari, who makes it a point to bless us from wherever she is for the success of the program. I welcome you, Madam, for this inauguration. Our fond President, Dr. N. Painiyappan, for the year 2020 at OGSSI, and has made it a real reality to conduct this program for this year. And I'm happy on one hand that the corona did not allow him to do it last year, so that it could spill over to my tenure, also contributing to a very good webinar for this year in my presidency. Thank you, Painiyappan, for your efforts and your thoughts. My welcome to the very efficient Honorary Secretary, Dr. Vijayalakshmi Gnanasekaran of the OGSSI year 2020, who has been working on it tirelessly. My welcome goes to the Treasurer of the Team OGSSI for 2020, who is with us as well. The orators for the three important oration of the OGSSI oration, Dr. Rekha Kurian, for the Indira Ramamurthy oration, Dr. Paul Fogarty from UK, for the MKK Krishna Menon oration, Professor Kypros Nicolaites from UK. I welcome you all. You are all great orators, and we are looking forward to hearing to you. Of course, Professor Kypros, we heard him just a little time back. I invite all the international faculty, Dr. John Smolnik from Australia, Dr. Abraham Pedikail from Muscat, Dr. Kalaivani Ramalingam from UK, Dr. Deepika Deshpande from UK, Dr. Aryant S. Karumanchi from USA, Dr. T.P. Bhaskaran from Malaysia, and of course, our very senior members of OGSSI who have obliged us by their presence for this conference. My welcome goes to all the eminent national faculty who have been doing a great work all through since yesterday and will be doing today and tomorrow as well. We had excellent workshops conducted yesterday, and I welcome all the workshop coordinators who have contributed immensely to this conference. Of course, our own executive committee members, both of the year 2020 and 2021, have joined hands and have made this conference a great success, and my welcome and thanks go to all of them. The delegates form the most important part of any conference, and welcome you all delegates for this wonderful conference, without whom this conference has no meaning. the coordinators, all the faculty, all the chairpersons, all the entire audience team, I welcome you all from the bottom of my heart. The pharmaceutical sponsors who are always instrumental in making these events happen, I welcome them all. So I welcome each and everyone, and whatever you have witnessed yesterday and today and will be watching even tomorrow, I welcome you all from the bottom of my heart. Thank you very much for this opportunity, and I look forward to a great conference in my tenure of 2021 also. Thank you so much.
Thank you very much for your kind wishes and your beautiful welcome address, madam, as beautiful as you are. We now move on to the next person, Dr. Vijayalakshmi Gnanasekaran. She is a dear friend. She is meticulous, energetic, and a secretary who is difficult to match. She has her own genre. She is the Honorary Secretary of OGSSI 2020. She is now the Associate Professor of Department of Obstetrics and Gynecology in the ACS Medical College. She is the Executive Committee member now in OGSSI 2021. She is the Honorary Treasurer of TNFOG 2021. Fields of interest are high-risk obstetrics, adolescent gynecology, and infertility. Can we have the next slide? I now invite Dr. Vijayalakshmi Gnanasekaran to deliver her secretary report.
Thank you, Dr. Sumati, for the kind words. It's not that it is unmatchable or anything like that. Okay. One second.
Difficult standards, high standards.
அடுக்கி வரினும் அழிவு இல்லான் உற்ற இடுக்கண் இடுக்கண் படும். இக்குறளை கேட்பதற்கு நம்ம மாண்புமிகு அமைச்சர் அங்க இல்ல. அதனுடைய பொருள் என்னன்னா, இடைவிடாது மேலும் மேலும் வந்தாலும் தன் முயற்சியை விடாதவனை அடைந்த துன்பம் துன்பப்படும். துன்பமே துன்பப்படுமா? ஏன்னா இவர் அவ்வளவு முயற்சி பண்றவர். அப்படிப்பட்ட ஒரு பெரிய கார் விபத்திற்கு பிறகும் கூட நடக்கவே சிரமப்பட்ட போதும் மாரத்தான் ஓடி சாதனை படைத்த சாதனையாளர், ஓய்வறியாமல் உழைத்து கொண்டு இருக்கும் நம் மாண்புமிகு மருத்துவம் மற்றும் மக்கள் நல்வாழ்வுத்துறை அமைச்சர் திரு மா சுப்பிரமணியம் அவர்களுக்கு என் பணிவான வணக்கங்கள். தமிழகத்தின் மருமகள், எங்கள் மகப்பேறு மற்றும் பெண்கள் நல மருத்துவ கூட்டமைப்பின் இந்திய கூட்டமைப்பின் தலைவி, தமிழகத்தின் மருமகள் திருமதி சாந்தகுமாரி அவர்களுக்கு என் வணக்கம். அறிவும் ஆற்றலும் நிறைய பெற்று எங்கள் அனைவரையும் எப்போதும் வழிநடத்தி செல்லும் எங்கள் தனிப்பெரும் தலைவர் திரு பழனியப்பன் அவர்களுக்கும் என் வணக்கங்கள். 2021 வருடத்தின் தலைவி திருமதி விஜயலட்சுமி சேஷாத்ரி அவர்களுக்கும் என் வணக்கங்கள். பொருளாளர் திரு குந்தவை அவர்களுக்கும் மற்றும் இங்கு கூடியிருக்கும் அனைத்து மருத்துவர்கள் மற்றும் அனைவருக்கும் என் பணிவான வணக்கங்கள். It is indeed a proud privilege to read the secretary's report, which is the privilege of a secretary to mention whatever are the things that has been going on for the entire year. It started all in December 2019 when we had a gala swearing in ceremony, and this was the team who took over the lead under the leadership of our president, Dr. Palaniappan. And all of you are aware of all the academic activities that we are routinely used to, our clinical society meetings, which are conducted on the last Tuesday of every month, where we have case presentations by postgraduates and practitioners. And to encourage them, OGSSI presents silver medal, and this year we have introduced 2 silver medals, one for the postgraduates, and we don't want the practitioners to along with the postgraduates. So 2 silver medals, one for the postgraduates and one for the practitioners. And we have updates and panel discussions, and we conducted totally 9 last year. And these are some of the images of the various clinical society meetings that we have conducted. We have CVME programs every month on various topics, minimum 1 or at least 2 or 3 programs also get held. So that is to update us on our recent advances, and also in accordance with international days like promotion of breastfeeding, cancer awareness, like cervical breast ovarian cancer awareness programs and CMEs regarding that, World Environmental Day, PCOS awareness, World Contraception Day, etc. Like that, we have conducted totally about 18 programs. We started in the month of February with actually a CMA program held at our Oxy auditorium. We do not know when we are going to have such a kind of a conference, CME or a conference again there. And after that, it has all become webinar. And these are some of the programs that we have had on all the various topics that I have told you. We have had conducted CME programs jointly with other committees like FOXY committees. We have had CMEs on contraception, a FOXY focus on contraception, Tamil Nadu Society's webinar by the FOXY Vice President, Dr. Ramani Devi, Happy Learning Masterclass series on cesarean section. And we have conducted programs with the World Association of Sexology and the Sexual Medicine Committee together, along with IMA and along with ACOM Foundation for the paramedicals. And these are the clippings of some of these programs that we have conducted. And of course, all of them have been virtual. Teaching is always our passion in Oxy. We conduct 2 postgraduate revision courses every year. Our undergraduate revision course, Diksha, is conducted once every year, and we named it Diksha this year. This is really a benefit to the students as they are exposed to all the faculty throughout our entire state and our neighboring states. One thing which was good about webinar was it brings a lot of international faculty, national and other state faculties who close to us. So our postgraduates and UGs also benefited in all these programs. And when we had it physically, we had about 200 and odd registrations and 531 when it was virtual, and 400 undergraduates also during the undergraduate revision courses. And these were some of the clippings. And we had training, COVID-19 training conducted by FOXY for our healthcare workers, in which our society members had participated. And the society has got the appreciation award from FOXY for that. Outreach programs are always part of FOXY. Our first outreach program was a camp conducted at Siruvalayam village in the month of February 2020. And both our president had a lot of ideas about further outreach programs also. But unfortunately, women, this place is near Ranipet district, and we gave health education talk, screened the women for breast cancer, pap smear and cervical cancer screening, and they were also evaluated by a medical team, and they had ECG and other investigations were taken. And this was in collaboration along with Ramachandra Medical College, organized by a free camp for women police, a free pap smear and breast examination by expert gynecologists. We had a walkathon. We walked the pap smear and cancer screening program also, which was a great success. Then, as per the guidance of FOXY, we did the World Environment Day in June, and on a single day, we planted 150 trees. And this tree plantation is also a pet project of our health minister. And we planted 150 trees. And the environmental education extended to the various colleges and the schools and for the general public, through to which we did webinars. And then when this our course really needed the need of at that time, and a total of 1,525 kits were donated by our various obstetricians, both in the form of people who donated kits as such and people who gave money, and we collected and bought KMC and RSRM. A total of 1,525 kits were given. And we conducted awareness programs on contraception, and anemia awareness program was conducted. These were all done by our Oxy members. 400 ICT workers were benefited. And in this, FOXY had given us an anemia-free campaign, outstanding contribution award for this for Oxy. Then organ donation was also a project of Oxy, which we did along with them. And Oxy motivated 44 persons to take the pledge, and their forms have been filled up, and their names have been given to Foxy. And our concept of organ donation was taken to the children. So the grooming the youngsters is definitely very, very important. And this was promoted in the form of competitions for them, writing, drawing competitions and all. And conferences are always our favorite thing, favorite agenda. But all our conferences could be only held as a webinar. Our Love to Labor conclave is really that is the hard. We could have a very successful conference about which he will talk in detail. The other two conferences that we held were the Yuva OGSSICON Talir 2020, which was an introduction, and the first TNFOG conference, which was also new. And this was our Yuva OGSSICON, conducted purely by the Yuva people, and of course, ably guided by us, but the main conference was held by them. And the Yuva OGSSI oration was instituted in that conference. And these are the clippings of our Love to Labor conference, in which we had it was an international conference with international speakers, all our national faculty, president, secretary, Dr. P.C. Mahapatra, and all other eminent faculties of OGSSI, and the entire state was there. And it was an excellent conference there. And we had paper presentations and prize distributions for free papers and posters in the conference. And then came the TNFOG, the Tamil Nadu Federation was instituted, and we had its first conference. The swearing-in ceremony of the team took place during that conference, and that was also a very grand success, the OGSSI and TNFOG conference. And with that, we handed over the team to Team 2021. We are all part of Team 2021, but we had the only one physical interaction between us was the handing over ceremony of Dr. Palaniyappan to our incoming president of 2021, Dr. Vijayalakshmi Seshadri, and it was handed over. And Madam is presently the president, who kindly consented to us having our international conference, which we could not have in person or we had planned. But because it is conducted as a webinar, we have the privilege of having it as OGSSICON 2020 International Online Conference. The conference actually is happening from yesterday, today, and extends on to tomorrow, with so many international faculty who have really decorated the entire dais and making us listen to such lectures. And we started on the 24th with free papers and poster presentations, ably guided by Dr. Dhanalakshmi Madam, along with her team, Dr. Geeta Lakshmi, Priya Kannappan, Rajeshri, and Sumati Premanand. And these are the prize winners. And the first prize is a gold medal for the best free paper, instituted by Dr. Radhabai Prabhu under the name of her mother, Mrs. T. Rajarathinam Gold Medal Award. And the best first prize for the poster is instituted by our past president. Both of them are our past presidents. And Dr. Shanti Gunasingh, Madam, instituted the prize in the name of her mother, Mrs. Mangalam Kasirajan, best poster for gold medal. The prizes will be announced tomorrow in the valedictory, and the prize winners will receive their certificates and the medals. And the second and third prizes would be silver medals for both the best paper and poster. And we have introduced, Palaniyappan sir has introduced the CRRI paper for the first time. And we have first, second, and third prize. And all the entire effort of choosing the entire thing lay with the team, which I showed you. This was followed by the workshop, which we had yesterday. 3 workshops: recent advances in rhesus disease, minimal access, injuries secured, CTG, can tell goodness. It was fantastic workshops. We had international faculty in 2 of our workshops, national faculty, rhesus workshop, inaugurated by Dr. John, our CTG workshop, inaugurated by our past FOGSI president, Dr. Alpesh Gandhi, and the endoscopy workshop, inaugurated by our own excellent. And today we listened to all the messages and take-home messages from all the speakers of today. Excellent messages which they conveyed. And there were 3 keynote addresses by Dr. Anand Karumanchi, Dr. Kurian Joseph, and Dr. V.P. Paili. And definitely the fantastic thing about today was the M.K. Krishna Menon oration, which was rendered by Professor Kipros Nicolaides. It was fantastic. We could never have heard such an oration previously. It was a fantastic thing that sir did, and all those who are here would have definitely would have been part of it, enjoying it throughout. And tomorrow we have a full day session from morning to evening, which will be the end of the conference. And this is the team. Everything is teamwork. Nobody can individually function to perfection. And it was the team. Thanks to the entire team. Thanks to all the OGSSI members for all the cooperation that they have always extended. Thank you all so much.
Thank you, Dr. Vijayalakshmi Gnanasekharan, for that meticulously designed secretary report. We now move on to the next agenda. Could we have the next slide, please? We now are here. I'm here to introduce Dr. N. Palaniappan. He is our vibrant and enthusiastic leader with patience and teamwork as his armor. His presentations are always a work of art. It is in his tenure that COVID locked us down. That did we give up? No. He initiated and implemented with our team the bonanzas of virtual seminars, CMEs, and the conferences as is now going on for the non-stop knowledge sharing. He is a professor and unit head, Department of OBJ, Ramachandra Medical College, Chennai. He has won the Indumati Javeri Award in 1994 and the Young Scientist Award. He is an awardee of Dr. A.L. Mudaliar Traveling Fellowship, Senior Overseas Fellow of Liverpool Hospital, Sydney. He is Dr. Kamini Rao Yuva Foxy Orator, Young Gynecologist Awardee of Asia Oceania Federation of Obstetrics and Gynecologists in 2007. He is an invited speaker at various national and international conferences. He has authored multiple chapters in textbooks. Interests are in high-risk obstetrics. He is a joint secretary of All India Congress of OBG in 2015 that was conducted in Chennai. He was our president in year 2020, and he's a chairperson of Safe Motherhood Committee in Foxy 2017 to 2019. May I now invite Dr. N. Palaniappan to deliver his presidential address.
Good evening, ladies and gentlemen. Respected and Honorable Chief Minister, Health Minister of Tamil Nadu, Thiru Ma Subramaniam, President Foxy, Dr. Shantakumari, like my own sister and mentor in Foxy, members of Foxy and a couple of Foxy people who have logged in, my dear friends, the press, especially Raj TV and Times of India who's logged in, and of course, past presidents of Foxy, my very hearty welcome to one and all, and I'm extremely thankful for all of you to have logged into this wonderful inauguration, which was my dream come true. Let me share my slide and start. Are you able to see my screen?
No, sir. We can see your folder. So kindly stop share and select your screen instead of folder. Or else you can kind of select PPT.
Are you able to see?
Yeah, now, yeah, we can see.
Teamwork works, no doubt about it. And ladies and gentlemen, this was a team which took over in the year 20. There is a difference between interest and commitment. When you are interested in doing something, you do it only when circumstances permit. When you are committed to something, you accept no excuses, only results. And that was by Arch Rock. Keeping this in mind, Team 2020 started working very hardly when we took over in the year 2019, December 15th. We had enough webinars, we had enough CMEs, which I'm sure Dr. Vijayalakshmi Gnanashekaran did tell you about. The grand events of Team 2020, we had the distribution of PPE kits to various government hospitals, which was done during the COVID time because the era took over with the COVID. The Yuva OGSSICON Talir 2020 was only the Yuva people presenting the titles here, and the theme of the conference was Youth and Truth, and Dr. Vijay Karthikeyan, District Collector Tirupur, was the chief guest at that point of time, and we had 40 Yuva members present, and we had the Yuva OGSSICON oration instilled by Dr. Arkat Jayashree Gajaraj, which will happen every year, and the winner of the last year's Yuva OGSSI oration was Dr. Sneha Sethumathavan. We had the South Chennai CME and the North Chennai CME for the very simple reason that the members were not able to come to OGSSI at that point of time. So we decided to have South Chennai, North Chennai, and the Central Chennai CME. And we had a South Chennai CME, which was attended by 815 members or so. And we had the first ever e-elections conducted in the year November 2020. Obviously, because of COVID, it was a new innovation. And these were the results. And the OGSSI members who voted were only 369 in spite of that. But then otherwise, the numbers used to be very less. So the voting was made e-voting. We had the North Chennai CME in the month of December, and then we had the wonderful culminating conference called the Love to Labor International Conference on January 22nd to 24th, of which we had a fantastic academic event, and then it went on. And there we instilled the Dr. A.K. Joseph oration, or the mid-year oration, which first oration was delivered by Dr. Justice Hofmeyr from South Africa, and that was on, is labor worth it? Definitely yes, and the conference was worth it as well. And the conference highlights where we had 2,627 registrations all over the world, and it was an academic bonanza. The success of the conference was because of all these people. Most of them you will know again here. Dr. Shanta is there, Jaydeep, Dr. Paili, Dr. Kurian, and all of them, including Dr. Arul Kumaran from UK. In my committee, the formation of TNFOG happened under the leadership of Dr. Anjala Chandrasekhar and Dr. Sampath Kumari, and the first conference was hosted by OGSSI at that point of time, and that was almost the ending of the event. And then 5 MOUs were signed, as what we had mentioned before, and these were the MOUs kept in place in the office, and the money saved as fixed deposits was a huge money, and they put it as fixed deposits and given a huge sum of money to OGSSI to be spent in the future. 2 accounts were closed. The All India Conference account and Tular accounts were closed and converted into FDs. And the Kekanagar property, which we are very happy to have owned after the AICOG money, is being maintained very well. And this is the property which people who have not seen, please see that it's still locked during the COVID time. The newly acquired Patta was done for the Kekanagar property. And because we had a lot of events to be kept inside the locker, we opened a locker in the Axis Bank, and that is where we had stored our safety things into, because the OGSSI office was closed during the COVID time. And so for that particular event, we had to open the locker and it was kept inside. At the end of that particular event, we had few promises, and that was yet to be done. And annual conference of the year, should we do it offline, online, or we should do it as a hybrid, was a question, and we did.
Let me sing a goodie story, pay attention, listen to me. If you want, take it out of. That
was my Kutti story. We started there, and 30th May 2021, the concept of consumption and the Kutti story started. The mid-year conference of OGSSI 2021 was held by Dr. Vijayalakshmi Seshadri, and the general body meeting granted me permission to conduct the annual conference of 2020 online in the year 2021. And so that is exactly the event of today. And the Kutti story started at that point of time.
Speed up on Gamana must stay. Slow up steady you must stay.
So we went quite slow, and the pregnancy started. And who were the support of pregnancy? Oral, vaginal, or intramuscular progesterones were the support of pregnancy. And the support of pregnancy was initially given by the INCAS, the Spectra divisions of the Sun Pharma, and it went on very, very well. And who were the calcium and who were the iron? My calcium was the White Health Minister, Tiruma Subramaniam, who's here to give us the grace. And who was the iron? The iron was the Iron Lady of FOGSI, Dr. Shanta Kumari, President FOGSI. Of course, embodiment of iron, she's wearing a red sari. Dr. Shanta is always the Iron Lady of FOGSI. The anomaly scan was done at around 20 weeks of pregnancy, and the anomaly scan was a detailed survey of the pregnancy, and that was the program. And the entire program was put in place by me, and I chose the lecture topics and the speakers were all handpicked by me. But then the entire anatomical survey was put in place and made it right by somebody. And the sonologist for that particular baby was none.
Hard work smart work self-motivation.
So hard work, motivation was Dr. Dhanalakshmi to do that. Of course, during the era of COVID, we need COVID vaccination. Everybody was worried about COVID vaccination. And somebody who said, oh, this baby or this mother needs a COVID vaccination. And that was done by Dr. Sampath Kumari and Dr. Shanti Gunasingh, who said you should have these COVID shots. And they helped me put in place the organization of the entire conference. And that was the COVID vaccinators. The placenta was, of course, none other than my team 2020, which gave me nourishment and cherishment. The preeclampsia started to flow in a little bit later, and there was resistance to blood flow from the entire team. Some of them said, why should you do this conference at all? You were not granted this to be done. But then the general body meeting said we would go ahead. And so there was some resistance, but even with the resistance, we started moving forward with the conference, and we went ahead and did the conference online after the GBM granting, and the permission went through the team 2020 and 2021, and the conference went on with the resistance, but there was good blood flow as well. The 3-vessel blood flow, Doppler said very good, and the umbilical vein and the umbilical arteries seen out there, what was that? And that was the technical team which are doing wonderful job here. Sapan Shah, Mr. Kishore and Mr. Prakash, they were the blood flow for the entire conference, making the conference quite live. Thanks to the tech team who are doing a wonderful job. The pre-conference events, we need 2 tetanus toxoid shots, Government of India recommendation, and that was the PG poster paper, and the intern participation is a new event. And these were the people who did the PG papers and conference, and they were like my tetanus toxoid shots, which went on for the well-being of the mother. This is the winner list, which will be displayed in the valedictory function tomorrow. The fetal well-being tests definitely have to be done just before labor, and this baby, which is going to be called as OGSSICON, out of this particular Kuti story, had to undergo the fetal well-being test to be on the safer side. The well-being tests were on the 24th, the pre-conference workshops. And of course, these workshops which happened yesterday, CTG Can Tell Goodness is one of the well-being tests done by Dr. Umaram and Dr. Jayashree Gajaraj very ably. Amniotic fluid index is very good to say that this baby is doing well. And that was done by Dr. Shanti Gunasingh and Dr. Meena Prakash. And decreased fetal movement counts, of course, no way, the counts were very good. And that was a workshop which went through by laparoscopy done by Dr. Meenakshi Sundaram and Dr. Vanitha Anban. Oh yes, who was the labor companion? And this baby, this mother had to go, the Kuti story had to come to an end, and the labor had to be delivered. And who was the labor companion at that point of time?
பாசம் வைக்க நேசம் வைக்க தோழன் உண்டு வாழ வைக்க அவனை தவிர உறவுக்காரன் யாரும் இங்கில்லே உள்ள மட்டும் நானே உசுரக்கூடத்தானே என் நண்பன் கேட்டா வாங்கிக்கென்னு சொல்லுவேன்.
Dr. Vijayalakshmi Seshadri, my able honorary secretary, was my labor companion. And of course, the baby was delivered. And who was the obstetrician who delivered the Kuti baby? And these were all the obstetricians who delivered the fantastic Kuti baby, which came out today. And that is Dr. Paul Fagati, Dr. Kipras Nicolaidis, Dr. Kurian Joseph, Dr. Rekha Kurian, and of course, blessings always from Dr. Savitri Subramaniam, and the extremely well-rendered talk by Dr. Paili. The well-born baby was, of course, jeweled. The baby was jeweled by, of course, Dr. Shanta Kumari and by the Honorable Health Minister, Ma Subramaniam. And these are the jewels and the crown which you're going to have today because of their presence, and that is our essence. The breast milk or the lactation support was given by Bharat Serum and Vaccines, Rizera Pharma, Ferring Pharmaceuticals, Stryker Medtronics, and of course, my able secretaries, Ms. Sri Priya and Ms. Meghala from the Oxy office, without whose evidence this breast milk support or the lactation support for the baby OGSSICON could not have been possible. The designer baby went across and went because of all these free paper for interns, gold medal for first prize and foreign faculty across the globe, well-designed sprouts or the capsules, which we used to call before, the youngsters who are talking about We have 6 sprouts, and sprouts mean easy to digest and of course easy to do. And that is what the sprouts mean. We have lively lectures, mighty debates, and pushy panel discussions which are happening. And the well-bloomed baby, groomed baby, well, we had 881 logins today, 353 logins in the Thai Hall yesterday, 296 logins in Say Hall yesterday, 211 free papers and posters on the 24th August. With hard feelings, Vasikara and that is what is the feeling when Oxy is there. Oxy, I do love you, and that's a feeling which I get when I finish my presidential address and my story Oxy. Thank you very much, ladies and gentlemen.
Thank you very much for that lovely scripted presidential address. This lovely weaved Kutti story of yours is a very successful one. The healthy Oxyka is not small. She is already big. And she is already successfully born and is being nurtured from this week. Very successful. Thank you very much, sir, again. Can we have the next slide, please? I now request Dr. Vijayalakshmi Gnanasekaran, Honorary Secretary of Oxy 2020, to introduce our guest of honor, Dr. S. Shantakumari, Foxy President 2021.
Thank you, Sumati. Dr. Shantakumari, Madam, definitely needs no introduction to this August gathering. Madam is President of Foxy 2122, Senior Consultant, Obs and Gynae and Laparoscopic Surgeon of Yasoda Hospitals, Hyderabad. She has served in Foxy. It reached to pages, sir. And she is an achiever of major awards and achievements. Okay, and she has organized many conferences, AICOG 2011 organizing secretary, and many more too. And I always refer to Madam as Tamilagatin Marumagal. Madam, welcome back to Tamil Nadu. It would have really been a big thing if we had an actual conference and you were here. Welcome, Madam, on this virtual platform. And over to you to give your talk as the guest of honor for today's conference. Thank you.
Thank you, Dr. Vijayalakshmi. Honorable Minister of Health, Shri Sir Subramaniam Sir. I can't see him, so maybe his video is off. Our regards from Foxy Sir for joining us today at this 37th OxyCon conference. My dear friend, Dr. Palani Appan, who has been a very close friend for many years. So, in fact, I was just fighting with him that he did not call me for a physical conference during his tenure of taking over as the Oxy president. But nevertheless, I think the pandemic has taught us many things to relive the life in a virtual way. And it's indeed a pleasure to be here to see all the senior members of Oxy here. My dear friend Vijayalakshmi, who is now the president of Oxy, Dr. Sampath, our vice president-elect, Jairani Kamraj, Meenakshi, I can see so many friends, Dr. Guna Singh, so Premlata Madam, so many people are here. So it's indeed a pleasure to see you here, Dr. Sumati. Let's hope in the near future we will get an opportunity to be in Chennai. And the Madras Society has been the pioneer in Foxy. In fact, the Foxy was born in Madras in 1950 on the 6th of January, the 6th AICOG, which was at Madras. And the first AICOG, the All Indian Congress of Obstetricians and Gynecologists, was also inaugurated only in Madras. So Madras was I think the birthplace of Foxy and the AICOG conference. And that time, if you all remember, it was the Ahmedabad, Bombay, Madras, Bengal and Punjab. These 5 societies got together and decided that they'll form a federation, the Federation of Obstetrics and Gynecological Societies of India. And now I'm very happy to say that we have grown into 262 societies with 37,000 members. And Foxy is going stronger day by day. Friends, this year I came in front of you as the 60th president of Foxy and the 20th woman president of Foxy, and with the theme Foxy for all always and Dhira stop violence against women. Foxy vision and mission is for women's health. So in my theme this year, I said, Foxy, for every mother to reduce every preventable death, to reduce the maternal mortality rate so that we reach our SDG goals. And Foxy, for every woman to stay courageous with Dhira, stop violence against women. And friends, Foxy is for all Foxians. The main mission of Foxy was created for us Foxians so that we would be able to practice with protocols and dignity. So with this theme, and we have come across this year that Foxy cares for all the women, and right from the adolescent age group to the menopausal age group. And I have to actually congratulate all of you, my dear members, seniors, juniors, and colleagues, that it's the hard work done by each and every one of you is the reason why we have been able to reduce the maternal morbidity and mortality. And I was very proud always of our states, Tamil Nadu, which was doing extremely well in reduction of maternal mortality and morbidity. In fact, it's no political intention, but I really appreciate when you had a woman chief minister to lead the state of Tamil Nadu, maternal mortality went down very much. And that showed the commitment of women to women's health. And I'm very happy that the subsequent governments which have come in, everyone has taken it on themselves to see that the maternal morbidity and mortality reduces. But unfortunately, this year, what we have been seeing because of the COVID pandemic, even in states like Kerala, which was supposed to be the role model with low maternal mortality, the government has noticed that there has been an increase in the maternal mortality, probably because of this COVID, which is even affecting the mother's life. So let's hope that together we'll be able to get back on track and reduce the maternal morbidity and mortality. And I'm sure with the support of the government, the gynecologists, the healthcare workers, everyone together, we can definitely achieve our goal of reducing the maternal morbidity and mortality. And I wish the new team who has taken over, Dr. Vijayalakshmi Sheshadri and team, all the best for continuing good work. And let's hope that very soon you will have a physical conference where I would definitely love to come. And that will be great. I still remember when Palani asked me to come for this conference, I said, if you're doing physical, I'll come and give. If it is not physical, I will not come. But then we had no choice. It's a virtual presence. Nevertheless, thank you very much for having me. And thank you.
Sure, we will have you, Shanta, here. Thank you so much.
Thank you, Dr.
Shanta. That was fantastic. And thank you very much for coming and gracing the occasion amongst your busy schedule. I'm sure you have to go and inaugurate another conference.
I have to give a lecture in the Bangalore Society. That's
Thank you very much. Thank you very much. Hope to see you soon. And while the minister is just joining, I've called him again and again. He's just held up and he's just come in and his team is ready.
Yeah, I'll join.
Shanta, please accept this appreciation award, OGSSICON 2020 International Online Conference, 27, 28, 29th August 2021 Appreciation Award presented to Dr. S. Shantakumari, President Foxy, for being the guest of honor at the conference inauguration on 28th August 2021. This is not virtual. This is the real plaque which is lying down here, and I will see to that this is handed over to you somehow or the other. And I'm sure I will have the privilege of meeting you in person and giving it to you. If not, let me see how I can hand it over to you. It is ready and lying down next to me, and I'm extremely happy to give this award to you. And thank you very much.
Thank you, Palani, but I'm not taking it virtually. I'm definitely coming to Chennai and then I'll take it.
Definitely.
I will in an event in Chennai.
Okay. Thank you very much, Shanta, madam. Thank you so much. Thank you.
Thank you very much, ma'am.
Bye. Please convey my sorry that I can't wait for our minister because already Bangalore Society is waiting for me to give the lecture. Otherwise, I would have loved to listen to sir. Okay. Thank you.
No problem, madam. Thank you. Thank you very much. Bye, ma'am. Bye.
Thank you for your time, ma'am. Fine, sir. Shall we move on?
We'll have to wait, Sumati.
Okay.
That should be the talk by the chief guest, isn't it? Introducing him and
yeah.
Whatever are those things, all those three things have to be in his presence.
Yeah.
So we'll wait for a few.
Sumati, the health minister is just logging in, Sumati. Just give him a minute just a minute and we will be having him because he's in the car. He's going to log in from the car. So fine. So let him, that's the best thing because he cannot log out. So he will be logged in and we are quite happy about it.
After he logs in, then will be the CM's letter. Once
Correct.
he logs in, we will go ahead with that.
No, he's just logging in. Give us a minute and so he will be there.
In the meantime, some announcements to be made. Anything is there regarding?
Yes, Vijay, you can go ahead with the announcements, the prizes, all that can be done out there. He's just...
Yeah, we wait. More than the prizes, at the end of this inauguration program, we have a well-formulated entertainment program which is supposed to have taken place during the lunchtime. And thanks to Meenakshi for really putting in an effort, motivating every member of OGSI, not only our executive members, but others also. She's been behind everybody's back, asking everyone, give something, so that we have a good entertainment program. And sorry, Meenakshi, because we had delayed, we couldn't, see or that visual treat could not be had during the lunchtime, that we are waiting for it during the snack time. Okay, before our, just immediately after the inauguration ends, we'll start off with the entertainment.
Sure.
Kishore, can you put in that video now once more? Just to entertain people.
Yes.
Yeah. And Meenakshi, don't worry. Meenakshi is worried people may not be there to watch whatever efforts all of us have put in and others have put in, but no, everyone will wait for it.
Yeah, we may have to post it again in the groups that the entertainment is still waiting today.
Okay.
We may have to post because the previous posts said it is 12:30 to 1. We may have to repost it.
Okay. Can somebody do that? Meena, can you take that up and post everything in all the groups?
Awesome.
Thank you. That was awesome, and we'll wait for it. And the minister is logging in, so let us just start. Yeah, here, sir is.
I think sir has joined.
Yes, sir has joined, and we will start. Good evening, sir. Vanakkam, sir. We will start. Sumati, you can go ahead.
Yes.
The health minister is here, and we can start. Sumati, over to you.
Yes, sir. Vanakkam, sir. இன்று எங்களோடு இணைந்திருப்பதில் நாங்கள் பெருமை கொள்கிறோம், sir. Can we have the slide, please? மாண்புமிகு தமிழக முதலமைச்சர் திரு M.K. ஸ்டாலின் அவர்கள் எங்களது ஆக்சி குடும்பத்திற்கும் தலைவர்களுக்கும் பிரத்யேகமாக வாழ்த்தி அனுப்பிய மடலை உங்கள் முன் படிப்பதில் பெருமை அடைகிறேன். Next slide, please. Just a minute. The letter from the Chief Minister of Tamil Nadu, Mr. M.K. Stalin, addressed to Oxy, says, as a wishing message, thus, I am happy to know that the Oxy is organizing its 37th annual conference from August 27th till 29th August 2021.
சொல்லுங்க சார். தெரியும் பார்த்துட்டேன். அதனால தான் இத போட்டுருக்கேன். சீஃப் மினிஸ்டரோட விஷயம் படிச்சோம்னா சாரா தான் பேச சொல்ல போறோம்.
I appreciate the noble, relevant and unique efforts of all the obstetricians and gynecologists. I extend my greetings and felicitations to Dr. N. Palaniyappan, President of OXY 2020, Dr. Vijayalakshmi Gnanasekar, Honorary Secretary of OGSSI 2020, and everyone associated with OGSSI's International Conference. I am confident that the deliberations during the conference would be beneficial and the event would be successful in achieving objectives. My best wishes for the entire endeavor. With regards, Mr. M.K. Stalin. மாண்புமிகு தமிழக முதலமைச்சர் திரு M.K. ஸ்டாலின் அவர்களுக்கு எங்கள் குழுமத்தின் நன்றிகளும் வணக்கங்களும். Can we move ahead with the next slide, please? May I request our beloved President 2020 to introduce our chief guest, Mr. Ma Subramanian, of Department of Health and Family Welfare, Government of Tamil Nadu.
Slide, please.
Slide, please.
Let me have the proud privilege of introducing Ma Subramaniam, BA LLB, Member of Legislative Assembly, Saidapet constituency. He had had various posts, 1996 to 2006, member of the 135th Ward Council, Corporation of Chennai, 2006 to 2011, Mayor of Chennai City, 2016 to 2021, MLA, 2021 MLA and 2021 Honorable Minister of Health and Family Welfare, Tamil Nadu. He has had various awards, the CRS CRISIL Award, Exemplary Services as Mayor, National Award, Empowerment of the Disabled, World Leadership Award, Limca Book of Award. Slide, please. Slide, Kishore. Thirumas has excelled in his social work, 1 lakh green sapling scheme, Kalinger Computer Academy, marathon records being 129 marathons recognized by India Book of Records, Asia Book of Records, and the World Record Union, International Golden Disc Award. Sir, we are extremely happy and honored to have you with us amongst your busy schedule. And now we would like to have you give your address and we are all waiting for your address. Over to you, Minister, sir.
வணக்கம். மகப்பேறு மருத்துவர்களின் 37ஆம் ஆண்டு நிறைவு விழாவில் நானும் கலந்து கொள்வதற்கான இந்த வாய்ப்பு என்பது மிகப்பெரிய மகிழ்ச்சிக்குரிய வாய்ப்பு. எனக்கு கிடைத்திருக்கிற வாய்ப்புகளிலேயே மிக சிறந்த அரும்பெரும் வாய்ப்புகளில் இதுவும் ஒன்று என்று நான் கருதுகிறேன். காரணம், மகப்பேறு மருத்துவர்களின் மருத்துவ சேவை என்பது இன்றைக்கு எந்த அளவுக்கானது என்பதை அனைவருமே நன்றாக அறிவார்கள். மகப்பேறு மருத்துவர்களின் இந்த கடந்த 1.5 ஆண்டு காலமான பேரிடர் காலத்திலும் இவரதும் சேவை என்பது பாராட்டுக்குரியது, போற்றுதலுக்குரியது. ஆக மகப்பேறு மருத்துவர்கள் தமிழக அரசை பொறுத்தவரை அரசு மருத்துவமனைகளில் பணியாற்றி கொண்டிருக்கிற மருத்துவர்களின் தேவையை அவர்களின் சேவை மனப்பான்மை கொண்டு எந்த அளவுக்கு செய்ய இயலுமோ அதை கடந்த 4 மாதங்களில் முடிந்த அளவு செய்து கொண்டிருக்கிறோம். மருத்துவர்களுக்கான இந்த இடமாறுதல் போன்ற பல்வேறு விஷயங்கள் டிரான்ஸ்பரண்ட் டிரான்ஸ்ஃபர்ஸ் என்கின்ற வகையில் மருத்துவர்கள் மகிழ்ச்சி அடைகிற வகையில் அந்த பணிகளை செய்து கொண்டிருக்கிறோம். அதோடு மட்டுமல்லாமல் இந்த மருத்துவத்துறையின் மகப்பேறு கட்டமைப்பை பெரிய அளவில் உயர்த்துவதற்கான எல்லா மாண்புமிகு தமிழக முதல்வர் அவர்களை கொண்டே திருவாரூரில் உள்ள ஒரு தீவிர மகப்பேறு மருத்துவ சிகிச்சை மையம் ஒன்றினை திறந்து வைத்திருக்கிறோம். இப்போது தர்மபுரி போன்ற பல்வேறு இடங்களில் புதிய தீவிர சிகிச்சை மகப்பேறு மையங்கள் கட்டும் பணிகளும் நடைபெற்றுக் கொண்டிருக்கிறது. அதே போல் வருகிற 2ஆம் தேதி இந்த துறைக்கான மானிய கோரிக்கை நடைபெறவிருக்கிறது. அதிலேயும் கூட கடந்த 1 வார காலத்திற்கும் மேலாக இந்த துறைக்கு என்னென்ன புதிய அறிவிப்புகள், அதுவும் குறிப்பாகவும் சிறப்பாகவும் இந்த மருத்துவத்துறையை மேம்படுத்துவதற்கு குடும்ப நலன் சார்ந்த விஷயங்களை கூடுதலாக கொண்டு வருவதற்கான அந்த முயற்சிகளை ஏராளமானவைகளை எடுத்துக்கொண்டிருக்கிறோம். அந்த வகையில் 2ஆம் தேதி மாலை நிச்சயம் இந்த மருத்துவத்துறைக்கு ஒரு மகத்தான ஒரு சிறப்புமிக்க ஒரு நிகழ்வுகள், புதிய அறிவிப்புகள் பட்ஜெட்டில் இடம்பெறவிருக்கிறது. அதோடு மட்டுமல்லாமல் தமிழகத்தை பொறுத்தவரை மக்களை தேடி மருத்துவம் என்கின்ற ஒரு மகத்தான திட்டத்தை செயல்படுத்தி கொண்டிருக்கிறோம். அந்த திட்டம் இன்றைக்கு ஒரு பெரிய அளவில் வரவேற்பையும் பெற்றிருக்கிறது. ஏறத்தாழ 2.5 லட்சம் பேர் கடந்த 18-20 நாட்களில் பலன் பெற்றிருக்கிறார்கள். கடந்த 1.5 ஆண்டு காலமாக தமிழகத்தைச் சேர்ந்த நீரிழிவு நோயாளர்கள், அதேபோல் உயர் ரத்த அழுத்த நோய் உள்ளவர்கள் எல்லாம் மருத்துவமனைகளுக்கு வந்து மருந்து மாத்திரைகளை பெற்று செல்ல இயலாத நிலையில் அவர்களுக்கு பெரிய அளவில் அந்த உயர் ரத்த அழுத்த நோயும் நீரிழிவு நோயும் கட்டுப்பாட்டில் இல்லாமல் அவதியுற்றுக் கொண்டிருக்கின்றனர். அவர்களுக்கு இந்த கொரோனா பாதிப்பு ஏற்படுகிற போது அவர்களுக்கு ஒரு பெரிய அளவில் அது பாதிப்பும் ஏற்படுகிறது. எனவே இதை கருத்தில் கொண்டு மருத்துவமனைகளுக்கு இது போன்ற பொது முடக்க காலங்களில் வர இயலாத சூழலில் இருப்பதால் கிராமங்களிலே, குறிப்பாக மலை கிராமங்களிலே இருக்கிற மக்களுக்கும் வீடுகளை தேடி சென்று மருந்துகள் கொடுக்கிற, மருத்துவம் பார்க்கிற ஒரு நல்ல திட்டத்தை தமிழகத்தில் தொடங்கி இருக்கிறோம். ஆகஸ்ட் மாதம் 5ஆம் தேதி மாண்புமிகு தமிழக முதல்வர் அவர்களின் மூலம் கிருஷ்ணகிரி மாவட்டத்தில் உள்ள சாமனப்பள்ளி என்கின்ற இடத்தில் தொடங்கப்பட்டது. இதில் வீடுகளுக்கு நேரடியாக சென்று நீரிழிவு நோய்க்கான மாத்திரைகள் தருவது, உயர் ரத்த அழுத்த நோய்களுக்கான மாத்திரைகளை தருவது, பாலியேட்டிவ் சிகிச்சை என்கின்ற வகையில் நீண்ட நாட்களுக்கான சிகிச்சை பெற்றுக் கொண்டிருப்பவர்களுக்கு அந்த வலி நிவாரண மாத்திரைகளை தருவது, இயன்முறை சிகிச்சை பிசியோதெரப்பி தேவைப்படுபவர்களுக்கு அதை பிசியோதெரபிஸ்ட் நேரடியாகவே வீடுகளுக்கே தேடி சென்று செய்வது, டயாலிசிஸ் தேவைப்படுபவர்களுக்கு டயாலிசிஸ் பைகள் இலவசமாக வழங்குவது போன்ற பல்வேறு பணிகளை இந்த மக்களை தேடி போய் செய்து கொண்டிருக்கிறோம். தினந்தோறும் ஒரு 15,000 பேருக்கு புதியதாக இந்த மருந்து மாத்திரைகள் தருவது, மருத்துவம் பார்ப்பது என்கின்ற இந்த பணியை செய்து கொண்டிருக்கிறோம். தமிழகத்தை பொறுத்தவரை இன்னும் ஒரு 4-5 மாத காலங்களில் 1 கோடி பேருக்கு இந்த மக்களை தேடி மருத்துவத்தின் மூலம் மருத்துவ சேவை செய்யப்படவிருக்கிறது. எனவே இது ஒரு பெரிய அளவிலான மருத்துவ புரட்சியாகவே தமிழகத்தில் இருக்கும். இப்பொழுதே பெரிய அளவில் அதற்கான இந்து, தினத்தந்தி, தினமணி போன்ற தினசரிகள் எல்லாம் தலையங்கங்களே எழுதி பாராட்டுக்களை தெரிவித்திருக்கிறார்கள். இது ஒரு மகத்தான சேவை திட்டம். இந்த சேவை திட்டங்கள்லாம் கூட தமிழகத்தில் தொடர இந்த துறையில் இருக்கிற மருத்துவர்கள், செவிலியர்கள், சுகாதார ஆய்வாளர்கள், மருத்துவம் சார்ந்த களப்பணியாளர்களின் அந்த பணி என்பது அளப்பரியது. அந்த வகையில் இந்த மகப்பேறு மருத்துவர்களின் பாராட்டுதலுக்குரிய பணியும் இதிலே இணைந்திருக்கிறது. எல்லா இடங்களிலும் இந்த மருத்துவமனைகளை பொறுத்தவரை பெரிய அளவில் இன்றைக்கு சிறந்து விளங்கி கொண்டிருக்கிறது. தமிழகத்தை பொறுத்தவரை இந்த மகப்பேறு மருத்துவர்களுக்கு ஒரு பெரிய அளவில் தமிழக மக்கள் அந்த மகளிர் மருத்துவம் பார்க்க வருகிற மகளிருக்கு யோகா பயிற்சிகள் போன்ற தருகிற அந்த திட்டங்களை ஏற்கனவே செயல்படுத்தி கொண்டிருக்கிறோம். இப்பொழுது நிதிநிலை அறிக்கையிலையும் அதை அறிமுகப்படுத்தவிருக்கிறோம். இப்ப பல்வேறு விஷயங்கள் வருகிற 2ஆம் தேதி புதிதாக அறிமுகப்படுத்தப்படவிருக்கிறது. தமிழகத்தின் மகப்பேறு மருத்துவர்கள் மற்றும் உலக அளவில் இந்த ஒரு மாநாடு 37வது இந்த ஆண்டு மாநாட்டில் நானும் கலந்து கொள்வதற்கான இந்த வாய்ப்பினை அளித்தவர்களுக்கு என்னுடைய மகிழ்ச்சி நிறைந்த நன்றியினை தெரிவித்துக் கொள்கின்றேன். உங்கள் சேவை மகத்தானது. இந்த மருத்துவத்துறையில் நீங்கள் ஆற்றிக் கொண்டிருக்கிற பணிகள் என்றைக்கும் மறக்க இயலாத ஒன்று. ஒரு 50-60 வருடங்களுக்கு முன்னால் கூட எந்த மருத்துவரிடத்தில் அந்த மகப்பேறு நடைபெற்றதோ அவர் எவ்வளவு பெரிய ஆளாக இருந்தாலும் அவரை பார்க்கிற போது இவர்தான் எனக்கு பிரசவம் பார்த்தவர் என்கின்ற அந்த விஷயத்தை சொல்லும் போது அதில் ஒரு பெருமைப்படத்தக்க ஒரு நிகழ்வு, ஒரு வெற்றி என்பது இருக்கும். எப்படி ஆசிரியர்களை பார்த்தால் இவர்தான் எனக்கு பாடம் கற்றுத் தந்தவர் என்று சொல்வார்களோ அதுபோல் இவர்தான் என்னை பிரசவம் பார்த்து நான் பிறக்க காரணமானவர் என்று மருத்துவர்களை பார்த்து சொல்லுகிற போது இந்த சுகம் வேறு எந்த மருத்துவர்களுக்கும் கிடைக்காத ஒன்று. அந்த வகையிலான இந்த மருத்துவர்களை மனதார பாராட்டுகிறேன். நன்றி.
நன்றி ஐயா. சார், ஒரு கவிதை உங்களை பத்தி எழுதியிருக்கோம். அதை படிக்கிறதுக்கும் உங்களுக்கு பிளாக் வழங்குறதுக்கும் ஒரு நிமிஷம் அவகாசம் கொடுங்க. சுமதி, சுமதி ஸ்லைட், நெக்ஸ்ட் ஸ்லைட். நோய் நாடி நோய் முதல் நாடி ஐயன் வள்ளுவர். நாடாத நோய் நம்மை நாடி வந்தது, முதல் பட்டியெல்லாம் கவர்ந்து சென்றது. கருணை இல்லா அந்நோய்க்கு கொரோனா என்ற பெயரிட்டனர். முதல் அலை முடிந்து மூச்சு விடும் முன்னே சுனாமியாய் வந்தது 2ஆம் அலை. அந்நேரம்தான் பதவியேற்றார் புதிய முதல்வர், தமிழ் அன்னையின் மூத்த புதல்வர் கலைஞர். சுனாமியாய் வந்த அலையை சுருட்டி அடக்க அவர் சுப்பிரமணியை தேர்ந்தெடுத்தார். ஆம், நம் முன்னாள் மேயர், இந்நாள் மருத்துவ அமைச்சர். அவரின் பெயர் சுருக்கம் ஆனால் அவர் மனதில் இல்லை, என்றும் இல்லை சுருக்கமும் மாசும். அவர் பெயர் சுருக்கம்தான் மாசு, ஆனால் அவர் மனதில் என்றும் இல்லை சுருக்கமும் மாசும். மாநகர தந்தையாய் அவர் ஆற்றிய மாபெரும் பணிகள் மனதை விட்டு அகலாது. முன்னேற்றத்தை நோக்கி பிறந்தன பல பாலங்கள். ஸ்லைட் பிளீஸ். மாறி தோன்றின பசுமை கோலங்கள். கூகிளில் பார்வை பார்த்தாலும் அறிய இயலா தெருக்களுக்கு பெயர் பலகை கொண்டாட்டம். ஜிபிஎஸ்க்கு வேலையில்லா திண்டாட்டம். அறிய இயலா தெருக்களுக்கு பெயர் பலகை கொண்டாட்டம். ஜிபிஎஸ்க்கு கொடுத்தார் வேலையில்லா திண்டாட்டம். மாநகர பள்ளிகளுக்கு சென்னை பள்ளிகள் என்று பெயர் மாற்றம். தாழ்வு மனப்பான்மை நீங்கி மாணவர் பெற்றனர் மன ஏற்றம். மாதரை மாதவிடாய் படுத்தும் பாடு. மாணவிகள் கல்வி தடுக்கா வண்ணம் இலவசமாய் நாப்கின் தர செய்தார் ஏற்பாடு. மாதரை மாதா மாதம் மாதவிடாய் படுத்தும் பாடு. மாணவிகளின் கல்வி தடுக்கா வண்ணம் இலவசமாய் நாப்கின் தர செய்தார் ஏற்பாடு. அமைச்சராய் பதவியேற்று நாட்கள் சிலதே, அதற்குள் செய்த சாதனை பலவே. தடுப்பூசியா ஓடு ஓடு என்ற கூட்டம் இன்று தடுப்பூசியா போடு போடு என்ற வண்ணம். தடுப்பூசி தயக்கம் நீக்கி விடுதலை நோக்கி இட்டு செல்கிறார் நம் மாமனிதர் மா சுப்பிரமணியன். நலமாய் நீடூடி வாழ வாழ்த்துவோம், வணங்குகிறோம் பணிகிறோம். பாவாக்கம் மருத்துவர் ஜான் பென்னோ, நாவாக்கம் டாக்டர் பழனியப்பன். வணங்குகிறோம் ஐயா. தேங்க்யூ வெரி மச் சார். அண்ட் ஸ்லைட் பிளீஸ். OGSSICON 2020 International Online Conference, 27, 28, 29th August 2021. Appreciation Award presented to Thiru Ma Subramanian, Honorable Minister of Health and Family Welfare, Government of Tamil Nadu, for being the chief guest at the conference inauguration on 28th August 2021. Thank you very much, sir. Mikka nandri. Thank you very much.
பங்காளர் மாண்புமிகு அமைச்சர் மா சுப்பிரமணியன் அவர்களுக்கு எங்களின் மனம் நிறைந்த நன்றிகளும் வணக்கங்களும். அவர் சொல்வதை போலவே மகிழ்ச்சி நிறைந்த நன்றிகள். உங்களுடைய நேரத்திற்கு எங்களுக்கு ஒதுக்கியதற்கு மிக்க நன்றி சார். எங்களுடன் உங்களுடைய நேரத்தையும் உங்களுடைய வார்த்தைகளையும் பகிர்ந்து கொண்டதற்கு மிக்க நன்றி. நாங்களும் உங்களிடமிருந்து எங்களை பற்றி அறிந்து கொண்டதில் எங்களுக்கு மிக்க மகிழ்ச்சி. நன்றி.
சார், உங்க மைக் மியூட்ல இருக்கு, கொஞ்சம் அன்மியூட் பண்ணாதான் நீங்க பேசுறது கேட்கும்.
அமைச்சர் அவர்களுக்கு அந்த மைக் மியூட்ல இருக்கு. டாக்டர் பழனியப்பன்
இருங்க, அவர் அன்மியூட் பண்ணிட்டு ஒரு நிமிஷம்.
I think it's logged out.
I think he's logged out. Yeah. Because he said thank you, I think he logged out. Yeah. So you can go on with the proceedings.
Okay, fine. Can we have the next slide, please? Okay. I now invite Dr. Kundavi Shankar for rendering the vote of thanks. She is a senior consultant obstetrician and gynecologist. Is a specialist in reproductive medicine and laparoscopic surgery. She is a lead IVF consultant, IRM MMM. She is a HOD there. She was our honorary treasurer, OGSSI 2020, a very busy person. Member of OGSSI, IMA, ISAR and TAPIZAR. She is the honorary treasurer of TAPIZAR, and she conducts a lot of training and fellowship programs in the IRM, and she examiner for FNB and MGR University fellowship programs. May we have Dr. Kundavi Shankar render the vote of thanks, please.
Thank you, Dr. Sumati. Good evening, ladies and gentlemen. I feel honored and privileged to get the opportunity to propose this vote of thanks on this special day. This is the proudest day in the history of our OGSSI society, as we are hosting the biggest international e-conclave in Chennai with more than 800 plus delegates from all over India. My first and foremost thanks goes to the Almighty God who made this day possible. On behalf of OGSSI, I convey my regards and hearty thanks to our Honorable Chief Minister, Thiru M.K. Stalin, for giving us the conference message. And my thanks to our chief guest, Thiru Ma Subramaniam, our Honorable Minister of Health and Family Welfare, Tamil Nadu, in spite of his busy schedule, sharing the insights and the wisdom for all of us. We will definitely follow and cultivate your advice, sir. Your thoughts have invited us our minds and shown us a new path. And Dr. Shantakumari, the Foxy President, guest of honor, having accepted to participate in this International Conclave in spite of the busy schedule and making this conference a grand success. Thank you, ma'am, once again. I would also like to thank the international faculty and the national faculty who have come in spite of the busy schedule and gave us their opinions. And the organizing team, the judges, without them, I think this event was not possible. Thank you very much once again. And I also like to thank our major sponsors, Sun Pharma. Without them, we wouldn't have this program successful. And I thank the Medtronic and the Stryker for sponsoring the endoscopic workshop, and the BSV for the Rhesus workshop, and the Severa for posters and the paper presentations. And I once again thank them for their academic support. The digital partners for helping us to run this event very smoothly. In the end, I would like to thank the respected delegates and participating various colleges, the chairpersons, speakers, and the hall coordinators. Thank you once again for making this event successful and for adorning the occasion and sharing their expert opinions. Special thanks to my beloved Meenakshi for organizing the entertainment program. This type of event cannot happen overnight. The wheels start moving about few months back, and it requires planning and bird's eye for details. We have been fortunate, supported by a team of very active and dedicated core members, headed by the vibrant President OGSI 2020, Dr. Palniyappan, supported by the dynamic secretary, Viti Nanashekaran, and the opportunity given by Vijayalakshmi Sheshadri, the present President OGSI, to conduct this e-conference. I also want to thank the people who worked behind the scene to execute this event, Mrs. Priya, the event manager, and Mehla, our beloved secretary. Ladies and gentlemen, once again, I would like to say that we are all the most grateful to all the speakers on this forum. We thank you for being with us this evening. It's a great pleasure. Thank you very much. Nandri Vanakkam.
Mikka Nandri, madam. May we all now rise for the national anthem. அனைவருக்கும் மிக்க நன்றிகள். இந்த விழா இனிமையாக தொடங்கி மிகவும் இனிமையாக முடிவுற்றது. திரு பழனியப்பன்.
Yes, Sumati, thank you very much for coordinating this program fantastically well, though we had some technical glitches with the minister joining in, but finally he could do it with his phone on the car, and that was quite nice because actually he can't get out of the car, so it was very nice that it was locked in the car, and so we were able to get that time out of him, and he was just coming from the budget, and so he couldn't do that, and very nice of him to have logged in amidst that busy schedule, and I thank all of you for having logged in and supported, and now we'll have the photograph fast. And we will move on for the Meenakshi's cultural event because that's the most awaited event, one. And two, we'll have to log out of this and come back again for the trial run for tomorrow. And let me mean business at that point of time. So we need to be very fast, Meenakshi. And so we'll take the photograph. Meenakshi, please go ahead and take the photo. Vijay, whoever's taking the photo, I'm sure most of us are here. Geeta Lakshmi, please switch on your video. Geeta Lakshmi, yeah. So please go on and take the photo, and we have to do the trial run after that.
Geeta has to switch on a video. Geeta,
please switch on your video. The faculty members who are there, please switch on your video. We will take a photo, quick photo, and then we'll move on to the cultural event because that's very much awaited by most of us. And Meenakshi is waiting to display it as well because of the hard work she's put in already.
Somebody take a photo, please.
She's taking. Meena's taking.
Geeta is switched on. Geeta is switched on.
Jayashree ma'am, Shanti ma'am.
Shanti Gunasingh ma'am was there. I saw her. Yeah, she's there.
Shanti Rani ma'am, Anjalakshi ma'am.
Okay, man.
Anjalakshi ma'am.
Shanti Rani ma'am.
Geeta.
Okay,
Ina, one second.
Let's all be aware that we are live and there are enough people watching on the other link. So it's fine. Go ahead and whatever is possible, we'll do. Yeah.
Whoever wants to join, please join. Just a few seconds. 1 second more. Ready?
Say cheese.
Cheese. Done. Over.
Thank you, Meena. Over to you, Meena. Can I have the slide of Meena? I'm sure Meena has been introduced enough and well. And apart from the laparoscope, Dr. Meenakshi's passion is to not only to dance, but to make others dance. It's easy to be the king, but to be a kingmaker is not very easy. And Meenakshi is one such person. She will make all of us dance, and that's what she's here for. And Meena, over to you for your cultural event, and let's be fast.
Thank you. Thank you very much.
Meena, by the time you want to say something, or you're directly starting?
Okay, I'll say something.
Say.
Okay. So welcome to the relaxed, wonderful evening. I think my screen is already shared. Okay, fine. So welcome to the relaxed, wonderful evening to watch this various talents Oxy really has. And I appreciate the efforts that has been taken by each and every one of you who have contributed to this program. It is really a challenge to, get people together, especially virtually, for such things. Because we always used to enjoy this getting together, getting trained with a choreographer, dancing together, learning from each other. But when it is virtual, you just have to do it by yourself. And, it's funny at home that you have to ask your daughter or your husband to shoot this for you. But amidst all this, I really, really appreciate the enthusiasm, the effort that is being taken by all the Oxy members and especially the Oxy executive team for putting up this program. So please stay. It's just half an hour for today. You will really enjoy. Thank you. And I'm just sharing my slides. So we start with a very, very beautiful voice. Thank you, madam.
Hi, friends. Good evening. Nice to meet you all virtually. Hey, Govinda, hey, Ananda, Nanda, Gopala. Mohana Muralidhara Shyama Gopala. Hey Govinda, hey Ananda Nanda Gopala. Mohana Muralidhara Shyama Gopala. Sundara Giridhari Hare Natavara Lala. Sundara Giridhari Hare Natavara Lala. Madhava Keshava Madana Gopala. Hey Madhava Keshava Madana Gopala.
Wow, wow, wow. Thank you so much, madam. That was a wonderful unplugged rendition of a very beautiful song. Thank you, Jayashree ma'am. She sent this to me within seconds of requesting her to send her singing. Thank you, ma'am. The next is a dance we have put together. This is celebrating our 75th independence year and also celebrating women's independence from health issues. Enjoy.
There's a bland with black band. Your screen sharing. Stop share. Can you move that and put it on top? Will you be able to do that? Because that is hiding the video. Yeah. Put it on top. Yes.
Okay. So this was a very wonderful dance, so gracefully done by each one of you. Though we were at different locations, you all brought this spirit together. And thank you so much, each one of you. The next we are going to see a very nice instrumental piece. Ma'am, I never knew you had such a wonderful talent. Wow. That's an awesome rendition of an instrumental by the grand piano by Hepzibah Madam of Chinna Chinna Asai. Lovely, Madam. This was such a wonderful rendition. The next we have is a very interesting group song. I should first say that I thank all the people who have joined this song. I know everybody is new to Smule and doing a group collab like this, but they all followed the instructions so sincerely and made an effort to join this song. I'm so happy with this output. Everyone can now enjoy. So you not only see the wonderful obstetricians and gynecologists, you also see the enthusiastic people who can sing and dance so well. Thank you so much. The next is a dance performance by one of our Roxy members, Dr. Mohana Pramila.
Actually, sorry to interrupt. It is 6 o'clock. You need to choose what you need to put today because we'll have to open the dry run. There are people who are asking already for the dry run. So maybe we can take another 5-10 minutes and then we'll have to open the link for dry run for tomorrow's program. So you have to be choosy to put whatever you want. Though I want to see all of them because I have not seen any of them. So you have to be choosy and do that.
Sure. I'll just play the next dance and maybe we can keep the rest for tomorrow.
No, you can put one more also. We can run 5-10 minutes late. That's fine. Yeah.
Okay. Are we stopping with this or can we do one more dance?
You can go one more dance, Meenakshi, and then we'll close the main link and we'll have only this faculty link for people to come in and log in for the trial run. Is that okay?
So that for tomorrow, yes.
Now the main link is open, so everybody will be watching this. After the first one more dance, we will close the link and we will have only the faculty for the trial run. Yeah.
Oh गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि ஆசை தரும் பார்வையில் எல்லாம் ஆயிரம் எண்ணம் வரும் 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 ஆசை தரும் பார்வையில் எல்லாம் ஆயிரம் எண்ணம் வரும் 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 ஆடலுடன் பாடலை கேட்டு ரசிப்பதிலேதான் சுகம் 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 ஆசை தரும் பார்வையில் எல்லாம் ஆயிரம் எண்ணம் வரும் வரும் வரும்
கட்டு கோடி மேளம் கொட்டு இந்த ராசாவின் நெஞ்ச தொட்டு ராசாவே கந்தல் நட்டு புது ரோசா பூ மாலை கட்டு அது ராசாத்தி தோளில் விட்டு தினம் ராவெல்லாம் காலம் கட்டு கட்டுக்காவல் இது ஒத்துக்காது என கட்டி போட ஒரு சூரன் ஏது ஜாங்கு தக்கு சரக்கு தக்கு ஜாங்கு தக்கு சாம் 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 அடி ரக்கம்மா கையை தட்டு புது ராகத்தில் மெட்டுக்கட்டு ராசாவே பந்தல் நட்டு புது ரோசா பூ மாலை கட்டு
செவத்த மச்சான் செவத்த மச்சான் ஊரைக்குள்ள உங்களை ஏசுறாங்க தினம் ஒன்ன ரெண்டா சொல்லி பேசுறாங்க நம்ம ஊருக்குள்ள உங்களை ஏசுறாங்க ஒன்ன ரெண்டா சொல்லி பேசுறாங்க
சின்ன புள்ள
என்ன மச்சான் சொல்லு மச்சான் சொல்லு மச்சான்
யாரு யாரு என்ன பேசுனாங்க அடி என்னவெல்லாம் சொல்லி ஏசுனாங்க யாரு யாரு என்ன பேசுனாங்க அடி என்னவெல்லாம் சொல்லி ஏசுனாங்க
Wow, that was an amazing performance by everyone. Thank you each and everyone once again for putting up this show together. I know it was quite a challenging effort by all of you. Thank you so much. And we would probably see some of this again tomorrow in the entertainment program during lunch. Thank you so much, sir, for giving me this opportunity.
Meena, do we have something more new from today, or it's the same dance which is going to come tomorrow?
We have a couple of new ones.
So say that to the audience. And so audience, thank you for staying with us. And Dr. Paul Fogatti has already logged in for the trial run. And audience, thank you very much for having logged in today. And see you tomorrow morning at 8:55. We would start at 9 sharp. And thank you very much for being logged in so late in the evening. We've had almost 887 logins today, only through the web, but we don't know whether they've been watching through some other device. And so thanks to all of you who've been logged in, and thank you very much. And thank you for the wonderful effort. It's not very easy to make so many of us dance, and you've made us dance, and to collate them, edit them, and put in this absolutely meticulous job. Thank you very much.
One thing, she is so patient, waiting for everyone to join in this. That is really, really great.
Thank you very much. And see you all tomorrow.
Thank you, Meenakshi. Thank you very, very much. Bye-bye.
Kishore, the tech team, can we close the recording and close the delegate link, and we will start the...
Parni sir.
Yeah.
We have to continue here, Abhidana.
Same link. Yeah, Dr. Paul Fogatti has already logged in. Yeah.
Okay.
Lakshmi Seshadri.